Good afternoon, everyone, and maybe good morning to those in the West and good evening to those in the East. Thank you very much for joining us for this second day of the INASL midterm single theme meeting on hepatocellular carcinoma. We've had a wonderful day yesterday. I think we had 1,300 registrations, 700 logins, and I thank the audience and the delegates for their overwhelming response. And I think the questions and the discussions which we had were really wonderful, and we look forward to the similar, kind of discussions and the talks today. So to start with I think before we go on to the first session, those of you who were not with us or didn't join us yesterday, briefly telling you about the format of the meeting. The format is that we have all the sessions. We have 2 to 5 speakers in each session. Each session would be chaired by 2 chairpersons, and we have 4 to 5 panelists in each session. So the chairpersons would be inviting the speakers. Speakers would be giving talk one by one. And once all the talks are over, chairpersons then would be inviting the panelists of the session to do a discussion for around 15 minutes or so, kind of panel discussion, or the panelists can ask their questions or comments as the time permits. So to start the ball rolling, I think we have the first very interesting session, which is on staging and the treatment decision. Things are evolving every day, and the BCLC has come out with the new kind of algorithm for staging, and we have a speaker from BCLC. So introduce to you with the speakers, I would like to invite the chairpersons for this session. And we have with us to chair this session, Dr. Virendra Singh, who's professor and head Department of Hepatology at PGI Chandigarh here. And I will request him to invite the first speaker of the session. Dr. Gaurdas Chaudhary has not been able to join us as the second chairperson. He's stuck somewhere. So I would be there with Dr. Virendra Singh, and Dr. Rao would be there with us to chair this first session. Dr. Virendra Singh, please, you can go ahead and invite the first speaker.
Thank you, Dr. Ajay, for organizing the wonderful meeting. And now I will, without wasting time, I'll invite Dr. Sunil Taneja. He's associate professor in our department, PGI Chandigarh, and he'll be speaking on the staging in patients with the HCC and overview. Dr. Sunil, please.
Very good afternoon to all, and let me just share my slides. So are my slides visible?
Yeah.
Am I audible, sir?
Yeah.
Thank you very much, sir. And my job here is to discuss the different staging systems for HCC, and I am going to give an overview of the staging for HCC. And we all know that HCC is a major health problem, and it's associated with high incidence and mortality. And if you look at the natural history of HCC, it is extremely heterogeneous. And this is because there is a complex interplay between the biological characteristics of HCC and because of the underlying chronic liver disease. So we have around 18 staging systems which have been proposed and are available in literature. And this is because this is a heterogeneous disease. And if you look at the East and the West, the scoring systems are different, and even the treatment modalities are different. So over the next 10 to 15 minutes, I will try and differentiate between the different scores which are available in the East and the West, and in the end, try and give a summary to which score should be used. So first and the foremost question is, why do we really need a staging system? We all know that staging system is the key for management of cancers. The first and the foremost is to assess and describe the extent of the tumor burden in originally primary organ and its spread throughout the body. The second point, which is important, is it allows an accurate prognostic stratification of tumor and gives us a choice of the best therapeutic approach according to the stage. The third important point is that it is useful for grouping patients homogeneously in clinical trials and scientific research, which is important because, as I said earlier, that the scoring systems which have been used in the West are different from the East, and even the treatment modality which are being used for different stages is different in the West and the East. So what is an ideal staging system? An ideal staging system is one which is simple and easy, which is quick to be determined as soon as possible after diagnosis, and also provides us information on prognosis and guides the therapeutic decisions. So whatever classical staging systems are available, like the Tnm staging, which was introduced way back in 1977, it gives us only the inherent characteristics of the tumor and do not include the variables which influence the patient's prognosis, which is very important for HCC. So what are the other important points? One, that each staging system and prognostic score must be reproducible and externally validated so that it can be used in a larger population. Two terminologies which I'll be using are homogeneity and discrimination ability. Homogeneity is the characteristic whereby the difference in survival time is small among patients classified in the same staging system. And discriminatory ability is the feature by which there is a greater difference in the survival time among patients classified in the different staging groups. For most solid tumors, we just look at the extent of the tumor, whether it's in the primary organ or it is beyond the primary organ and has extra organ spread. And this is considered exhaustive for most of the tumors. But HCC is a peculiar tumor. Why do I say so? Because usually it occurs in the background of a liver disease, making the level of management not only complex and unique, but also we know that it's associated with functional impairment of the underlying liver disease, and which has a significant impact on prognosis irrespective of the tumor stage. So this has led to the development of whatever staging systems we have. 18 or 20 staging systems have been proposed, and these are based on whether you are looking at just the tumor characteristics, you're looking at the size, nodule, portal thrombosis, or metastasis, or you're looking at the liver functions where people have looked at bilirubin, child score, presence of ascites. Even people have looked at the, people have looked at the ICG clearance and the portal pressures. The third and the most important is the performance status of the patient. Is the performance status of the patient good enough to undergo treatment, or the various modalities which are being used in management of HCC is also important. So whatever classifications are available, the earlier classifications like the TNM and the Okuda classification, they primarily looked at the tumor characteristics. But the recent classifications like BCLC or the Hong Kong classification, they have not only looked at the tumor characteristics, but have included the performance status as well as the liver functions for assessment. So let's look at the milestones in the staging of HCC. The first score which was advocated was the TNM way back in 1977. And then came this Okuda staging in 1985. And this remained there for around 2 decades. And subsequently, we had the CLIP, the BCLC. Then you have the Chinese classification, the revised BCLC staging in 2003. And subsequently, the Hong Kong and the Italian liver cancer classification, which has been recently proposed. So let's move on to the first staging. This is the TNM staging, which is primarily used for all solid tumors. And the first edition came back way back in 1977. This score has been proposed by the American Joint Committee for Cancer as well as the International Union for Cancer Control. And this has been used primarily by all the oncologists in several fields. And it will assess primarily the primary tumor, the lymph nodal spread, the vascular or the extrahepatic metastasis. They do not include any measures of liver function and health status. And what all is included, you divide it primarily into stage 1 to stage 4, and includes the size of the tumor, the vascular invasion, the extrahepatic spread, and the nodal involvement. And then you divide them into stage 1 to stage 4B, depending upon whether it is T1 to T4, presence of nodal metastasis or the extrahepatic metastasis. So just to give you an example, this is a small tumor, 2.5 centimeters, no lymph node involvement, no vascular involvement. So this would fit into T1N0M0, which is stage 1 of HCC. So let's look at the advantages of the system. This is a very good system for patients undergoing surgical resection because it imposes heavily on major vascular invasion and the extrahepatic spread, which is important when you have to resect a tumor. However, it fails to account for the liver functions, which has an important role in the prognosis of patients of HCC, and when they have, especially when they have features of cirrhosis. And it may not be suitable for application in patients who are not indicated for surgical resection or who have reduced liver function reserves. For example, advanced HCC patients. However, people have modified this staging also, and they have used this in combination with child score, as well as in other grading systems like CLIP and BCLC score. And this has improved the predictive capability of this score. So let's move on to the second score. This is the Okuda staging. This was proposed way back in 1985, and this is based on 850 patients from Japan and proposed by Okuda et al. This was the first staging system which incorporated the anatomical features along with the degree of underlying liver disease. And they divided this into tumor size, albumin, bilirubin, and ascites, and staged the tumor into stage 1, 2, and 3, and had a good predictive value on the survival of patients with HCC. So what are the advantages of using this score? This is a simple system, widely accepted, and it has been used for more than 2 decades. And now subsequently, you have scores which have included the performance status and other parameters which have taken over this score. However, this stage was the first staging system which included both tumor characteristics and the liver functions. The only caveat in this study was that most of the tumors were advanced, and only 20% patients underwent surgery in this staging. So with the development of advancement of techniques, small tumors are being picked up, and this staging is not good if you have to characterize these small tumors. It does not include the vascular invasion, the multicentric tumors, or the extrahepatic spread of tumors, which definitely affects the outcome of the patients. And it has a low predictive value as compared to the modern staging systems like CLIP or the BCLC staging system. So then came the CLIP scoring system. This is the Italian scoring system, which was proposed again way back in 1998. This was based on a retrospective analysis of 435 patients. And again, in this group also, a very small proportion of patients underwent surgery. Most of the patients underwent locoregional therapy, and they classified the patients based on the child book score, the tumor morphology, and they also include the tumor marker alpha-fetoprotein in this staging system. And it was seen that this stage correlated very well with survival. So let's look at the advantages of this score. This score was validated in multiple studies, not only in Italy, but also in Canada, Japan, and other countries. And it is also ranked as one of the best staging systems with the ability to predict survival. What are the caveats and disadvantages? Information regarding the performance status and extrahepatic metastasis, which affects the outcome, is lacking in the study. And it does not offer any appropriate therapy for HCC patients, which has been subsequently added now in the BCLC or the Hong Kong classification. And it cannot effectively identify early stage patients who would benefit from radical treatment like resection or transplant. So moving on, then came this French staging system proposed along with the CLIP classification in 1999. And this was again based on 761 patients. This included the performance status, but lacked the tumor morphology. And they divided the patient into 3 groups, the A, B, C. And this classification had a good predictive value on survival. And the stage A had much better survival as compared to the stage C. And it was a simple score, included the performance status and the liver test along with the serum alpha-fetoprotein. The limitations of this score was that 53% of the patients did not receive any specific therapy. That means they were advanced, and only 7% of the patients underwent resection. Hence, this score is not suitable for predicting the survival of HCC patients who are undergoing curative resection or transplantation. And another caveat was that they had used ultrasound to look for vascular invasion, which is not a very good technique. Now you have such good modalities which are available to assess the tumor as well as the vascular invasion for HCC. So moving on, the BCLC stage was proposed again in 1999, and this was the first staging system which recommends evidence-based clinical treatment algorithm. And this treatment algorithm has also been recognized by the American Association for the Study of Liver, as well as the European Association for the Study of Liver. This is a very important classification, and it identifies patients who will benefit not only from curative therapies, but also from palliative treatment or the best supportive care. So they have divided the patients into 5 groups, And not only have they given us the idea how to treat them, but also talks about the prognosis of these patients. So what are the advantages? It helps in predictors of prognosis like tumor extension, liver function reserve, and overall performance status. And early stage HCC is well defined in this staging system, which are patients who are suitable for curative therapies. And this system has been validated in multiple countries and has shown good predictive ability to predict survival. The only caveat is that Asians feel that this treatment modality is too restrictive. And for example, if you have a patient who has a child C cirrhosis and have an HCC within the Milan criteria, he would fit into BCLC-D and he's not fit for any kind of treatment, but he becomes a candidate for transplant, and people have transplanted such patients. However, I'm not going into the details of this classification and the subsequent modified BCLC and the recent modified 2021 classification. This will be discussed by the next speaker. So let's move on to the classifications which have been used by the Eastern countries. This is the Japanese integrated staging system proposed way back in 2003 based on 722 HCC patients from 2 Japanese institutes, and they combined the CTB score along with the Japanese Tnm stages. And this was based on 3 parameters: the vascular invasion, single versus multiple nodules, and diameter less than or more than 2 centimeters. And this score stratified patients who really required curative resections or transplant and had a very good predictive ability to discriminate these small tumors. So advantages of this scoring system is it looks at both the tumor characteristics and the liver functions, and it is good for early tumors. The only caveat, or I would say limitation, is it has been developed based on patients who have been in Japan only and not been validated in other populations. And the tumor size which have been taken in this study is 2 centimeters only. So you're not discriminating small or larger tumors, and there is no discrimination based on the tumor morphology in this staging system. So people have also tried to modify this classification, and they've added and they've removed encephalopathy and included ICG clearance. This is for patients who undergo surgical resection, especially in Eastern countries like Japan. And this another modification which has been suggested, which includes inclusion of biomarkers like AFP, L3, and DCP, which has shown to be a good predictive value in assessing the survival of these patients. You also have this Chinese University Prognostic score, and this score was based primarily from China and HPV population, and study was done in around 920 patients, and they have used the conventional Tnm scoring system along with the factors of liver function and tumor load. They've included total bilirubin, alkaline phosphatase, alpha-fetoprotein, and looked at ascites, and also included asymptomatic presentation versus the patients who present with other complications. So they divided the patients into 3 groups: low risk, intermediate, and high risk group. And this study also showed a good survival predictability for HCC patients. The strengths of this system is that they are readily available. The parameters which are assessed we can get them at baseline. And you also look at the liver function and tumor load in this study, which has a good predictive value for assessing prognosis of such patients. However, this study is not applicable for patients who are suffering from other etiologies like HCV or alcohol or NAFLD, and this has not been validated. And most of the patients in this cohort were in the late stage and received only supportive treatment, and thus this is not applicable for patients who come in early stage with small tumors and are eligible for curative resection or transplantation. So moving on to the most comprehensive classification from the East, this is the Hong Kong classification. And this is based on 4,000 patients. And this is a single center study. And this is very good and comprehensive in the sense it links HCC stages to the treatment options. And it also better stratifies the patient into distinct groups with better survival outcomes based on more aggressive treatment recommendations than BCLC. And This algorithm expands the scope of surgical resection beyond the BCLC-B, which I will show you here. And if you look at this, BCLC staging would fit into stage 2B, where they do not suggest resection, but this is an aggressive staging system, and they have shown pretty good results with resection in this stage. And advantages are that it is able to stratify patients in the BCLC B and C stage, as I said earlier, and they have shown better survival outcomes with more aggressive treatment recommendations that are observed in the BCLC treatment algorithm. The only caveat is that predominant patients in the studies were from HVB cirrhosis. They have not looked at HCV, alcohol, or NAFLD, and needs validation in patients with different disease etiologies. There is some data from our institute also. This was published by Professor Yogesh Chavda way back in 2010. And they had compared the 7 staging systems from North Indian cohort of HCC patients and included 101 patients. And they showed that CLIP, Tokyo, and the BCLC staging system showed a significant difference in the probability of survival. And the only marker which was associated with survival was the serum bilirubin levels. So just to give you the fallacies of the existing staging systems, none of these systems take into account the location of the tumor or its proximity to major vessels, which affect both the treatment selection and the tumor progression. The second thing is that they do not incorporate the etiology of liver disease, as I've said earlier. And most of these staging systems lack optimal treatment allocation, except for the BCLC and the Hong Kong classification. So what is the future of the staging system? People have tried to incorporate MELD and look at the outcome of such patients, and there are studies available. This is the model to estimate survival in ambulatory HCC patients, the MISI score. And this was proposed by the Mayo Group, and the population which was studied was the American as well as the Korean population. And they showed better predictive value than the original scores. You also have scores which have looked at the subgrouping of CLIP into 36 subgroups. And you also have subgrouping of BCLC stage, and all these scores have shown better predictive value for outcome of patients with HCC. So what about biomarkers? You have biomarkers which are available, which can be added to the routine staging systems, and studies are available where these biomarkers along with the other staging systems have shown better predictive outcome of patients with HCC. People have used IGF and VEGF and CRP also. And future seems to be that we should include genetic testing also. And this is one study where they looked at the 5 gene scores, and they showed that it has a good prognostic value along with the conventional scoring systems. So just to summarize, currently no globally accepted systems are there for assessing HCC patients due to the extreme heterogeneity of the disease. Clinicians should use currently available staging systems carefully with understanding their features and limitations. Understanding of the tumor biology is very important, and advancement in imaging techniques and treatment modalities will result in development of better staging systems. And as I said, that addition of biomarkers can lead to refinement of the process of stratification, survival prediction, and treatment allocation in order to optimize the management of HCC patients. Thank you very much for the patient listening.
Thank you, Dr. Sunil, for the wonderful overview. Now I hand over the mic to Dr. Ajay.
Thank you, sir. I think it's my privilege now to invite the next speaker, who is none other than Professor Maria Reg, and she heads the liver unit of the Barcelona Clinic for Liver Cancer Hospital Clinic at Barcelona. And on behalf of INASL, our special thanks to her to joining us for this meeting. And she will be telling us that what is new in the BCLC staging and how do we now do the treatment recommendations as per the new BCLC staging. Over to you, Professor Maria.
Thank you very much for your kind introduction and also for the invitation. Good morning and good afternoon, good evening for all of you. It's an honor to be here. So in the next 20 minutes, I will share with you the evolution of the BCLC staging system and all of the news that we incorporate in the new version that we presented and published last week. This is the BCLC staging system. As it was mentioned before, the first version was published in 1999. Over the years, we will include new data that characterize the patients and also include the new treatment that improve overall survival in patients with HCC. However, this new version that is now online in Journal of Hepatology was published last Monday. And we organized this publication from the BCLC members and also for extra external key opinion leader in the field, as you can see here in this slide. So this is something that was not done in the past. And we believe that it's important to consider the opinion for outside BCLC because the complexity of the disease is getting more and more difficult in the following years. The fair modification is here. We divide the figure from the prognosis. Here we include the refinement of the prognosis based on AFP, ALBI score, child or male. The second part is focused on patient characterization, and I will show you later on the modification that we have here. And after that, we link the prognosis, patient characterization with the best fair option that we could have based on overall survival improvement. After that, we have the expected overall survival if you follow this treatment. However, in clinical practice, there are many reasons why the patient could not be candidate for this fair option that we propose. So we add, and this is a very new tool that we add for the classification, that is the clinical decision-making part, where the physician who's responsible of the patient management will define based on age, comorbidity, patient values, or availability of the treatment, what is the best option for each patient. So in summary, we start from evidence-based data, and then we extrapolate this data from clinical practice in this part that is clinical decision-making part. As you can see here, the BCLC staging system have these 5 stages. They are not changed in the definition of that, but as I mentioned before, we refine the preserved liver function definition, and we add these asterisks to avoid the confusion that we usually have in those patients who are candidates for liver transplantation, but with worse liver function. So for those who have preserved liver function, the treatment is an option. But for those who have decompensated cirrhosis, but with candidate for liver transplantation, they are also part of the BCLC 0A or B. Again, we consider that child score is the most common score that we have. However, ALBI score and MEL and MEN-SODIO could refine the assessment of the liver dysfunction, and we could consider them in our clinical decision-making part. In addition, we also add AFP as a prognostic factor. However, we don't use a specific cutoff for any of these classification because there's not possible to extrapolate to all stages, but we need to keep in mind when we have the patient in our outpatient clinic. For this reason, as you can see here, we have information about the ALBI, child, male, are also AFP in almost all the stages of the disease. However, none of them identify 100% of patients, the patient with decompensation, for example, patient who develop a variceal bleeding or hepatorenal syndrome. Not every patient have liver dysfunction. So for this reason, we link the prognosis with the clinical decision-making, but for sure, we need to consider these factors in the clinical decision-making. The same thing happened with AFP, and I will show you later on the only way that we insert AFP in the new classification. The other important point, as was mentioned in the previous talk, is the performance status. Performance status is symptoms related to the tumor, and it's important to keep in mind when we assess the performance status that the patient with HCC could have symptoms from the HCC, from the cirrhosis, and also comorbidities. When we focus in advanced and terminal disease, there are patients who could have symptoms. We need to focus on tumor-related symptoms. They are not the symptoms that the patient have for years due to the comorbidities. And sometimes the characterization of performance status require more than one visit because the patient have other things that could consider symptoms related to the tumor, and it is not the case as the patient have mild liver dysfunction or fatigue for years due to the disease. So that's that about the prognostic in this part. Now I move on to the patient characterization. The first modification is here in the early HCC, those patients who have single lesions with portal pressure or bilirubin increase with contraindication for liver transplantation. The first option is ablation, and the exception is those patients who have single lesion, peripheral, and adequate remnant volume. In this setting, we have evidence to support the resection in this group of patients. And here you have all the papers that support this new modification of the BCLC. However, this version does not recommend resection for multinodular HCC within Maitland criteria, regardless of we having information in this regard. The first publication was in Japan, and the second one also is a randomized controlled trial, and I will show you later on the reason why, despite having this information, we don't insert in this new version. And we expect to have prospective studies in the future that could support the data from these two studies. This is the first one. This is the SURF clinical trial. This is a randomized clinical trial that compares resection versus radiofrequency in patients with less than 3 lesions, less than 3 centimeters, up to 7 Child-Pugh score. As you can see here, the recurrence-free survival was similar between both groups. However, when we focus on patients with multiple HCC, we only have 15 patients in each arm. So that's why we do not have a strong data to support this indication in patients within Milan criteria. The second study that was focused on this topic is from Japan. This is a prospective register from 2000 to 2007, more than 1,000 patients in liver resection and more than 1,000 in TACE. However, in the methodology, the authors mentioned that TACE was considered when resection was not possible. So at the very end, the patients are not exactly the same patients. The other important point is the characterization of patients according to the BCLC. They show that the rate of patients in the different stages are significantly different between the two cores. And here you have the summary of the study. The stage of HCC was not considered in the analysis. When they focus on patients who meet the Milan criteria, we reduce the numbers. 199 patients for liver resection and TACE. And the most important thing, the analysis considered liver function, performance status, and tumor burden together were not done. So that's why, regardless of we're having this information, we don't believe that is strong enough to support the recommendation. The second news is focused, and maybe the most important news in the patient characterization is the patients in intermediate HCC. In this group of patients, we divide the population into 3 groups, all of them with all the tumor inside the liver, performance status 0, and preserved liver function, except those who are candidates for liver transplantation. So those patients who meet the extended liver transplant criteria based on size and AFP could be candidate for liver transplantation. Remember that there's not a specific cutoff for AFP. However, more than 1,000 is usually considered exclusion criteria for that. The second group is those patients who have well-defined nodules, preserved portal flow, and selective access. For this definition of selective access, it's very difficult to extrapolate around the world, but we have the publication from 2012 from Lencioni and other experts in the field that characterize these specific things. And the last group from BCLC-B are those patients who have all the lesions inside the liver, but is diffuse, infiltrative, and involve both lobes. So in this setting, we propose systemic therapy as a first-line option. And here we have also all the data to support this indication. If you have a patient who is within the intermediate HCC, it's not feasible to transplant, it is not feasible to TACE, we consider systemic therapy as first-line option. Now I move on to the advanced HCC. There is not modification in terms of the characterization of this group, but we have a lot of information in terms of systemic therapy. And here we have the clinical decision-making part as the most important part in the decision of what is the best option treatment for each of our patients. Here we could consider the baseline characteristic of patients and also the evolutionary events, because we have some patients that could be candidates for downstaging, and this is applied for patients who are in intermediate HCC and meet the downstaging criteria and will be risky for liver transplantation. In addition, we have other patients who receive the treatment, the first option treatment, however, evolve with untreated progression and is not feasible to continue with the same treatment, and we move on to the right part of the figure, giving systemic therapy or best supportive care. So for the clinical decision-making part, if you have a patient in BCLC 0 or A who is not candidate for the first line, treatment option, or have a failure for that, the next step is stays or radioembolization only for those patients who have single lesion less than 8 centimeters. And I will show you why we include this new treatment in the clinical decision-making part, because it's another news in our classification. The next step is those patients BCLC 0 or A where achieve the criteria of downstaging, or those patients who come from here, from intermediate HCC, who achieve this point, could be rescued for liver transplantation. However, there are other group of patients, they are not candidate for that, or they are not achieve the criteria or present failure. In this setting, we move on to the systemic therapy. So let's go to show why the BCLC approach considers radioembolization in the clinical decision-making only for BCLC 0 or A with preserved liver function and performance status. The legacy study was the rationale for the FDA approved, was focused on patients less than only one lesion less than 8 centimeters, child A, BCLC A or C with performance status 1, and portal vein thrombosis. Here you have the result. Important to keep in mind that the time is overall survival. I see that the time is over, but I don't think so because we have more minutes. Could you confirm that I can continue?
Yes,
Yeah,
just
you can continue.
Okay, perfect, thanks. So the important thing here is radioembolization. The information that you have is based on response and non in overall survival, and that's why it's not first option, neither second option for this specific patient, but we could consider because we need to validate the information that we have until now. Now I arrive for the most important part of the clinical decision-making part, because it's the systemic therapy, and I will show you this in bigger because it's a lot of information. Here you have the landscape of systemic therapy. Sorafenib was approved in 2007. Atezolizumab versus bevacizumab was superior to sorafenib in 2019, was approved in 2020, and now is a current treatment in several countries. This year was announced the Himalaya trial, Treme-Durva, and will be presented in ASCO GI next January, and was also presented the Cosmic trial, that is cabozantinib more atezolizumab, and I will show you later on. We are also waiting for the ongoing clinical trials that could modify our clinical decision-making based on the results. And we have also all the treatment that was demonstrate the benefit in comparison to placebo, such as sorafenib or lenvatinib. And we also add radioembolization and nivolumab that will have response rate information, but is not approved based on overall survival. So that's why clinical decision-making is key in this part of the figure. When you have more than one option that improve overall survival, the physician have the responsibility to decide what will be the factors that he or she consider in the clinical decision-making. And this review summarize all of these points. The rationale could be safety, rationality, response, quality of life, However, the physicians could have different approach, and the most important thing, the patient could decide what is the best option, but we need to be careful because the patient usually decide based on our recommendation. So that's why it's important to be informed about all of this information. And now I would like to talk about the treatment beyond overall survival information. As I mentioned before, first-line treatment, atezo plus bev, is superior to sorafenib. It was announced the role of durva/treme, but we don't have the information to compare this head-to-head, and also have information about sorafenib, lenvatinib, and durvalumab. For second line, based in evidence, we only have options after sorafenib. Other first-line treatment, there are not options in evidence-based, and what we propose is consider clinical trials. However, if it's not possible to have this option, we could go to this box that is alternative sequences could be considered, but they have not been proven. And here we have the data. We have data about overall survival in all of these green treatments. However, we have data based on progression-free survival or response for atezo plus cabo, radioembolization, Sbrt, or immunotherapy. And we need to decide what is the best option for all of these patients. In this setting, we have the responsibility to decide, and here we have the different options that we could consider. The presentation of this talk is limited, so I will not enter in detail of all of these options, but I would like to mention that we have evidence-based treatment for first line, second line with TKIs, also vascular and vascular growth factor antibody. We have immunotherapy, treme-durva or the combinations, atezo plus beva. However, the information that you have in the setting of local regional treatment is limited, and also is limited the combination of cabo plus atezo. So in this setting, we need to carefully evaluate if we could consider safety, availability, or mechanism of actions. The situation that we have, at least here in Spain, is very, very bad because we don't have approval for several options. So to summarize my talk, I would like to say that this new version maybe covers some of the coverage that was mentioned in the previous talk, because we refine the prognosis. We also update the different treatment options, and in the prognosis, we better characterize the definition of those patients who are candidates for liver transplantation. We add this new chapter that is clinical decision making, and we also have the input for non-BCLC expert in liver cancer. So with that, I would like to thank you all for your attention. This is the last photo of the BCLC team. As you can see here, there's a multidisciplinary team that the different members are working in different parts, but all together as a group. So with that, I would like to thank you for your invitation, and we will go to the discussion.
Thank you, Professor Maria. I think that was wonderful. I think taking us through what is new in the BCLC staging in 2021 and will help us in better managing these patients. So with this, I'll request Professor Virender Singh to invite the next speaker, and Dr. Maria, you kindly stay on. We'll have discussion at the end of all the three talks.
Sure. And thank you, Dr. Ajay. Now we'll have a lecture by Professor Sareen. He doesn't need any introduction, and he'll be speaking on the role of antivirals in the decision-making and the tumor recurrence in HCC. Professor Sareen, sir. Unmute yourself.
Thank you, Professor Virender Singh and INASL for inviting me, Dr. Duseja. I will just share my slides. I bring greetings from ILBS. It's a difficult topic with limited clear messages. I have nothing to disclose. I want to define here HCC recurrence. We all know occurrence. Recurrence is reappearance of HCC that was judged to be radically and successfully treated by ablative techniques, TACE, surgical resection, or transplant. Recurrence rate is number of patients per 100 patient years who previously obtained complete response and developed HCC after therapy. The recurrence rates, whether it is B or C, in different studies have ranged from 2.2 to 54, and it depends on the duration for which you have followed up your patients. Normally, we have morphological and biological predictors of tumor recurrence. The most important of them remains the pre-transplant AFP levels, second, the grade, and third, macrovascular invasion. Pre-LT AFP is a useful marker, but see that where we are and what the future tells us. We are looking at less than 200 or more than 800. If it is more than 800, your survival is 5-year survival is just 40% or so. Now I come to the main topic, the decisions for HBV, occurrence, and timing. And mainly it covers occurrence while on therapy or mainly on recurrence post-ablative surgery. So we have primary prevention, secondary prevention, which is antiviral therapy with monitoring on compliance, efficacy, and resistance. And tertiary is antiviral therapy to improve liver reserve and reduce recurrence after curative therapy. Let's look at some basic data. This is an old study, but it tells you hepatitis B patients who are viremic, the survival probability is lower. Recurrent HBV, why there are challenges? Because HBV, although you are DNA negative, but the virus stays in the tumor cells and it is inaccessible to the drug because of change in liver structure and blood supply. So your Tenifo Enteka doesn't reach. 2, CCC DNA exists in the HCC cells. Also extrahepatic micrometastasis, wherever they are, and non-HCC tissues, they are potential reservoirs. So your CCC DNA persists and your drugs can't reach. Third, your hepatic immune network is dysfunctional due to HCC and poor response. So you have hypoxia, neither blood nor drug reaches there. So I will focus now simply on the antiviral therapy. I will not work on high-risk groups, course, or surveillance. So secondary prevention, either by PEG or by nucleoside analogs. Now, there are several studies, 2,000 odd patients, relative recurrence of HCC is decreased. This is occurrence and also subsequently recurrence. So occurrence is both decreased and tertiary prevention, which is your recurrence, is also decreased. While patient is on nucleotide analog, the adjusted hazard ratios, whether you are using Tenifo or Enteka, is decreased. On meta-analysis of all the patients available, both are nearly equal. Unless you have a randomized trial, I put both as equal. Non-viral therapies like aspirin, they have been used in large studies, including one in the recent New England. So aspirin reduces the risk of HCC. If there are no viruses, one should, or eradicated, you can prescribe aspirin. Statins similarly have been found in very large studies to reduce the risk of HCC. Can be prescribed if you are working on patients who have B or C plus fatty liver or otherwise. Now is the major question. Can antiviral treatment affect the incidence of microvascular invasion and early tumor recurrence after hepatectomy for HBV-related HCC? So this is tertiary. And what should be the timing of therapy? Now, there are two meta-analyses. This one by Chen it says that if the DNA is above 20,000 or equal to that, you have a distinct benefit. Recurrence is lower if the patient is treated. If the DNA level is less than 20,000, it is still better, but not as much as if you have a high DNA level. Similarly, overall survival post-operatively is better if the patient is on antiviral, and if it is less than 20,000, still beneficial, but not as much. Now, this is a landmark study in JAMA surgery, which everyone may like to be familiarized with. What they did was patients who were not receiving versus receiving antiviral therapy. So only 326 were on antiviral, so they were operated, and not receiving antiviral were 2,000. So the patients could undergo surgery even when they were not on antivirals. And what they showed was not 20,000 but 2,000 DNA. If the patient has less than 2,000 DNA, he has much less risk of developing recurrence. So remember, not 20,000, it is 2,000 DNA level, which can create a problem. And antiviral therapy, if it is given, it is beneficial, though marginal. I would therefore say we should wait if we can, if it is a proper hepatic resection. And this is the bottom line statement. Antiviral treatment administered more than 90 days before surgery was associated with reduced incidence of invasion and early tumor recurrence. Furthermore, AFP of 400 was considered as enough for recurrence, not 1,000, not 800, but 400. If the AFP is above 400, there is a recurrence. And I think this is a well-established fact. Surgeons generally want to go up, but we would say no. Tumor diameter, the encapsulation, satellite nodules, the type of Edmondson grade, and presence of cirrhosis all influence. But still, virus is important. Now, post-hepatectomy, early tumor recurrence, no treatment versus treatment, beneficial. Overall tumor recurrence, having given antiviral, much better, lower recurrence, and overall survival with antiviral therapy is better than non-antiviral. So, message is, if possible, wait till the DNA is less than 2,000. You can use 2 antivirals or whatever, but try to bring down the DNA before hepatic resection. The incidence of recurrence can be up to 50% at 5 years after complete curative treatment, and high viral load is associated, and preoperative nucleotide or nucleoside and agents are significantly better. So this is the carry-home message. Now let's look at some more data for tertiary prevention. If you have patients who have got nucleoside analog and you do surgical resection, decreased risk, decreased tumor and delayed recurrence, and lower cumulative incidence of HCC recurrence. Do interferons work? Well, not as much as the nucleoside analogs have worked. In HCV versus HBV, I'll come to HCV later, interferon reduces mortality and recurrence. But in HBV, it decreases mortality, but not recurrence rate. So interferon is inferior to nucleoside analogs as far as Hep B is concerned. Aspirin and statin, I would like to re-emphasize, even after surgical, one was to prevent, but this is post-surgery, resection, liver transplant. In both, aspirin reduced the risk of HCC recurrence. Statins reduced. So now we can say that while on therapy to prevent development, post-surgical recurrence, post-ablative therapy, the new 2 drugs which we can add are aspirin and statins. There is no study of combination. Going to HCV, It's a tough area, and I have just taken this from a large, good study published in Hepatology International. Here is a case who had a complete ablation, local ablation, but got a recurrence in the lung. Here, recurrence and the fracture is seen in the humerus. Here, another patient, he got a recurrence in the pubic symphysis, and here the patient got multiple nodules in the liver itself. After DAA therapy, this study shows that HCC may be more aggressive. Why? I mean, we think that you have given antiviral, the patient should get better. But the HCC behaves differently because we have started taking patients who are older. We never would do that with interferon when they are sick. The FIB4 score in these patients may be lower, means we are sometimes taking patients who are not that cirrhotic and they may have multicentric disease. So they will not manifest with cirrhosis, and we have started taking them. Third, and very important, and I agree with this, many of these patients have more infiltrative HCC. We never used to see such. They have more PVT and they have regional lymph node metastasis. AFP levels are higher in those who are treated and more advanced stages sometimes in these patients. But these two statements are slightly controversial. But yes, I agree, they are more infiltrative. Now, this is just to show you of all the available studies on HCV, HCC, and DAAs. 20% recurrence is seen. Some have high recurrence rates up to 80%, some have 50% or so. Now, what is the scenario? You have an HCV patient with HCC, which is unresectable. Otherwise, you will transplant or operate. Now, you give this patient DAA. HCC progression can occur with DAA ongoing. The tumor is not influenced by your DAAs. It is different environment. And you will continue giving therapy as well as you are treating the patient. Now, this patient has multiple tumors. They will keep on increasing. But you have a time lag. He is a good patient. He has not decompensated till now. So you will say, oh, HCV related HCC, the death is late. On the other hand, you have another patient, you have not given DAA, but he already has hepatic decompensation. He will progress. He will probably die early. And you will say, well, those who are not having DAA die early. Let's see this very important concept. These are called immortal time biases. A DAA exposed and DAA unexposed. Now, DAA exposed will be misclassified because you start counting the time from where the DAA is being given, and then you count till the event. In the other patient who is DAA unexposed, you just count the event, and from here to here you will count. In this, you will count from here to here, and you will miss this much time. Therefore, there can be bias. Similarly, like this is what I said, this time you will miss. Similarly, you have patients in which there is death. One is event and one is death. Both are missed. So we'll go back to this concept. It is the timing from where you have counted all this. And this, since this is not available, we still are under challenges. Now, here is one study, the same one I showed you earlier. There are three groups of patients. HCV plus DAA is group 1. A1, where you have received end of therapy response but no SVR. A2, where you have SVR. B, HCV but no DAA. And third is no HCV. Now you see in this, when there is group C, no HCV, here is the survival. In group B, which is one which has got HCV but no DAA, and here HCV where you have got DAA, the survival is better. When you split this into those who have got SVR versus no SVR, the SVR, the A2 group behaves better than those who have no SVR. but both groups are better than those who have got no HCV. So first, HCV, recurrence-free survival, is better than other types of HCV, but yes, getting SVR is better than having no clearance, only ETR. Now, this study, which covered all the US, about 31 centers, by Dr. Amit Singhal, who I think spoke yesterday, I might have used these slides. Conflicting data is there. Here is a set of patients who have HCV-related HCC. You have got a complete response and you have given DAA therapy, whether there is a recurrence or not. And I told you the immortal time biases will occur. They have 304 treated, 489 treatment naive. Their results showed DAA therapy has no impact on overall HCC recurrence or early HCC recurrence. So their message was clear that these therapies do not influence and timing does not make any difference. Now, there is more data which has come on this. Here you have data which has come from studies in gut. It is 2021. Number of previous HCC recurrence. The ECOG status, this is March 21 gut. Then AFP 1 log increase and tumor burden at last HCC treatment were found to be variable. This is a large global study of nearly 2,000 odd patients. See, the important part is previous HCC recurrence. So you have treated, but it has occurred again. The performance status, very important. AFP 1 log increase. The patient had an AFP of 5 and it has become 15. Tumor burden at last. And the study concludes that as of today, HCC recurrence for DAA treated patients is not different in patients with untreated HCV, at least during first 2 years. I will exemplify this more, but I want you to remember these few new data. Now here, patient has an alpha fetoprotein of less than 6. We don't bother till about 5. The moment it is less than 6 means it is 5 or it is 6 and above. And 6 and above, recurrence of HCC is significantly higher. The occurrence also depends upon presence of diabetes and also the eGFR. I told you the performance status. Now it is GFR, means involvement of kidney or diabetes. So 3 new variables. First is AFP, and remember AFP of 1 log increase now is considered significant. In another study from Korea, HCV has been treated. The duration of HCC after having treatment, SVR is about 18 months. Well, if it is SVR is 18 months, it is better. But if the treatment has not been durable, you got an ETR, you got an SVR 24, but not SVR 24, not 48. If you have a relapse after 24 weeks or so, it is a hazard ratio is high. So let's understand, just SVR 24 is not enough. SVR 48 and longer is required. And of course, as always, platelets are important. Further, this gut paper, I have come back to it. HCC recurrence, a lot depends on pathology. Solitary nodule, whether it is 1 or more, will decide. And secondly, you will also see that if there is a history of previous recurrence and resection, there is a lot to be seen. So all these will determine the recurrence rate. Solitary nodule, nodule with history of recurrence, nodule with previous recurrence and resection, with 1 previous recurrence or more. So this data shows you that, well, we have to know about tumor biology very well. With this, I would like to stop here and just to say that in HCV, the last message is that we do not know, and we need at least 2 years long follow-up. But today it does not make a major difference, and your biological markers are the most important markers. Thank you.
Dr. Vinder Singh, you need to unmute yourself.
Thank you, Professor Sareen, for the excellent lecture. And now we'll have the panelists, and the panelists are Dr. S.P. Misra from Allahabad, Dr. Goswami, Dr. Abha, then Dr. Mehtab, I don't know whether he's here or not, and then Dr. Brij Sharma from Shimla. Yeah, so before we go on for the discussion, this has been my observation. After COVID, the whole scenario has changed. Previously, we used to see the early BCLC or maybe the burn stage. And now the patients which we are receiving are unresectable. They are just for palliation only. All either you do tear or TACE or DAP-TACE. This is all, or give them the chemotherapy. This is what has happened because of the COVID, because they didn't have the facility for the treatment. And I think we are seeing the maximum number of HCC patients. And that may be because the Punjab, the polyclinical disease, Hep-C, and NFLD. We see day in and day out patients. Every OPD, we see maybe hundreds of patients of HCC. So with that, we can go to the panelists. Dr. Misra, what is your opinion, or if you have any question?
Well, I heard all the three speakers and all were excellent. And just to say that things are evolving. And as you said, we have got a setback because of somebody is chatting somewhere. Because of COVID, and things have changed because of COVID. Hopefully, COVID should, abate, and we should get back to what the speakers have said, to the normalcy. And even you see the BCLC classification has evolved 6 times. And now the Hong Kong one has about so many 9 parameters. So the parameters are changing. It's a dynamic process. Probably we don't have the exact answer even now. And gradually things will improve and we'll get better answers, I said.
Yeah, Dr. Abha.
Yes, thank you, everybody. I think these were great talks, enlightening. I have some questions for Dr. Maria. Very nice talk. Just wanted to know whether portal hypertension in any way could be incorporated in this system, especially for patients who have been selected for resection. That was the first question. If you could answer that.
Yeah. For the portal hypertension, we maintain the same cutoff. The only thing that we add is for those patients who have single lesion beyond peripheral lesions and with a minimum increase in portal hypertension. It means those patients who have from 10 millimeters of mercury to 12. Sometimes if it's a very easy resection now with the laparoscopy approach, you could consider in this specific setting. But we are not consider that we need to increase more because there are not strong data. Indeed, in the presentation of the BCLC staging system last month, Kokudo, who was part of the paper that allowed to use a more increased portal hypertension, said that after the evolution of patient, now they decide to stop resection in this setting of patients. So reinforce the idea that portal hypertension is a predictor factor of outcome, and beyond 10, you have risk. If you have a specific population such as single lesion peripheral, you could consider a minimum increase on that.
Yeah, thank you. The other question was the role of Sbrt. Where would it figure in your algorithm, especially with the recent Hong Kong paper, which said that patients on the wait list for transplant, the Sbrt group, of course, they had a control group, which was retrospective, did better in terms of tumor control and drop out from the wait list. So where would you place Sbrt in the early group?
The simple answer is we don't consider it in this version because the information that we have, there are a lot of information in the last, I believe, 8-10 years. But when you analyze the patients, are very heterogeneous group of patients, and the paper that have more patients and more information did a propensity score, and they compare radio frequency with our patients that are not candidates for this treatment to Sbrt. So we believe that this is the same in the same line of multinodular HCC. We need to have prospective data and very well select group of patients that could be candidate for that. But we add in this box of there are information about response, but they are not the first, second, or third option. If you are not other options, you could consider based on the information that you have.
Yeah, Dr. Goswami, we'll take up the comments from the panelists first, and then after that, we'll invite others.
Yeah, my point is already I have heard all the speakers and all of us who know about the whole HCC. It is a very complex problem. The severity is very high, and ultimately that's why we do not have till today the ideal scoring system or the staging system. That's why probably it is an evolving one. More and more new modalities will be coming up in the future. And it is a unique because ultimately we have to address the tumor burden. Then we have to consider the background, liver disease, and also we have to think about the condition of the patient. These three components are there while treating a patient with HCC. That is the whole problem, and that's why it is evolving to have an ideal staging system.
Viren, can I butt in for a moment?
Dr. Mehta, is he there?
Viren,
Dr.
can I butt
Mahmood, are
in
you
for a
there? Yeah,
moment?
please.
Mehta,
Yeah, I'm here. Yeah, I'm here.
please give your comments.
I actually had much disruption with the net today, but I have a question to Professor Sarin sir. So one of the situations that we face often in our countries, patients with HCV-related HCC. Should we treat both HCC and HCV? Should we give the DAs to HCC patients?
In simple terms, if you are going for transplant, you can do transplant and treat post-transplant. If it is for resection, you start DAA and can go ahead with resection.
If it is for neither, sir.
Yes, the chance of recurrence with or without DAA are unlikely to be different. If you are not doing any surgery or ablative therapy, that also can be taken up directly without waiting for RNA levels to come down.
Yeah, Dr. Bridge Sharma.
My question is to Dr. Sunil. As your talk was excellent, you have told that there are 18 different classification or staging of the cancer. Does there any study which has compared all these staging, different staging of the HCC treatment or not?
Yeah,
so I think you have to understand that these systems have been developed looking at so many features. So either you have the anatomical, or you have the liver functions, or you have the performance status, and you have staging systems which have looked at the combination of all. And these systems have evolved over a period of time. So it's not that at one point of time these systems evolved. There are no comparative studies which have compared all the four systems, but yes, there are studies which have looked at the major systems like the BCLC or the CLIP or the CUDA, and they have shown that these systems do fairly well in prediction of outcome of patients with HCC.
Does the BCLC system has been tested in Chinese patients, or Chinese classification has been tested in the Western patients or not? Is there any difference between the race or the etiology of the HCC?
Yes, that is the major difference between the staging systems which have been used. These systems have not been validated in different populations. For example, the Japanese or the Chinese scores, they have not been validated in the Western population. So that's what I've shown the disadvantages of the scoring system is that you do not have one system which has been validated all over, except I would say the BCLC, which has been most widely used now.
Yeah,
Okay.
Dr. Ajay.
Yeah, Dr. Maria, we have some questions for you, and we will obviously allow you to answer those and make your comments. So before that, I think we have 2-3 questions on the chat box also. And before we take that, I think the first question to you, Dr. Maria, would be, where do you place transarterial radioembolization, Y90, in the revised BCLC? So that's, I think, probably we saw was missing. There were some comments and the commentaries related to tear in this. So first question is to you on that. The second question, which we have taken from the chat box, is about, the role of systemic therapy in BCLC-B patients who have undergone, loco-regional treatment. Say somebody undergoing TACE, routinely systemic therapy would be indicated as a first line, as you said. But then after, the loco-regional treatment, say TACE, and then consideration of systemic. And the last question we have in the chat box is about, the size of the lesion. So that remains the same in the new classification, or have you changed the size for the single lesions?
Okay.
3 questions, and you can make your comment also.
Yes, the radioembolization we consider only for patients who have only one lesion less than 8 centimeters who are not candidate for other options. This is the only way, and the rationale for that is the legacy study that was published in Journal of Hepatology and the approval of FDA. The second point, if I understand correctly, is systemic therapy in patients who are under TACE or local regional treatment. We don't allow the combination therapy because the trial that was evaluated in that setting were negative. So we allow the sequential treatment. If the patient have failure for TACE, you could consider for systemic therapy. And the last question about the size of the tumor for resection, we have never have a cutoff of size for single lesion. If the patient have preserved liver function, portal hypertension less than 10, one lesion, the patient is candidate for resection. The only cutoff that we have is for those patients who are not candidate for resection, nor candidate for TACE, and we consider for a radioembolization due to the study that I presented. And I believe that I answered the 3 points. The comment that I would like to do is based on the validation of the different staging system, it's important to keep in mind that each staging system proposes a treatment. So it is not feasible to validate one with the other, because at the very end, the outcome is associated to the treatment that the patient received. This is the first point. Okay. And related to the recurrence, I understand that Dr. Sarin mentioned the GATT publication that we were the authors, and also the single paper. Both papers say that there are no difference. That does not mean that it's better to give one treatment or other. It's inconclusive, and it's important to mention the patient, the risk that they have to receive the treatment. I believe that this is the most important thing.
We are running short of time. Very quick comment. Very quick comment.
By Dr. Arka first.
Dr. Sarin, and then Dr. Arka. Last 3 comments only, that's all. Dr. S.P. Misra.
Yeah, Maria, I was just wondering if what Dr. Sarin said about the JAMA surgery paper, would you like to incorporate those things into your BCLC revised classification? Next, Dr. Sarin showed you some data about the JAMA surgery paper, and there were very important things over there. The AFP levels have gone down, things have, smaller tumors are there. Would you like to incorporate them in the next BCLC classification?
Indeed, we incorporate AFP, we incorporate several points, but they are not a specific cutoff to mention above or beyond these points. So something is prognostic and predictor, but we are not strong data to support it. In the future, we will have to have more data. Means that the science improves.
Thank you.
Dr. Sarin.
Yes, Maria, I enjoyed your talk. Only one question. There was paper in GUT or so that nivolumab patients, once they are resistant, they make a cluster of cells which are non-approachable. And in the therapies beyond nivolumab, are there any which can reach out to the clusters of non-sensitive nivolumab? So can you give atezolizumab plus bevacizumab to nivolumab resistant patients?
The point is for Atezo plus Bev, the only evidence that we have is in first-line treatment. Beyond that is clinical research, and at least from the recommendation of the BCLC, we base on evidence-based and then clinical practice. If you ask me as a clinician, if you have availability of the treatment, if you could consider, my proposal is if you do not have a clinical trial to enroll the patient, that is the best way to support the indication, you could do based on the characteristic of the information that you have.
Dr. Arka, very quick comment.
Yeah, my question is to Professor Maria. Basically, it's about BCLC-A. So we are considering any single lesion above 2 centimeters in size, irrespective of the size to be BCLC-A. And the treatment options are either a resection or an ablative option. Now, suppose the patient is not a candidate for resection. He has CSPA. Then how do we do? Because if it's a very large lesion, then what is going to be the efficacy of an ablation? And the second question is, do you think, ma'am, that it's time that we start to bring in the etiology into the staging, given the fact that, you know, ascertainment of CSPH in NAFLD could be difficult, the role of immunotherapy could have lower responses in patients with NASH. So should the etiology also be coming into the picture now in future staging considerations?
Yes, regarding the first question, this is the treatment state migration, not candidate for resection, no candidate for radiofrequency. We move on to TACE. If it's not candidate for TACE, chemoembolization, and this is the concept. Regarding the etiology and the potential impact in the treatment, the information that we have from NAFLD and immunotherapy is weak in terms of patients. Very well done in basic research, but not for patients. So Dr. Sian said that we need to stop. This is my short answer.
Thank you. Thank you very much. Thank you, Dr. Maria, Dr. Sunil, Professor Sareen, Dr. Abha, Dr. Goswami, Dr. Mehta, Dr. Bridge, and everybody for a wonderful discussion. Thank you very much.
Thank you, sir. So on behalf of INASL, I would also like to thank all the key speakers for wonderful presentations, Chairperson, Dr. Virender Singh, and all the 5 panelists. And we've had a wonderful discussion. So thank you all. And Dr. Maria, especially thanks for joining us. And let's move on to the next session. And I'll request Dr. Madhumita to take over the next session, please.
For the next session, which is on the radiological treatment of hepatocellular carcinoma, I invite our 2 chairs, Professor R.K. Dhiman, my mentor, who is now the head of the Department of Hepatology at SGPGI and director of the Institute, and Professor Usha Datta, who's head of the Department of Gastroenterology at PGI Chandigarh. Welcome to the stalwarts. Professor Dhiman, sir, unmute yourself. And
unmute.
And good afternoon, Professor Datta.
Good afternoon. Thank you, Madhumita, for a kind introduction. Thank you for inviting us for this session. It's a very interesting session we are looking forward to. And after we discussed on various forms of therapy, radiological intervention remains a very key role in management of patients with HCC. We look forward to this discussion. I request Dr. Dhiman to introduce the first speaker.
Thank you, Dr. Usha. I think it is a very interesting session on the treatment, particularly the radiology. And we have 3 speakers, Dr. Naveen Kalra, Dr. Deepak Shiriti, and Dr. Shivanand Gamnagati. So the first speaker, Dr. Naveen Kalra, he is a professor in the Department of the Radiodiagnosis, PGI Chandigarh, and he would be talking on radiological ablation of hepatocellular carcinoma, when, which, and how. May I now invite Dr. Naveen Kalra, please?
Yeah, good afternoon, sir.
Good afternoon.
My slides, sir,
They are visible, sir. Please make them full screen.
Okay. So is it fine now?
Yes.
Okay. Yeah. So good afternoon, everyone. And at the very outset, I'd like to thank INASL, especially Dr. Ajay, for having me here for this talk here. And I'll be speaking on radiological ablation, when, which, and how. so I have no financial disclosures. So as we all know, surgery is definitely the treatment of choice for hepatocellular carcinoma. Unfortunately, 70% to 90% are unsuitable for resection due to extensive intrahepatic tumor involvement, extrahepatic disease, and poor liver reserve. Ablation involves the use of chemicals, thermal or non-thermal energy delivered by electrodes directly to the tumor to achieve necrosis. So we've had a lot of discussion on this one, but as per this version of the BCLC staging system, ablation is indicated for the very early stage, which means a single lesion less than 2 centimeters, or for the early stage tumors, which mean single or 2 to 3 nodules less than 3 centimeters. That's where the ablation fits in. But as far as the practical implications are concerned, this observation in the practice guidelines of ASLD are very pertinent. They say that whereas smaller single tumors less than 2.5 centimeters that are favorably located may be equally well treated by either resection or ablation, tumors larger than 2.5 to 3 centimeters, multifocal or near major vascular biliary structures may have limited ablative options. But this limitation may also be there for resection in case of multiple tumors that are bilobar or centrally located. So we will see different case scenarios and see which ablation method and how we did it. So first, this classification of this ablative therapies. There's the chemical ablations not used routinely, ethanol and acetic acid. And then the thermal ablation, primarily RFA, microwave ablation, and cryo ablation. And then the non-chemical, non-thermal ablation, that is the irreversible electroporation. So the first case scenario, this is a hypervascular lesion in an HCV positive patient. You can see the enhancement and the washout here. In this patient, we decided to do radiofrequency ablation. So these are the grounding pads. These are the different types of electrodes. That's the generator and that's the pump. So the mechanism of RFA, which is that the high frequency alternating current is used and alternating current is passed into the target tissue from the electrode tip. And there is cellular damage due to the frictional heat subsequent to the rapid oscillation of ions. So there's a controlled area of ablation due to the oven effect of the cirrhotic liver. And this procedure is usually done under conscious sedation or sometimes under general anesthesia. And there's the circuit that we create. That's the probe inside the lesion. That's the generator. And those are the grounding pads. So that was the lesion that I showed. That's the probe in situ, and that's the progression of the ablation, and the lesion gets gassed out. That was a 3 months follow-up. You can see this this ablated area with some hyperdensity within on the non-contrast CD because of the coagulative necrosis, and but there is no enhancement. So there is treatment of the lesion is technically successful. 6 months later, we see that there is this is shrinkage of this ablated area and no enhancement. So this is a good result. But 1 year later, we see some nodular enhancement at the periphery, indicating local recurrence. Now, case scenario 2. So here we have a hypervascular lesion here, subtle hypervascularity here. On the venous phase, you see some washout, but you see this lesion is abutting the hepatic vein here. So because of this, there could be a heat sink effect. And that's the lesion on ultrasound. That is, you can see it's less than 3 centimeters, but it is very close to the hepatic vein, which means that there could be heat sinkage. So in this patient, we chose to do microwave ablation using this applicator here. That's the generator of the microwave. So the mechanism of microwave, these are electromagnetic waves, and the devices use frequencies higher than 915 megahertz. And microwaves of 915 megahertz can penetrate deeper than the 2450 megahertz microwaves that are also available and may result in larger ablation zones. In this technique, the water molecules act as electric dipoles and align to the changing field lines. Neighboring macromolecules are heated by convection, and this best heating effect is achieved in tissues with a high content of water. Now, this procedure can also be done under conscious sedation, usually, but sometimes you may need general anesthesia. So that was the lesion that I showed. That's the applicator in situ, and that's the ablation going on, and the lesion gets gassed out. That's the 1 month follow-up. You can see a large area of ablation, and these are the location of the lesion. Those are the hepatic veins that were close to the lesion. And that's the coronal reconstruction, the large ablation area with the vessel close to the lesion. And this is the 3 months follow-up. So you do not see any recurrence here in this tumor. So when we look at a comparison of RFA and microwave ablation, lower intratumoral temperatures with RFA, higher with microwave. Heat sink effect is more with RFA, less with microwave ablation. More procedural time with RFA, less ablation volume with RFA, shorter procedure time with microwave ablation, larger ablation volume with microwave ablation. And RFA contraindication is pacemaker, but on the other hand, with microwave ablation, the pacemaker is not a contraindication. So just highlighting the advantages of microwave, higher intratumoral temperature, larger tumor ablation volume, faster ablation time, improved convection profile, and a lower risk of heat sink effect. But there are adverse effects of any treatment. This holds true for both RFA and microwave: hemorrhage, infection, or abscess, visceral organ injury if you're not careful with your placement of your needles, liver failure rarely, pneumothorax if you cross the pleura, and skin burns more common with radiofrequency ablation and not seen with microwave ablation. As far as the results are concerned, results regarding local disease control are controversial. You have data where sometimes ablation was better with microwave and in others better with RFA ablation. And even the local recurrences, the data is slightly controversial. Conflicting data here. You have sometimes local recurrences being reported more with RFA and sometimes more with microwave ablation. And as far as the overall survival is concerned, data is there which looks at a range of success or of overall survival at first year to the tune of 68 to 100%, and then a wide range at the 4th year as well. And the complication rates are similar. So a commentary in 2020 in an esteemed journal of IR, the CVIR, looks at microwave ablation versus RFA in HCC, superior, equivalent, will we ever know? And some interesting observations there. So RCTs have failed to show any oncological benefit of microwave ablation over RFA. Studies compare one microwave system to one RFA system. Results of these studies should apply to these systems. They refer to and cannot be generalized unless the equivalence between systems is demonstrated. Local tumor progression may also depend on the imaging guidance used for needle placement, and ultrasound has been shown to reduce the risk of local tumor progression owing to its real-time ability as compared to the CT guidance. This is a meta-analysis which looked at RFA versus microwave ablation for early stage hepatocellular carcinoma, looked at total studies of 26, 5 of these were RCTs, and in total 17.6% patients exhibited progression during follow-up in the microwave ablation group compared with 19.5% in the RFA group. So no statistical significance there. So no statistical significant difference was observed between microwave and RF groups in terms of overall survival and disease-free survival. So microwave ablation exhibited similar therapeutic effects as RFA in the treatment of early stage HCC. Another case scenario. This is a patient, ethanol-related disease. This is a subcapsular lesion. This is close to the gallbladder and also close to the hepatic flexure. So if you wanted to do these thermal ablations, that is the RFA or microwave, you would have to create artificial ascites to kind of create a cushion between the gallbladder and the lesion here. But here in this patient, we chose a different modality to treat it without creating artificial ascites. So that's again a lesion less than 3 centimeters. And that's the crisscross positioning of the cryo probes without creating any artificial ascites here. So that's the 3 months follow-up. We see the good ablation here. No damage occurred to the surrounding structures whatsoever. At 30 months, there is again no tumor recurrence, and even the ablated area is almost very negligible here. Another case scenario, a lesion that we treated last week only. This is a subcapsular lesion causing a bulge of the liver capsule. This is sitting next to the IVC. That's the location of the lesion, less than 2 centimeters here, and no vascularity could be demonstrated within the lesion. We placed the cryo probe here, and that's the ice ball and it's shadowing, and that's the lesion getting treated with cryoablation. That's the position seen on CT, and that's the oval oblong ice ball that we see during the procedure, and that's at the end of the procedure. The ablated area is larger than the lesion that we set upon treating earlier. So the enlargement of the hypoechoic area indicating the ablation zone. So cryoablation is an ablation technique based on in situ cyclic application of low temperatures to the targeted tissue. Early cryotherapy systems used bulky probes and liquid nitrogen as a refrigerant, and that's why the complications were more. They had a high rate of complications, and the procedure was limited to laparotomy. Development of the argon helium superconducting targeted system and smaller probes has revolutionized the clinical application of cryotherapy. It works on the principle of cooling via rapid expansion. The argon rapidly expands and the Joule-Thomson effect occurs, and there is this freezing or ice ball formation, and then thawing is done, active thawing with the helium gas. Procedures under conscious sedation or local anesthesia here. Monitor with CT scan after 2 to 4 minutes. And typically we give 2 cycles of like 10 minutes freeze, then 10 minutes thaw, and then repeat it 10 minutes freeze and 10 minutes thaw. This exploits the early focal edema and alveolar hemorrhage generated during the first thaw cycle for better thermal conduction due to fluids beyond the margin of the targeted tumor in the second freeze thaw cycle. The cells, the HCC undergoes coagulative necrosis by rapid freeze and slow thaw. There is direct cell injury due to the crystallization of water molecules inside and outside the cell. There is cell dehydration and also cell membrane damage. During thawing, there is recrystallization of the tiny ice crystals, leading to formation of large ice crystals, and the interruption of the local microcirculation is also there because of the cold temperature and vasoconstriction, and there is also induction of apoptosis in the periphery of the lesion. So the advantages of cryo: ability to visualize the ice ball, no causation of severe pain, the cold temperature blocks the nerve conduction, the vasoconstriction minimizes the edema, and also the release of pain-inducing substances from the damaged tissue. There is little impact on nearby blood vessels, and it does not affect the collagenous tissue, and it also induces a cryoimmunological response. Adverse effects: bleeding, cryoshock, now rarely seen with the new machines, liver abscess, as was seen even with thermal ablation, and the risk of tumor seeding. So future directions are there for cryo. Like for other heat-based therapies, they cause protein denaturation, but cryoablation has the highest potential to elicit an immunogenic response because there is availability of intact immunogenic antigens. There's activation of nuclear factors, higher cytokine levels seen with cryoablation as TNF-alpha and macrophage inflammatory protein 2 after cryoablation. It triggers a tumor-specific protective immune response, and there's need to explore the abscopal effect of cryoablation. So this is our group looked at the overall survival and local recurrence following RFA, microwave, and cryoablation of very early and early HCC meta-analysis, and we looked at the hazard ratios and the risk ratio for local recurrence, and the observations were that there is no significant difference in the overall survival and local recurrence at 1 year and 3 years following ablation for very early and early HCC with RFA, microwave, and cryoablation. And there was no effect of tumor size on the treatment efficacy. Unfortunately, we could not in this data look at the tumor location because of this non-homogeneous data available with us. Now the last, the ablation therapy that is available with us and is commonly used at other places in the West, that's IRE, is a non-thermal technique that uses pulse direct current to induce cell death. It's a process of creating nanopores or holes in the cell membrane using an electric field to increase the cell membrane permeability, resulting in apoptosis-induced cell death. And this again spares the normal connective tissue network. So IRE is thus done as an alternative to thermal ablation in the same stage of HCC, but for lesions located close to vital structures like the perivascular and peribiliary region. So another case scenario, you can see this is a cirrhotic liver with this hypervascular lesion sitting at the hilum of the liver, very next to the major hepatic arteries. And these are the coronal reconstructions showing the location of the lesion at the hilum of the liver next to the major vessels. And here we use this high energy current generator to the tune of 3000 volts with an ECG synchronizer. Use these unipolar electrodes, which have this active electrode at the tip, which can be adjusted from anywhere to 5 to 40 millimeter in length. And that's the anterior approach using CT guidance to place our probes very parallel to each other into this lesion at the hilum of the liver. Procedures have to be done under general anesthesia, and procedures have to be done under CT guidance because we have to be accurate and precise. That's the lesion bracketed within this triangle. These probes we cannot bring closer than 1 centimeter. We cannot take them farther away than 2.5 centimeters, and they have to be really parallel to each other. So that's the accuracy and precision required for this treatment. So at the end of this ablation, there was no significant arterial or venous injury, and the area got ablated well. So the adverse effects of IRE, transient cardiac arrhythmias, muscular contractions, transient hyperkalemia, and if you're not careful with your needle placements, you can have pneumothorax or venous thrombosis as well. This is our early experience in HCC with IRE. And in this, we looked at 21 patients, and the mean tumor size was 26 millimeter in the range of 14 to 40 millimeter. And we found that the size of the tumor, the maximum tumor diameter less than 25 millimeter, was significantly associated with local tumor progression-free survival. So that the tumor size affected the outcomes here. Now our group also looked at the efficacy and safety of IRE for malignant liver tumors in this meta-analysis, which actually covered IRE in HCC, cholangiocarcinoma, and metastasis as well. We found that HCC was associated with better overall survival at 12 and 36 months versus the other tumors. And that's the results, the overall survival and progression-free survival at 6, 12, and 24 months for all the tumor types. From starting at 93% and then dropping down to around 62%, and the progression-free survival from 80% dropping down to about 50%. So the other observations that we made were that the pooled overall survival and the progression-free survival of IRE is lower than that reported for RFA and microwave ablation. But this is the patient selection is also different for IRE. So a direct comparison of the efficacy of IRE with RFA and microwave in the clinical setting cannot actually be performed. Prospective randomized trials will also be difficult to perform. IRE also induces some immune response in the form of rise in interleukin-6 and the macrophage inhibitory factors. So just to give an overview of the cost of this therapy that we are having here in our country presently, anywhere from RFA would cost the equipment from 15 lakhs, IRE would cost 2 crores. The cost of the probes for RFA is 70,000, and for IRE it would be 300,000. So there's a cost difference as well. So this is the PGI liver tumor ablation model that we are following at our center presently. So if you have a central lesion, we go for IRE, that's a hilar lesion. More peripheral lesion, microwave ablation, this is usually close to the vessels, the branches of the portal vein or the hepatic veins. More peripheral lesion, not close to these vessels, we go for radiofrequency ablation. And if we have a tumor at the periphery in the subcapsular location, we go for cryo ablation. Just to mention here, more central lesions, you can also taste them, and more subcapsular lesions also you can taste them. You can, if you have artificial ascites, you can still use RFA or microwave in these peripheral lesions. But we have the luxury of cryoablation. So without creating this artificial ascites, we do cryos here. You could do IRE here at the periphery as well. So cryo, RFA, microwave, and IRE in this sequence from central to peripheral. Just showing how many ablations we've done at our center, but don't go by these figures of cryo because we just got it a couple of years back. Still, workhorse is still resting with the RFA ablation, no doubt. So to conclude, RFA and microwave ablation are comparable techniques for ablation of HCC. Microwave ablation may be preferred for lesions larger than 3 centimeters and for lesions close to blood vessels, as it achieves larger ablations and has less heat sink effect. Cryo ablation should be preferred for subcapsular lesions. IRE should be preferred for hepatic hilar lesions. And definitely a tailored approach to ablations is recommended based on the experience, preference, and local availability. Thank you very much for your patient hearing.
Thank you, Dr. Naveen, for a very comprehensive talk. And now may I request Dr. Usha Datta to introduce the second speaker.
Thank you, sir. The next speaker is Dr. Deepa Shri. She is the head of the department at the Department of Interventional Radiology at Dr. Rela Institute of Medical Center, Chennai. Dr. Deepa would be speaking to us on endovascular treatment for HCC, the role of TACE versus DEP-TACE. DEP-TACE is when you have drug-eluting beads along with TACE versus the TARE technique, that is transarterial radioembolization. So these are three techniques which are used by radiologists to provide endovascular therapy. I request Dr. Deepa to start her lecture. Thank you, Dr. Deepa.
Thank you so much, ma'am, for the introduction, and thank you, INASL, and thank you, Dr. Ajay, for having me over here. First of all, I must congratulate on the organization. It's been an excellent two-day meet, and once again, thank you so much. So today's topic is endovascular treatment for HCC. So I will be taking you through some of the cases and what does literature say about conventional TACE versus DEP-TACE versus TARE. So I work at Rela Hospital. And moving on, as we all know, transarterial chemoembolization, the conventional case, rather it is, mostly it's for intermediate stage HCCs, early HCCs in the curative therapy if it's not possible, and as a downstaging. At our center, we do quite a bit of downstaging as a bridge to liver transplant. And so conventional case mostly involves, it's very, very important to understand why, the literature is so varied and nobody has come up so far as to which technique is better, whether it's a conventional TACE or a DEP-TACE. I have, my own evidence as to why I feel, there are certain reasons as to why the literature is probably not accurate when it comes to differentiating conventional TACE to the DEP-TACE. So here, as we know, we have the doxorubicin and the Lipidal emulsion, and it is followed by embolization. So it's a very basic thing that we all understand in conventional TACE. In DEP-TACE, we use drug-eluting beads. These are the non-biodegradable beads, and these are of different sizes, as we know, 300 to 500 microns, 100 to 300 microns. And if you see the liver capillaries, especially the tumor capillary bed, it's about 30 microns. So generally, these beads, they just go up and then they swell, and especially some of the beads, it just kind of swells by 4 times the size. So we need to choose the beads accurately if you want to induce tumor ischemia. So choosing the right beads is very important. Choosing the right size is very important when it comes to drug-eluting beads. Having said that, there is a variability from one person to the other person when it comes to using the beads. So we have to decide with each and every patient, looking at the patient, looking at the vessel size. That is when you decide on table as to what bead size you choose for a particular patient. And so there is a variability here when it comes to doing DEP-TACE on each patient, because everybody's vasculature is so different. So choosing the right bead size really matters when it comes to tumor necrosis. And this is how DEP-TACE is done. Most of the times we cannot see these beads when we are injecting the beads, unlike Lipidal, which can be seen on the X-ray. We cannot see the beads because these are not radio opaque beads. So we just have to it has to be very precise, and we need to know where exactly we are going, because sometimes you can have a tumor which is very, very small, and if you want to do drug-eluting beads, and if you're not really sure about which vessel is actually supplying that particular tumor, which can happen in certain cases, then it can be extremely difficult for us if you want to go in and do drug-eluting beads in those patients. Now, conventional TACE and DEP-TACE, as we all know, these are contraindicated in patients with advanced cirrhosis for child C, if the performance status is more than 2, if there is a significant extrahepatic tumor burden, and those with medically refractory hepatic encephalopathy. And there are certain relative contraindications. I think we need to observe the word relative contraindications, because there are a lot of patients who we come across with main portal vein thrombus, with total bilirubin. Sometimes, we have done TACE on patients who've got bilirubin of 4.5 or really more than 4. But again, it's a wise call, and we need to choose the patients wisely. You can really do TACE in some patients When you do a super selective catheterization, bilirubin is definitely not an absolute contraindication. So sometimes patients are sent to us and they say bilirubin is 4.3. Can you do TACE on this particular patient or not? Yes, you can do, provided the tumor is small and we can super selectively go in and do it. I don't think it's a big disadvantage there. And if the serum creatinine is more than 2, and if there is significant arteriovenous tumor shunting, and I want you to note about this arteriovenous tumor shunting, because again, AV shunting is not an absolute contraindication, it is a relative contraindication. Conventional TACE versus DEP TACE, we all know that there is a slow release of the drug over a 2-week period, especially in drug-eluting beats, unlike conventional TACE, wherein they say, the drug is released into the systemic circulation. And because the drug is released into the systemic circulation, not enough drug stays inside the tumor. And that is the reason why there are a lot of systemic side effects when it comes to conventional TACE. Again, I will tell you why this happens, because there is a different way of mixing lipidol and the doxorubicin. The way you mix the lipidol and the doxorubicin really matters. And the reason why there is an early release of the drug is because it's not mixed as per the guidelines. There are no national guidelines until now. There is no standardization when it comes to conventional TACE. Whereas when it comes to DEP TACE, there is a standardized protocol of how to mix your beads. So probably the results are uniform when it comes to DEP TACE, but when it comes to conventional TACE, because there is no standardized technique of mixing the lipidol and the doxorubicin, the results are varied as well. So how can you actually compare conventional TACE to DEP TACE when there is no standardization, when there is no consensus guidelines, when there are no national guidelines for the conventional TACE? So this is a very important point that I want everyone to really understand. And so this is what happens with the conventional TACE. You probably will have slightly more systemic side effects compared to DEP TACE, wherein the systemic side effects are probably minimal. And this is how lipidol is mixed. Because lipidol kind of melts the plastic. So you take it in a steel bowl and you mix the doxorubicin and you take the lipidol and then you mix it. Now, how do we mix it? We did a study, across various centers in India. And what we have noticed is there is a significant variability from one person to the other person. Everybody, they have got their own methods of mixing lipidol. Whether you mix water to oil or oil to water really matters. And the other thing that really matters is the contrast agent that you take when it comes to mixing the lipidol. We need to mix lipidol. What we have noticed, in our practices, when you mix lipidol in Visipec, which is one of these isoosmolar contrast agents, the drug tends to stay in the patient a little longer. We have done a small study. Unfortunately, I don't have the paper right now because we haven't published it as yet. It is still in the preliminary stages right now. But this is an anecdotal evidence that I'm quoting from my own experience. And we need to come up with the consensus guidelines is what I would have thought when it comes to conventional TACE. So this is a way of mixing the lipidol. And we have the drug-eluting beads or the DC beads or the Hepaspias. There are various types of drug-eluting beads available in the market. And there is a standardized protocol when it comes to mixing and making a solution and how you inject, etc., etc. There is a protocol for this. And so this is what it is, conventional TACE versus DEP TACE. There is no standardization conventional TACE, whereas it's standardized when it comes to DEP TACE. And the lipidol ratio, how much do you mix, is again one big question. If you ask each person, everybody will have their own answers. How much of lipidol do you take for a 2 centimeter tumor? How much of lipidol do you take for a 10 centimeter tumor? We all have got different answers. And again, the formation technique, the emulsion formation, whether you mix water to oil or oil to water, lipidol is a poppy seed oil. If you mix oil to water, will it mix? If you mix water to oil, will it mix? What mixes better? And that is what we need to understand when it comes to making the emulsion. And of course, we use different people have got different ways of embolization. As you all understand, TACE is 2 parts to it. There is chemo part and then there is an embolization part to it. So the chemo part is done by the cytotoxic drug like doxorubicin, or some people use mitomycin. There are various drugs that we can use. But when it comes to the embolization aspect of it, we have different agents available in conventional TACE. Some of us use gel foam, some of us use PVA particles, some of us use embospheres. Whereas when it comes to DEP TACE, that itself is an embolic agent, the drug-eluting bead. It's a bead which is embolic, and at the same time, it releases the doxorubicin slowly into the tumor. So again, there is a variability here. What do people use? Do you use gel foam or PVA or embosphere? So when people actually do these studies, when you look at the literature, have they really looked at this? There is a significant bias when it comes to looking at the literature, especially comparing conventional TACE to DEP TACE, because nobody actually has looked at what embolic agent was used. How did they mix up lipidol? Nothing was looked. So it's just comparing the conventional TACE to a DEP TACE. So I don't really buy a lot of things the literature speaks when it comes to comparing these 2 techniques. And So there are several drawbacks of conventional case that are associated with ineffective treatment responses in many cases. And sorry, I just need to, I'm stuck here. I'll just have to move this. Okay. And the liquid motility of the lipidol to reduce effective concentrations of the chemotherapeutic agent really matters. Sometimes, the inability to release the drugs in a controlled and sustained manner also matters. And finally, there is a heterogeneity in the technique and the treatment schedules as well. So there is no agreement also on the optimal anti-cancer drugs. Now, if you ask how much of doxorubicin do you take, again, there is no standard regime as to how much we need to take. The most widely used agent is doxorubicin, as we all know, and the ranges is from, it's from 30 to 75 milligrams. You can go up to maximum of 150 milligrams. You can emulsify in 5 ml to 20 ml of lipidol. Again, there is a significant variability when it takes to, do you take 30 ml of 30 mg of doxorubicin or 150 mg of doxorubicin? How much of lipidol do you take for each tumor? So there is a lot of variability when it comes to the conventional case. So a significant problem with the conventional case, therefore, is the inhomogeneity or the heterogeneity of the technique across the centers worldwide. And there are 2 RCTs which were done on conventional case, and they use 2 different technical approaches. So coming to the evidence and the data, there are 86 studies, or probably more studies on depth case, looking at the efficacy, looking at the tolerability, and the other factors as well. And we all know about the Precision-5 trial, wherein the objective response rate and the disease control rate was significantly better with the depth case than with the conventional case, especially with more advanced disease like a Child-Pugh-B, ECOG-1, if there is a recurrent disease, bilobar recurrent disease. So, and this is what Precision-5 trial has, has told us. And one of the advantages of depth case, I personally feel, is definitely the ability to use higher doxorubicin doses without causing systemic toxicity. And this I would explain in some of the cases as we go through some of the scenarios, depending on the time available for the presentation today. And there are several studies and there are several meta-analyses which were done, especially the 16 studies, 4 RCTs on 1830 patients. And this is what was demonstrated when it comes to the depth case versus the conventional case. And looking at the toxicity profile or the side effects in all these trials, there were lower doxorubicin plasma levels after the depth case. Yes, I agree that there can be lower doxorubicin levels after the depth case. And again, because it's a standardized protocol and the drug is not really released into the systemic circulation, but you can achieve the same. You can achieve lower doxorubicin plasma levels even with conventional case, provided you know the right technique, provided you know how much you're mixing, provided you know how you're emulsifying it. So Precision-5, again, it is the same thing, and the few studies actually show no difference, between the 2, conventional case and the depth case. So the literature is very confusing when you look at the conventional case and the depth case techniques. In the context of the liver transplantation, HCC in liver transplant candidates obviously is not very advanced, and the tumor necrosis is very, very relevant when it comes to downstaging for as a bridge to transplants. Tumor necrosis is very relevant, and there has been a retrospective study on 22 depth cases compared to 16 conventional cases. So people have looked at the explanted liver, and there was a trend towards more necrosis in depth case patients. And again, the tendency to more necrosis in depth case patients is probably because of I was talking about the capillary size, about the microns. We have really smaller particles. And again, you can achieve the same result with conventional case, provided you use smaller particles to reach the tumor bed. Most of the times we end up using gel foam, which is actually not a distal embolic agent. So when you use gel foam, it is going to occlude the proximal arterioles and it's not going to reach the capillary bed. So obviously you're not going to achieve different, you're going to not going to achieve necrosis with conventional TACE because people have got different strategies and different techniques. Whereas when it comes to depth TACE, you have a specific particle size, so it reaches the distal capillary bed and you can achieve better necrosis with depth TACE. So this is what it is. It's all about the ultra-selective TACE. So the distal you reach, more necrosis you have. In fact, I am a strong believer of the fact that it is a necrosis which actually causes the which is really important more than the cytotoxic effect of the tumor. So more than the chemotherapy aspect, it is the embolic aspect which really matters when it comes to TACE. And looking at the larger lesions. Now, I have a different take when it comes to larger lesions. Generally, if somebody has got a large patient, they require multiple sessions because it's virtually impossible to treat the entire tumor. If you have a 13 centimeter or 10 centimeter tumor, it's virtually impossible to treat that entire tumor in one conventional TACE sitting because we have a dose limitation when it comes to conventional TACE. The amount of lipidol that you can use probably would suffice a 5 centimeter or a 4 centimeter tumor. Anything above or 5 or 6 centimeters, the amount of lipidol, because you have a cap to the lipidol, you can only use a maximum of 20 ml of lipidol, and that is not enough to target more than a 5 or 6 centimeter tumor. Generally, the tumor size to the lipidol ratio is something like 4:1. So if the tumor is 2 centimeters, you're supposed to use at least 8 ml of lipidol. And if you have a cap of 20 ml for the maximum usage of the lipidol, then that would just suffice something like a 5 or a 6 centimeter tumor. You really can't exceed beyond 20 ml. So what happens is when the tumor is big, you really require multiple sittings. And if there are multiple sessions involved for large lesions, you would end up using higher doses of doxorubicin every time. You have to use either 75 or 150 milligrams of doxorubicin every time the patient comes in. So that is the reason why I feel probably DEP-TACE has got better advantage in patients with larger lesions compared to conventional TACE, and it is more appealing, and I would definitely buy that, and that's what literature says as well. So considering the results from these studies, there is still a controversy regarding the clinical outcomes. Yes, there is some difference when it comes to the adverse effects, but when it comes to the clinical outcome or the overall survival, there is not much of a difference between the DEP-TACE and the conventional TACE. It is similar efficacy in both the techniques. It's just that less of adverse events when it comes to the conventional TACE. So DEP-TACE may be favorable to conventional TACE for large HCCs, especially in those with compromised liver functions, even though there is a lack of evidence to say that DEP-TACE is superior to conventional TACE in terms of efficacy. So probably efficacy, if efficacy is not your concern, but it's adverse effect, as in elderly patients, some patients who are prone to more adverse events, in those cases, maybe you can consider DEP-TACE. But in India, we do have, the problem with the economy as well, because the DEP-TACE is definitely more expensive compared to conventional TACE, and we need to think about that as well. Then the major limitation of TACE, as we all know, this is generally speaking, is a high rate of cancer recurrence. In 2 RCTs, a sustained response was reported in only 20 to 35% of patients treated with conventional TACE. So do we go for combination strategies? This is something that we can talk about. So in advanced stage HCCs, we all know about, the combination treatments, especially the SHARP trial and then the Asia-Pacific trials, wherein, conventional TACE as well as the DEP-TACE shows better or at least comparable efficacy in patients with advanced stage HCCs when you actually, combine them with, sorafenib or any other, drug for that matter. Several RCTs have sought to determine the benefit of an addition of sorafenib to conventional TACE or DEP-TACE in patients with more advanced HCCs. And we did a study, when I was working at a different hospital on around 100 patients, wherein for intermediate stage HCCs and stage B and stage C, combination treatment with sorafenib and TACE had resulted in a better overall survival compared to TACE alone or sorafenib alone. This was our own local study that we have done, and that was something that I wanted to mention here. So in comparison with conventional TACE, DEP-TACE facilitates higher concentrations of drugs within the target tumor and lower systemic concentrations. And despite the theoretical advantages of DEP-TACE, it is still controversial in several clinical studies as to whether DEP-TACE is superior to conventional TACE in terms of efficacy. But DEP-TACE shows at least similar clinical outcomes and less adverse events is what we've been talking about. And in order to gain better results for these treatment modalities, we need to select the right candidates for DEP-TACE and conventional TACE, and we need more studies as always. And moving on further, and there is still controversial in several clinical studies if DEP-TACE is better than conventional TACE in terms of efficacy. It shows better, at least similar clinical outcomes. And larger lesions, definitely DEP-TACE, because they will require fewer sessions, better toxicity profile for larger lesions. And again, for liver transplantation downstaging, they say DEP-TACE is better. And again, I explained to you why DEP-TACE is better because of the particle size that we use in DEP-TACE. However, the same result can be achieved with conventional TACE as well. Now, moving on to TACE versus TARE, there are very few studies comparing DEP-TACE and TARE. This was one paper wherein the overall survival was better than DEP-TACE than TARE. So they say in this particular study that DEP-TACE is better than TARE. It's 15 months versus 6 months respectively. And again, I feel there are a lot of things that we need to consider when it comes to considering the patients for DEP-TACE and then the TARE, because there are a group of patients. The kind of patients that we get for TARE are usually with advanced disease or a portal vein thrombus. Sometimes you cannot compare that group of patients with somebody with an intermediate stage HCC. So this finding is inconsistent with the results of the Lancet study, wherein they said there was no significant difference between radioembolization and chemoembolization. So again, there's one more paper which talks that there is no significant difference in terms of the median overall survival between the depth days and tear after the treatment. So there are several strategies, and there are several, this is a meta-analysis or a pooled data wherein the primary outcome was overall survival and the secondary outcome included complete response and the local recurrence. And what did this particular paper say? They said the comparison of tear when compared with conventional TACE indicated that tear has got a better overall survival than conventional TACE at 2 years and 3 years. And the comparison of depth TACE with tear indicated that depth TACE has a better overall survival than tear at 2 years. And again, after going through all this, actually, it gets very confusing because the current meta-analysis suggests that depth TACE is superior to both tear and conventional TACE in terms of the overall survival. But I have my own explanation as to why depth TACE is superior to conventional TACE. It's because of the subjective variation or the variability. And this is a paper, the pooled analysis, wherein it shows that the depth TACE is better compared to tear. And undoubtedly, tear has got significantly lower complications. Contrary to what people actually think, tear has got definitely lower complications than both depth TACE and conventional TACE for patients with HCC. So the no surprise conclusion is further multi-center, well-designed randomized control trials are needed, especially for evaluating depth TACE versus tear. But before that, I would have thought we need to come up with more standardized standardization of the protocol for conventional TACE before we compare conventional TACE to tear or depth TACE. I'm just going to go through very few cases so that I can explain the scenarios better if there is time. How do we choose scenario one? I'm just going to go through one case wherein, let's say, somebody has got a large HCC, which is about 10 centimeters. Let's say this is in segment 8 of the liver. It's a 70-year-old patient. Child B ECOG is less than 2. And what do you consider in that particular patient? So I would have thought I would choose, as I said, it's a very large lesion. Either you go for tear in this particular patient, or you can go for TACE. But if you go for TACE, rather than a conventional TACE, I would have thought depth TACE is probably better compared to conventional TACE, because the patient is going to require multiple sittings, and so that would require, that would end up with higher doxorubicin dose. So better to go for a depth TACE in this particular patient. Scenario 2. Let's say somebody has got 3 lesions, 2 to 3 centimeters, 2 to 3 centimeters each, and the patient is 45-year-old, and let's say a couple of lesions on the right side and few on the left side. So basically, it's a multifocal bilobar disease. Child B ECOG 1, something like this. I would go for conventional TACE in that particular scenario rather than go for a depth TACE, because a depth TACE, you need to virtually go in and, we have to be very, very super selective, and then the lesion is very small. If you are not really sure about the arterial supply, if you cannot reach super selectively, then better to avoid depth TACE in such cases, because if it is multifocal, widely distributed, then I wouldn't choose a depth TACE. I would just go for conventional TACE. It's a lot more safer because you wouldn't cause liver necrosis. Large liver necrosis is not possible with a conventional TACE as opposed to a depth TACE. Scenario 3, a large 12 centimeter lesion, no extra hepatic disease or a portal vein thrombus. Patient is only 52 centimeters, ECOG 1, child A. You can just go for a combination treatment with ablation or depth TACE. We have done several cases like this wherein there was a large lesion. In those cases, we have done combination of a conventional TACE with microwave ablation, or just a depth TACE alone, or we can even do depth TACE with microwave ablation. Because if there is a large tumor, if you want to just do conventional TACE, as I said, they're going to require multiple sittings. So what we can do in those cases is you can actually burn off the central part of the tumor with microwave ablation. A microwave ablation can handle up to 6 or 7 centimeters of the tumor, and the peripheral part of the tumor can be targeted using conventional TACE, all in the same sitting. This happens while the patient is in the cath lab, in the same sitting. We're not going to ask them to come back again. So it's more patient-friendly procedure, I would have thought, and we've had very good results for larger lesions like this. So scenario 4, if it's an infiltrative HCC, multifocal.
Dr. Deepa, sorry to interrupt you. Our time is up. So can you please wind up 1 minute?
Sure. So this is the last scenario that I'm going to explain, and I'll wind up. So in scenario 4, if somebody has got an infiltrative HCC multifocal with portal vein thrombus, ECOG 2, child B, 30-year-old patient, you would probably go for either depth TACE plus Sbrt. I know there were a couple of talks on Sbrt, so you can just go for a combination of depth TACE plus Sbrt, or tear, wherein you can just treat the dominant part of the liver with tear, and you can consider depth TACE later on. Thank you so much. This was the last case. Thank you.
Thank you, Deepa, for wonderfully highlighting all the three techniques and how to use which one in which set of patients and what is the comparison between each of them. So I'm sure it will add to an important modality of treatment in all these patients. At the end of this session, we would have a discussion where we would take up questions related to this talk. Over to Dr. Dhiman for introducing the next speaker.
Thank you, Dr. Usha. And the next speaker is Dr. Shivanand Gamnagati. He's a professor in the Department of the Radio Diagnosis, All India Institute of Medical Sciences. And the next talk is very good talk, and that is the combinations of radiological modalities of treat hepatocellular carcinoma, and what is the evidence and what are the recommendations that we would like to listen from Dr. Shivananda. Please, the only thing that I would like to say to the speaker, please do not exceed the time limit that has been allotted to you. Thank you so much.
Thank you, sir. Good afternoon, all. I hope you are able to see my slides.
Yes, please go ahead.
Yeah. Okay. At the outset, I would like to thank the INASL for a kind invitation. So next 15-20 minutes, I'm going to cover the combination of radiological methods, and let us see the evidence and the recommendations. So this slide is very well known to everyone. So we have two treatment modalities. One is the ablation, another is the TACE, which are most widely used treatment modalities for the treatment of TACE. And however, there is no recommendation, no suggestion regarding the combination treatment by the BCLC platform. Also, we have a lot of societies like ASLD and APASL or ESL. None of these societies make any recommendation regarding the combination treatment. Let us see why there are no recommendations. So already the earlier two speakers, they have beautifully covered about the ablation and the TACE. So just to summarize, the RFA is well suited for the lesions less than 3 centimeters, and the lesion should be away from major vessels. If the lesion is less than 3 centimeters, if it is adjacent to the major vessels, microwave is preferred over the RFA. And for the lesions for the size more than 3 centimeters and up to 5 centimeters, and again the microwave is preferred. The upper panel of the image showing the ideal lesion amenable for the RFA. The lower panel showing a lesion which is close to the IVC and the hepatic vein. So it is ideally suited for a microwave. These are standalone treatments. So whether you are considering the RFA or a microwave for the treatment of HCC, two important factors influence the treatment results. The first factor is the heat sink effect, which is possible. One of the problem with the RFA, wherever the tumor is very close to the large blood vessels, more than 2 to 3 mm diameter, may have an incomplete ablation. And the second factor is the untreated microvascular invasion, which is not appreciable on the imaging. So these two important factors may lead to incomplete ablation and the early recurrence. So these are the problems with the ablations. Coming to the TACE alone, which is recommended for the lesions more than 5 centimeters or the multifocal disease. So where I will not go into the details. However, having said that, the ablation and the TACE, they have mostly used techniques, but they have their own deficiencies, which are responsible for the local recurrence. When we consider ablation alone for the tumors more than 3 centimeters, which may have an incomplete ablation and responsible for local recurrence. And for the TACE alone, since the TACE alone may have a necrosis rate is very low, and again, which is responsible for the intrahepatic recurrence. So as a standalone treatment, both TACE and as well as the ablation, they have their inherent deficiencies, which will lead to the recurrences. And for theoretically, what we can say that the combination treatment, the ablation along with the TACE, could improve the treatment outcome by having a better tumor control. Let us see we are true or not and see the evidence. When I speak about the combination treatment, it refers to the TACE plus ablation and comparing this combination treatment with the ablation or alone or a TACE alone. This is, I will show one or two cases what we did our institute. This is a 4.5 centimeter lesion in the segment 6, which was treated with a RFA followed by a TACE. So we can go RFA followed by TACE or a TACE followed by RFA. Each has its own benefit and rate of preference. And this was a 5 centimeter lesion in the segment 8, which was treated with TACE followed by microwave, achieving a complete response. So both these cases are, the lesions are about 3 to 5 centimeter wide. So how the combination treatment works? When we use a TACE prior to the RFA, what it does, it blocks the blood supply to the tumor and minimizes the heat loss. And thereby it also enhances the area of the coagulative necrosis. By doing so, what you are going to achieve is that you are going to destroy the unidentified satellite lesions, one. Second, and also the undetected microvascular invasion that also comes into the ablating area, so that you will have a better tumor control and better survival. And if you do a RFA followed by TACE, you are doing a RFA first and followed by TACE. After that, what you doing a TACE after the RFA, what it does, it enhances the deposition of the chemotherapeutic drugs within the tumor, and thereby you will have a better tumor response. So this is the principle how this combination treatment works. So what are the advantages when you consider this combination treatment as a regional treatment? So sometimes you do a TACE, although the initial imaging may miss some of the sub-centimeter, very small satellite lesions. So by doing TACE, you are able to identify, when I say about the TACE, it is about the conventional TACE, you are able to identify some of the satellite lesions, which can be included in the same ablating zone in the same sitting of the ablation. So thereby you are going to enhance the ablating area, and so that the entire satellite lesions, they are included in the same ablating zone. And second one is that the ablation, since you are going to ablate the tumor with an area of 5 mm all around in order to get a R0 margin, so unrecognized microvascular invasion also comes into the ablating zone, so that you will have a reduced tumor recurrence and prolonged survival time. So these are the main advantages. Whereas the disadvantages or challenge is that by doing a combination treatment, because you are going to initiate a additional treatment, it is going to add to the cost, additional treatment time, and maybe an increased risk of complication. So these are the challenges. So now coming to the data or meta-analysis, this is one of the latest meta-analysis comparing the individual treatment with the combination treatment. So there are 21 studies, they were included, only 3 RCTs, and 18 studies were retrospective studies. That is one of the problem with this combination treatment. So among the 21 studies, they included 3,413 patients. The 12 studies compared the combination treatment with the TACE alone, and the 9 studies compared the combination treatment with the RFA alone. When you are comparing the combination treatment with the RFA alone, they included 1,273 patients, and the combination treatment has a better, longer overall survival and recurrence-free survival as compared to the RFA alone, and also there is no major difference in the complication rate. And when you are comparing the combination treatment with the TACE alone, they included 2,339 patients. Combination treatment has overall better survival as compared to the TACE alone, but the catch is that the combination treatment also has got a lower death rate as compared to the TACE alone. If you are taking only a TACE alone, so that is going to have a more death rate as compared to the combination treatment. Again, they have in their meta-analysis, they have subgrouped the analysis for the tumors 3 to 8 centimeters. So they analyze the combination treatment with a TACE or RFA alone. In this subgroup, for the tumors more than 3 centimeter or tumors of 3 to 8 centimeter, the combination treatment has a better overall survival and a recurrence-free survival as compared to the TACE alone and the RFA alone. So no doubt, For the lesions more than 3 centimeter treatment, according to this meta-analysis, the combination treatment is the way. Whereas when it comes to less than 3 centimeter, the combination treatment did not show any better overall survival or recurrence-free survival when you compare it with only RFA alone. Whereas the combination treatment has a overall improved survival or a recurrence-free survival when you consider only TACE alone, comparing it with the TACE alone. So if you consider a combination treatment or RFA alone for less than 3 centimeter, no statistical difference. But if you are comparing a combination treatment with a TACE alone for less than 3 centimeter lesions, though the combination treatment is much better than the TACE. The summary of this meta-analysis is that the combination treatment might achieve a better outcome compared with the TACE alone or RFA alone, and there is no increased risk of major complication when you add additional treatment. However, this meta-analysis lacks a high quality RCTs, and most of these studies they belong to the Asian countries, and also it is not applicable to the entire world populations. So we need a more RCTs to have a evidence. Coming to the another meta-analysis comparison, only there are very limited studies comparing the TACE with microwave, the TACE alone. In this study, they compared the TACE with a microwave, used a microwave along with a TACE in 23 patients and TACE alone in 24 patients. So they included tumors of 3 to 5 centimeter size. And at the end of this study, they concluded that the complete response rate with a combination treatment is very high of 65%, whereas TACE alone it is 37%. Another comparison, the combination TACE with RFA versus TACE with microwave, what we can call is a TR versus TM. There are 8 cohort studies, retrospective studies, 1 randomized prospective study. And in the TACE with microwave, they included 295 patients, whereas TR group 238 patients. In fathers, they concluded that the TACE with microwave had a better overall survival and complete response rate for the lesions more than 3 centimeter and younger patients as compared to the TACE with RFA group. So now current with existing evidence, the majority of the studies which are reported or published, these are all retrospective studies. Only 3 RCTs are there. So now the current evidence level of evidence is 2B and the grade of recommendation is B. Hence, it is overall in all the societies or in the BCLC staging system, it is currently not included. Still, we need a high quality RCTs. So to conclude, that the combination radiological treatment for HCC is still, the evidence is evolving. We need a high quality RCTs across the world. And however, having said that, with the existing data, the combination treatment offers a better tumor control and the overall survival as compared to the individual therapies or TACE alone or RFA alone, especially for the lesions 3 to 5 centimeter. So whenever we have a patient having a HCC of 3 to 5 centimeter, not suitable for resection or a transplant, may be considered for the combination treatment over a TACE alone, RFA, or a ablation alone. So I will leave with a slide, thought-provoking slide. So now we have imaging features which can predict the microvascular invasion. There are imaging, MR can predict the microvascular invasion. Also, there is a lot of data where the tumor size, with increasing tumor size, we have an increasing incidence of microvascular invasion. Also, we have a tissue biopsy markers and the serum markers, which are associated with the microvascular invasion and the microsatellite lesions. So whenever we have a combination of these features, so one has to be very aggressive in treating those patients. So this is the area where combination treatment is going to play a vital role. So this is the final slide. Thank you for patient listening.
Thank you, Dr. Shiva. Excellent presentation, very crisp. All the data has been presented and your conclusion is really excellent. Now over to Dr. Usha. Kindly introduce the panelists and start the discussion I'll chip in.
Thank you, sir. We have an esteemed panel for discussing the various modalities which can.
Sorry, Dr. Shiva, can you stop sharing your slides? Thank
Yes,
you.
sir. Sorry. Okay.
We have Dr. Manoj Sahu, who's a professor and head from the gastroenterology and the hepatobiliary sciences from Bhubaneswar. Dr. Sandeep Dhawan, who's a senior consultant gastroenterology and hepatology, and also president of the gastroenterology and the liver forum from Chandigarh. We have Dr. Madhumita Prem Kumar. All of you know her very well. She's an associate professor in the Department of Hepatology at PGI Chandigarh. We have Dr. Narendra Chaudhary, senior consultant hepatology from Medanta Medicity, Gurugram, and Dr. B.S. Rana, professor at Department of Hepatology and Gastroenterology from Tanda. Welcome all to all the panelists and all the speakers for this session. With this, we will open the discussion to the house. We will invite questions from the audience and also the panelists to handle the discussion so that we leave the audience with a clear picture as to what to do and what are the what should be the basis for choosing one therapy over the other. And just to remind, we have only 10 minutes for this discussion because we are running out of time. That's what I've been told by the organizers. So do we have any questions from the panel or to set the ball rolling? I would think that I think it has come, a time has come where we have a tumor board only for HCC, where we have the radiologist, the surgeon, the hepatologist, gastroenterologist as a part of the team, which can sit together and decide for each patient, individualize what is the best medicine. Because today is the day of precision medicine. If not the genomic component, minimum the radiological features and the clinical features can be put together to give the best treatment what is available today. And I think the site size of the tumor and the position of the tumor and the underlying liver status go a long way in deciding what treatment we should give, apart from the expertise available locally. I would request INASL to have a forum on the INASL website where general practitioners who are seeing these people who are not experts in this area can consult, and maybe once every week we could have a tumor board available for people to consult in. And we also, after listening to Dr. Deepa, we realized we don't have a standard way of mixing the solutions. Maybe we can standardize the way, we can have guidelines on that. I was thinking if we have a rotor for making that emulsion, it would give us a more uniform spread of the drug in these patients. And also the calculation of the dose, the radiologist can help us by telling us the tumor volume, and our calculation of dose can be more precise. So with these questions, I open the discussion to the speakers and the other panelists.
Ma'am, one question to Dr. Naveen. Sir, what is ideal size for cryo? And when will you consider cryo or other modalities?
Yeah, thank you, Dr. Narendran. So the answer to that one is like cryo ablation actually, as you are also aware that at one time had almost gone out of repute because of the side effects, and it's now coming back. And if you look at the literature, the size that most of the people have used cryo for treating is up to 4 centimeters again, and not larger than that. As far as the advantages are concerned, one is you can do it under local anesthesia. You can do it under the patient cooperates for the procedure. There is very little pain compared to the other ablation techniques. So as far as the recommendations for cryo, you look at literature, there are no objective recommendations that you could use here in particular situation. But the advantage we have seen in our practice is that it is safe when we use cryo adjacent to, because it doesn't affect the collagenous network. So you can use it even close to vessels now, and you can use it close to the capsule. So if we use we use it when it's close to the capsule. The reason being we do not have to create artificial ascites, and the patient, because the capsule, even if it is stretched by the thermal techniques, there is a lot of pain. But when it is stretched by the cryo technique, the pain experienced by the patient is less. And that's the reason why we have now started using cryo for these subcapsular lesions. So,
Dr. Naveen, I have a question to you.
Sure.
Yeah. your department has the luxury of having all the modalities in the Department of Radiology, PGI.
Sure.
But such luxury would not be available elsewhere also. And some department is already having the microwave in addition to the facility for the TACE and the tear. So what do you recommend? What should be the next facility available to cover the maximum number of the patients?
Okay, so if at present you have ablation technique, institute has to opt for an ablation technique in the present scenario today, I think they should go for a microwave ablation, because using that, even you can treat lesions even if they are away from a vessel. It is recommended for treating close to a vessel. That doesn't mean that it won't work for lesions which are away. So it works better in that location as well. So microwave is the modality to go for if you are opting to start a new ablation at any facility presently. And by using techniques like artificial ascites, you can inject and push the vital structures away. You can treat most of the lesions that are seen up to 3 centimeters or even larger than that with microwave ablation. So using that, if one technique is to be opted for at any place, go for a microwave ablation by. The only problem you may run into would be a location, as I showed you, a higher location, which you would be very, experience some difficulty in ablating areas.
What would be the next part? What should be the addition to the microwave? The next addition to the microwave.
Well, is in the ablation techniques, or are we looking
only
at
in the ablation techniques?
Well, in the ablation techniques, if we are looking for the next buy, then that cost effectiveness may not be there, but that's IRE. So if you are that's the for location. So you can do away with cryo. Those cryo scenarios you can still take care with the thermal ablations with microwave. But that's very small subset of patients, may not be a very logistically a very economically viable venture. But there are situations where you would want to do IRE, especially the central lesions.
Thank you, Dr. Naveen. Over to Usha.
Dr. Naveen, as Dr. Dhiman said, you have a luxury of all the modalities with you. So what's your take on the combo therapy in your department?
Sir, I think Dr. Shivanand has very rightly highlighted. So if you're looking for a 3 to 5 or 3 to 6 centimeter lesion, the best would be to go for a combination of conventional TACE with microwave ablation. So that is if we are looking for a combination therapy.
Yeah, thank you, Dr. Naveen. Dr. Madhumita has posed a question. I'll ask Dr. Shiva to take it up. What biomarkers or clinical parameters does a radiologist look for while deciding on a modality? Can we be brief in the answer, please?
Clinical markers, we follow all the BCLC staging system at our institute in deciding the modality. And imaging markers, the other question was, what was that, madam?
Clinical markers and biomarkers.
Biomarkers, we are just doing alpha protein, nothing else other than that for the looking at it. But at our institute, for the treatment modality, we are taking a BCLC staging all the criteria into account.
Yeah, she also has one more question for you. What is the gain time for yttrium-19 tear versus the rhenium tear and the cost difference?
Yeah, I've already answered, madam. I've already answered. The tear is the rhenium. We are doing a rhenium-based tear at our institute. The cost of the rhenium is 0 because we are getting free of cost. Only the cost of the hardware cost. And the benefit, there is no head-to-head comparison between the rhenium and the yttrium. The yttrium has additionally many advantages over rhenium. Rhenium technique is very, very simple. You can go and inject non-selectively, just like a conventional TACE. There is no specialized technique involved. However, there is no head-to-head comparison. What is the benefit we are going to get? So it needs a large studies or a sample size to make a comment about it. But the cost is, the rhenium is essentially the cost of conventional TACE. That's it.
So is it more cost effective to offer a rhenium tear in a in a resource?
No, because the problem with the rhenium is that the generator we get extra rhenium from the radionuclide. So initially when the generator is fresh, you are going to get high dose. So that time you are going to get a good response. Over a period of time after 3 months, the extraction, the amount of radiation dose you are getting is very less. So you have to be very accurate all your patients within 3 months and do it. So during that time you are going to get a good response rate.
Thank you. Question to Dr. Kalra. What is the role of tissue diagnosis in estimating the outcomes?
Yes, so I think what that question is by Dr. Madhumita again, if I can see in the chat box. So I think she's looking at a very important aspect of loco-regional therapy, which I am personally also feel could be the in thing in future, and that's precision loco-regional therapy, and which would probably rely more on the tissue diagnosis as well as the biomarkers that we can, there are some studies looking at the inflammatory biomarkers, the neutrophil lymphocyte ratio and the platelet lymphocyte ratio and the cytokines, and they, on the basis of that pre and post evaluation, they have tried to predict the responses with TACE. So at present, definitely it is not the clinical practice to do all these tissue biopsies and biomarkers, but I think in future, again, we are probably looking back at some kind of precision treatment where these kind of evaluations would determine our outcomes and our choice of therapies.
Yeah. I'll now move to another question from the tech team. There's Dipti Sharma who has asked, a large tumor more than 12 centimeter with portal vein thrombosis, tear or Sbrt. So can Dr. Shivanand take this question?
Hello.
You need to unmute yourself. Yeah.
Okay. So the for 12 centimeter lesions, so we at our institute we use a TACE plus the systemic chemotherapy. We individualize these patients. We don't restrict to ourselves only the radiological treatment. So we go for a combination treatment along with the systemic therapies like TACE plus the systemic chemotherapies.
Dr. Usha, can I ask a small question?
Sure.
Yeah, I think just a small question. Before that, I would like to congratulate, I think, all the 3 speakers for wonderful presentation. I think very nice. A very small question to Dr. Deepa about, she said about, the larger lesion, the choice between conventional and DAP TACE, the DAP TACE would be better. Because in convention for larger lesions, you have to do multiple sessions. My question to you is, what is your experience of post-embolization syndrome in larger lesion with DAP TACE versus conventional? I mean, we have seen sometime in larger lesions, when you do DAP TACE, we see more of post-embolization syndrome in comparison to conventional. So what's your experience on that?
Please unmute.
Thank you for the question. So when it comes to the post-embolization syndrome with DAP TACE, as far as I could see, I couldn't see much of a post-embolization syndrome. However, the tumor necrosis is significant with DAP TACE. So what we have seen is most of them, they came up with liver abscesses later on. Of course, a sterile liver abscess, there was a complete necrosis that later on they come with some abdominal pain, because whenever there is an abscess, it expands, and then patients complain of abdominal pain with a low-grade fever. So this is what I have seen, but not in my experience that I had seen post-embolization syndrome in those patients.
We are coming to the end of this discussion. The last question to Dr. Deepa is there a role of other chemotherapeutic agents other than doxorubicin?
Yes, cisplatin can be used, especially when you want to do TACE for neuroendocrine tumors. Cisplatin has got a better, advantage over doxorubicin when you want to treat neuroendocrine tumors with TACE. But my experience is limited when it comes to HCCs with regards to the role of other agents.
Thank you. And with this, we come to the end of this session. I request Dr. Dhiman to give the concluding remarks.
Dr. Usha, I think all the 3 speakers, they have spoken very well. As far as the review is considered, that is absolutely up to the mark. And the recommendations and the subsequent discussions have clarified the many issues also. So I won't add much what has been said earlier also, and what the recommendation have been discussed also. I really thankful to all the speakers. And lastly, I am thankful to Dr. Ajay Duseja for organizing such a wonderful meeting and for the invitation also. Thank you, Dr. Duseja. Thank you, Dr. Usha, and thanks all the 3 speakers and the 5 expert panel experts. Thank you so much.
Thank you, sir. Thank you, everyone.
Thank you. Thank you.
Thank you so much.
So thank you, sir, for this wonderful session. And we move on to the next session on the surgical management of HCC. And for this, I invite the chairpersons, Professor Arunanshu Behra. He's the professor and head of general surgery in PGI Chandigarh, and Professor Dr. Epan, professor and head of hepatology at CMC Vellore. Sir, please. Sir, please unmute yourself.
Okay. Yeah. Am I being heard?
Yes, sir.
Okay. Welcome, everyone. This is a very interesting session. I mean, there are 2 sections as I see. One is about hepatic resection, other is about the presence of EVTT and for and against a debate. And I invite my co-chairperson, that is Dr. Epan, Professor Epan, if he is around. Welcome everyone. This session is about surgical resection and HCC. And the second part is about the debate about resections or surgical resections, whether we have to go for it or not go for it, in whether when there is a portal vein thrombosis. Now, there are no prospective studies in this portal vein thrombosis and surgical resections, but anecdotal cases of and certain reports coming out that overall survival is increasing with resections. That too, when the second order portal veins are involved. So people have expanded their criteria to the first order or the main portal vein thrombosis, tumor thrombosis, and they have started resecting. And the debate is very open. I mean, at present, there is no conclusive evidence that it benefits. Anecdotally, there are overall survival has increased in certain centers. So with this, I invite the first speaker, Professor Subhash Gupta, for his talk in hepatic resections for HCC. And from here on, the panelist and my co-chairperson will take over for any further comments or additions. Thank you. Okay.
Dr. Subhash Gupta, you can share the slides.
Okay. I was just waiting for a cue. Can you see my slides?
Not yet.
Not yet, sir.
Huh?
Not yet, sir.
Oh, what's wrong then? I have shared screen. I've done it. Share.
Okay, now you can see. Yeah.
Now you can see. No? Okay.
You can make it full screen.
Yeah, I'm doing that. Thank you very much for inviting and asking me to speak on a very favorite topic of mine, which is hepatic resection indications and outcomes. At the outset, I would like to say that I have no financial conflict of interest, but with the frequency of Zoom meetings, I think we may need to sort of give some enticement so as to carry on being able to participate in these talks and lectures we take so much time to prepare. So the background of my talk is that curative treatment options for HCC are resection and liver transplantation. And these are sort of from long periods of time, in spite of many discussions of ablative therapy and TACE and others. The accepted curative treatments are resection, liver transplantation. Of course, for smaller lesions and for bigger lesions, local ablation therapies and TARE may be equally effective. Unfortunately, what has happened in our country the focus has shifted to transplantation because surgical resection and cirrhosis is difficult. Post-liver hepatectomy, liver failure is often a fear. And we all know if the patient lives long enough after resection, recurrence are bound to happen. So but there are some situations where resection is perhaps maybe the only option or the best option. Tumors in non-cirrhotic livers or HCC in child's acirrhosis, or when it is outside a center's criteria for transplantation, patients are elderly would not therefore qualify for transplantation, but otherwise well preserved. When associated with portal of venous tumor thrombosis, when alpha fetoprotein or PIVKAs are high, or as we do quite often nowadays as part of downstaging strategy for liver transplantation later on. So obviously resection in non-cirrhotic livers is an easy choice to make because the remnant liver volume is never a concern. Hepatitis B infection, we know cirrhosis can sometimes be absent. With hepatitis C, we know that cirrhosis is almost always present at the time of diagnosis of HCC. An important point I would like to make here, particularly to our physician colleagues, is that if we face hepatitis C infection and HCC sort of for the first time in a patient, then perhaps the treatment of hepatitis C should be deferred after adequate tumor control has been achieved. So with resection, large tumors can be resected. As you can see, this one is a tumor that is occupying most of the right lobe, and we use what we call the anterior approach. You don't mobilize the right lobe at all, otherwise it will rupture. And this, as you can see, is a nice and capsule around it, and these tumors do well. And ipsilateral vascular exclusion techniques would be helpful in minimizing blood loss. Now, that is, so resection in non-cirrhotic livers, any size could be resected, provided, of course, and they always have adequate remnant. Now, HCC in cirrhosis, now there's a debate all the time whether resection or transplantation, which is best, but I think both are equally applicable. But of course, if you choose resection, then you must assess for post-hepatectomy liver failure. And generally speaking, although there's a myriad the number of tests and ICG clearance, but a bedside parameter that has withstood the test of time is a platelet count greater than 100,000, no ascites, bilirubin less than 1.5, remnant liver volume more than 50. And of course, if you're in any doubt, living donor liver transplantation is always there for these patients. So if you look at resection versus transplantation results and the advantages and disadvantages and pros and cons, then resection, hardly any waiting time, transplantation, waiting time. Although LDLT, this says there is no waiting time, but in reality, there is always a waiting time because donors, to look for donor, it's not that easy. Recurrence rates are higher with resection. Liver failure rate is higher, but at the same time, you can have graft failure if you choose transplantation. Immunosuppression would be needed in transplantation, and 5-year survival, of course, much better with liver transplantation. But if you look at sort of intention to treat analysis, and there's a number of studies in this that found that initial resection did not give comparable results, provided you were aggressive with follow-up and did what is called salvage transplantation if there was recurrence. So that was, so we had resection for sort of non-cirrhotic areas, resection in cirrhosis, and also you can resect when clearly the tumor is outside the transplant center's criteria. So Milan and UCSF are widely accepted. So without going into long discussions on what criteria is appropriate, I think most centers will choose their own centers, and most centers will definitely not transplant people who have extrahepatic disease or have high AFP or PIVKA values, those with portal vein tumor thrombus or cholangiocarcinoma variants. And so once you've done resection, does not preclude transplantation later on. And if you combine all these things, then the overall survival between primary transplantation versus resection and salvage transplantation for those who reoccur are similar. So now I'll take you through some interesting resections that we've carried out. So this is a cirrhosis, and you can see the portal vein tumor thrombus. So we've gained control of the left portal vein, main portal vein and right portal vein, and we've done the resection, done a tumor thrombectomy. This is about a year ago, and with improvement in liver function. Then we've used multimodality approach to large hepatocellular carcinomas. This is, as you can see in the MR scans, large tumor in the right lobe, cirrhotic background, 66-year-old male, which is not a living donor transplant candidate. So had TACE followed by Sbrt, then was an lenvatinib. The AFP came down from 33,296, and post-TACE you can see there's sort of some enhancement, but a residual tumor in the right lobe. And he went on to have a right hepatectomy, partial excision of the diaphragm. As you can see, this right lobe tumor is invading into the diaphragm. Then We had another 78-year-old lady. You can see a large tumor with a portal vein tumor thrombosis. You can see there's a lesion at the periphery, and then there's a sort of thrombus going onto the portal vein. So this underwent a anatomical segment 8 resection with portal vein thrombectomy. We sucked out from the portal vein. So that's the sort of portal vein end with the thrombus in it. Then this is someone, a 69-year-old gentleman. Interestingly, he was from Chandigarh, and he had a segment 2-3 lesion with a bile duct tumor thrombus, as you can see here. And again, high AFP, so underwent a sort of, because of cirrhosis, and he underwent what we call a segment 2 and 3 pedicle ligation. So the segment 4 was preserved, didn't become ischemic, and we then sucked out the thrombus from the bile duct. And this is sort of the after the resection, and we can see the big opening in the bile duct from which the thrombus has been sucked out. So this the reasons why I included these slides are because portal vein tumor thrombus may result in ascites, and that should not be regarded as a contraindication to resection. Successful thrombectomy will improve liver function, and ascites therefore should not come in the way of resection. Similarly, bile duct tumor thrombus will cause a rise in bilirubin, and operative resection and bile duct tumor clearance will actually improve liver function. There have been certain fallacies with the current staging system in which lesions like this, such as intermediate and advanced stage lesions, are not allocated for surgical treatment. Stage B is really a heterogeneous group in Barcelona liver cancer clinic staging, because it contains many which sort of who may actually be suitable for resection. And it's also important to remember that poor performance status may not be an independent factor, but may be a result of the disease, and also does not look at center-specific data. So therefore, in the current staging system, resection has not been given due importance. Of course, what I like the most is the Italian liver cancer staging system, which actually tells you what will happen if you choose a particular treatment. For example, you choose supportive care for a local lesion, less than 2 centimeters, you would have 31 months survival. Whereas if you chose liver transplantation, you'll get 120 months survival. And similarly, in the most advanced category, where best supportive care would only give you 3 months, whereas liver transplantation or liver resection would give you much longer time. So this category, which I'm really keen on, is the intermediate category, where liver resection may have a meaningful role, and the 1, 3, and 5 is survival. This is from Wei Liu, the Chinese very aggressive HPV surgeon, reported a 5 is survival of 53% in this intermediate to advanced group. And of course, liver resection has come of age, and you can actually do liver resections without mortality, as Makuchi published way back in 2003 with 1,500 consecutive liver resections. So for the outcome part, what I've done is I've looked at not the HCC resection in the entire population. I actually looked at our patients who had cirrhosis as well as HCC, and we looked at 2 time periods between 2007 to 2017, and the second time period was 2017 to 2021. And of course, sort of with the increasing experience, in the first 10 years, we did only 36 resections in HCC with cirrhosis, but later on, we did sort of in the last 5 years alone, we've done 43 major liver resections in cirrhosis. The 2 groups were comparable, 2 periods, except that in the last 5 years, the number of patients with cryptogenic or NASH has increased to over 55%, whereas hepatitis B and C constituted the major proportion. They actually contributed about 80% of the HCCs in the earlier lot. And there's been also, in spite of more complex resections, sort of the mortality rates have actually been lower, and we've reduced the number of non-anatomical resections now, mainly because they lead to ischemic segments, and ischemic segments can contribute to sepsis and post-hepatectomy liver failure. And we also looked at overall liver resection and compared them their outcome in those who are above the age of 65 years of age. In our center, those who are above the age of 65 years of age will not be offered living donor liver transplantation, and therefore they often become candidates for liver resection. And there were sort of 102 patients in those who were less than 65 and 57 in those who were above the age of 65. And again, there was no significant difference in mortality in the two groups. Unfortunately, we didn't have follow-up for all the patients, but we had follow-up on 75 patients who, and in them the sort of survival, 5-year survival was 25%, 5-year survival in those who had surgical resection in both the groups, suggesting that if they're not eligible for transplantation, liver resection may be a good choice. Therefore, I'd like to conclude that resection in HCC can be curative. Viral causes for HCC are decreasing, but increased incidence with NASH in those with diabetes is indicated in subsets which may not be suitable for transplant. And many patients in BCLC intermediate advanced stage should be evaluated for resection. If LFT is normal, platelets are more than 100,000, remnant liver volume exceeds 50%, post-hepatectomy liver failure is minimal, and multimodality treatment will improve resection rates. And as I showed with one case, and of course there's been a Chinese study, case report of 10 cases were given tyrosine kinase inhibitors downstate and then underwent successful resection. Thank you for your patient listening. So if there are any questions, I can take them now.
Maybe we can have questions at the end. Maybe can we have the debate and the other talks first? Dr. Epan, can you invite the next speakers?
Thank you, Ajay. Thank you, Dr. Subhash Gupta, for an excellent lecture. I now request the next topic is the debate. The debate is on the issue of portal vein tumor thrombus in a patient with hepatocellular carcinoma, whether it's a contraindication for liver transplant or not. So to speak that it is an absolute contraindication, to speak for it, I invite Dr. Pamecha. He's a lead transplant surgeon at ILBS in Delhi. Dr. Pamecha, please.
And all the chairpersons. Can you hear me?
Yes. Yes, please.
Okay. Can you see my slides as well?
Dr. Pamecha, you can put it on the full slide mode. Yeah. Thanks.
You've got it now?
Now it's good.
Okay. So once again, thanks INASL for inviting me for this talk, and thanks Professor D'Souza, Sunil, and Professor Rao. So my job over the next 10 minutes is to basically see that whether it is worth transplanting patient with portal vein tumor thrombosis. So the way I see this this debate is more about whether it is good, bad, or ugly, and we'll come to the end of this talk whether it is worthwhile transplanting patient with portal vein tumor thrombosis or not. So just to start with, then if you look at the natural history of HCC, this is very important in the context of whatever treatment modalities we use to treat HCCs. There will be group of patients who will survive long in spite of not getting any treatment. So even though the median survival reported for BCLD C and D is very low, but still there will be a good group of patients with good tumor biology who may have a median survival ranging from 12 to 24 months. And that we always need to look into whenever we are seeing the treatment modalities being offered to the patient. So why we should not be transplanting patient with portal vein tumor thrombosis? So if you look at patients with profile of this patient, most of these patients, and when you divide them based on the tumor size, they have the alpha-fetoprotein levels are much higher in this patient compared to not having portal vein tumor thrombosis. They are more multifocal, even when they are smaller in size, that is less than 5 centimeters. If you take patient with a tumor size between 5 to 10 centimeters, again, the alpha-fetoprotein is much higher and multifocality is also much higher in this group of patients. And then if you take patients who are more than 10 centimeters, again, the alpha fetoprotein is much higher, and multifocality is also much higher in this group of patients. So what it means is overall portal vein tumor thrombosis is associated with larger tumor size. It is increased number of tumors are present in this group of patients. The tumor grade is higher. There is worse child class as well, and they are associated with higher serum alpha protein level as well. So what all this mean is they are associated with an aggressive tumor biology, and that is why the question comes why we should not be transplanting patient with portal vein tumor thrombosis. So what happens when you transplant patient with portal vein tumor thrombosis? And so this is a multi-center European data from 172 transplant centers and a large volume of patients of nearly 10,000. The macrovascular invasion was present in 3.1%, microvascular invasion was in 17.8%. And approximately 60% were inside Milan and 75 were up to this 7 criteria. And the median follow-up was 23 months. And you can see macrovascular invasion was associated with poor prognosis with a median survival nearly 25% at 5 years. And again, then if you divide the patient based on Milan and up to 7, again, this was associated with poor survival. Macrovascular invasion was associated with poor survival with a 5-year survival of nearly 30% in this group of patients. And if we move on to the live donor transplant, because this is an argument which is put on again and again, that in live donor, the waiting time is not there, so there is no progression of the disease. And because the patient will get quickly transplanted, so the survival will be better. But if you look at this is Korean data, again, large volume data as well. And the portal vein tumor thrombosis was present in 34 patients, and again, the median survival was only 50%. And this is overall survival, and disease-free survival was poor as well, around 40% at 5 years as well. And when we divide up to the extent of tumor thrombosis, again, the segmental portal vein thrombosis was not associated, was equal to the microvascular invasion, but when we come to lobar portal vein thrombosis, the survival was only 14% here. This was again overall survival and a disease-free survival as well. And this correlated with the alpha fetoprotein. Patient who had a higher than more 100 alpha fetoprotein, then the survival was poor as well in this group of patients. So moving on to other centers experience, this is similarly reported by the other centers as well. As the extent of portal vein thrombosis increases, your survival decreases. So in VP, if we take VP2 and VP3, 18% at 5 years in VP3 and VP4. Again, when we take main trunk, 3.7% at 3 years. When we take right and left branches, 5.2% at 5 years. So the more the extent of the portal vein tumor thrombosis, the worse the prognosis is. And that's why most guidelines, the European, whether you take the European, American, Apostle or Chinese, they all actually says that portal vein tumor thrombosis is a contraindication to liver transplantation. So then I'm sure Dr. Sayan will argue that the recent data is somewhat different, and these are all old guidelines and old data. So when we look at the recent data, this is from China, 75 patients. There is some improvement in survival in VP2 and VP3, but VP4 doesn't do well, and it is 21% at 3 years. This is data from Switzerland. Again, nearly 40% recurrence rate at 5 years. And most of these recurrences actually happen within a year as well. And this is Dr. Sayan's data as well. And again, you can see most of these patients are in VP2 and VP3 category, and there was recurrence, nearly 40%, 30% recurrence at 1 year as well in this group of patients. There was only one patient in VP4. And I'll actually talk about Dr. Sayan's data further in details as well. So is it really which liver transplant making the difference? That is the big question which comes in the context of the current data. And what has happened over the time, because of the newer therapies, the survival of this group of patients has changed. And this is some of the data which I have actually put up here. And you can see even patients with advanced disease, when they were offered combination therapy like TACE or levodopa, then the median survival actually increases quite dramatically in this group of patients. So when you combine radioembolization with sorafenib, the median survival goes up to 27 months. Then again, radioembolization, the median survival reported is 45 months. So if you're looking at the data on liver transplantation, we need to look into the context that the newer therapy itself actually are increasing the survival. And does the liver transplantation add to that survival? We don't know that. And it is whether just the liver transplantation is actually a better way of palliation at this stage. That is what the current literature will suggest. So there is no data regarding VP4 and downstaging for liver transplantation. VP4 and other modalities better survival or similar survival than LT at this stage. And even after downstaging, survival benefit is confounded with the downstaging treatment modality. So which we don't know whether the benefit is just gained by the newer therapies and LT actually on top add anything to the newer therapies survival benefit. So coming to Dr. Soin's data, again, most of these patients are VP1 and VP2. There are patients in VP3 as well, and there was only one patient in VP4, that is main portal vein thrombosis. And this was their protocol. I won't go into details of this protocol, but this is the survival they have reported. So what we got is nearly 40% recurrence in this group of patients, and most of this recurrences actually has happened within a year. And if you look at closely here in the table, only 15 have reached 3 years and only 7 has reached 5 years. So I'm sure as the follow-up of this patient will increase, more and more of this patient will have a recurrent disease. So we have an actual survival here. We don't have an actual survival to comment on that whether we should be upfront transplanting this group of patients or not. Then seeing more about this group of patients, the median alpha-fetoprotein at diagnosis and pre-LT was around 80 and 55 at the time of transplant. If you look at the median tumor size of this group of patients, it was nearly 5 centimeter. The median number of tumors were around 3 in downstage and 2 in with no downstage. And the grade of tumor, most of this are good grade of tumors. 80% are with a grade 1 and 2 tumor. And before liver transplant, most of them had a complete loss of FDG activity in PVTT as well. So again, coming to my same point, whether the newer therapies improve the survival and whether the liver transplantation has added anything to it, we don't know. And there was no significant impact on overall survival or recurrence-free survival in patients who had downstaging. And that was because in this group of patients, they have used a very short time to transplant. So after downstaging, the time to transplant was only 10 weeks. And the most literature will actually wait for 3 to 6 months before transplanting them. So these are a highly selected patient with good tumor biology and a fantastic response to newer therapy. So whether liver transplant added to the survival, we don't really know. And then if you want to transplant, you need a liver. And in DDLT, again, we got so many patients waiting. And to give livers to ones when we know that there is a very high recurrence rate, I don't think that is justifiable. Then coming to live donor liver transplantation, we can always argue that it's a dedicated gift. But would you like to give a dedicated gift to a patient with a 50% recurrence at 1 year? I'm not sure that is justifiable to take that risk in a live donor liver transplantation. And just to finish off, actually this is an HCC conference, and I'd like to highlight one of our papers in the context of Indian patient getting transplant. So this is around 600 patients of our own experience. And HCC actually only constituted 6.5% of the transplant activity. If you look at the world literature, it's around 25 to 30% of patients will be for transplanted for HCC. And out of only 40 had preoperative diagnosis, while 13 were incidental, and the median MELD was 18. This is without exception for the HCC. Okay. And only 10 of this had a primary indication for transplantation. Rest actually have undergone transplant for progressive decompensation. And 32 were up to 7 and 21 were outside the criteria. The 5-year survival was more than 80% with a recurrence-free survival of more than 80%. So the point here was to make with this slide was that the referral pattern for HCC need to change in India. We are not actually, the ones who can benefit maximum from transplant are not really coming to the transplant. Although this was out of the context of the debate, but I still thought an HCC conference deserved this point to be made. So coming to my conclusion, portal vein tumor thrombosis is associated with aggressive tumor behavior and poor prognosis. There are only small single center studies which have shown some survival benefit following LT in highly selected patients. Whether the benefit is because of LT or a better neurotherapy, we don't know, and the data is not really clear. It seems LT is just adding to the neurotherapy as a better palliation in the presence of portal vein tumor thrombosis, and tumor biology remains the king. And I think that it is bad to transplant patient with upfront with portal vein tumor thrombosis at this stage. Thank you very much. Hello.
Thank you, Dr. Pamecha, for this excellent making a point on the debate. And to talk on the contrary as viewpoint, may I invite Dr. Soin to speak against the motion that portal vein tumor thrombosis is an absolute contraindication for liver transplantation. Dr. Soin, please.
Okay. Thank you very much, Dr. Pamecha. Well, hello everyone, and thanks to the organizers for inviting me to talk about our experience with living donor liver transplantation for HCC with PVTT. I'm actually going to toss the same coin at you that Vinny presented. Just request you to look at the other side of it. So a lot of the slides and data are similar to what he's already talked about, including our own, of course. So I'll try and show you in the next few minutes how HCC with PVTT is not an absolute contraindication to living donor liver transplantation. Let's not even go down the deceased donor route, because obviously allocation priority cannot be given to these patients. So as soon as we see this, HCC with PVTT, we think that these patients are terminal and untreated. We all know that their survival is only a few months, 3 to 6 months, and hardly anyone reaches 3 years. Even in the BCLC classification and treatment guidelines, only tyrosine kinase inhibitors are suggested for these, again, giving an overall survival of somewhere between 7 and 10 months. ASLD, EASL guidelines, again, PVTT is an absolute contraindication to liver transplantation and also for resection. In fact, BCLC, NCCN, ASLD, EASL, Japan, Chinese guidelines, Korean, Taiwanese, everybody says that these patients should be treated with systemic therapy or TARE or TACE, and very selective patients can have resection. Now let's try and look at how this needs to be revisited in the context of living donor liver transplantation. What is portal vein tumor thrombosis? Again, Dr. Pamecha already alluded to that. VP1 is segmental. VP2 is also segmental thrombosis. VP3 is in the right or the left portal vein, and VP4 is in the main portal vein. Now, the first thing to understand is that is PVTT actually equal to systemic spread? And if it is, then this whole discussion is pointless. We should not be transplanting them. But the point is, PVTT does not necessarily mean systemic spread. Quoting the same paper that Vinny quoted, basically, even without downstaging, they looked at 11 patients who had had living donor liver transplantation, and these guys had achieved a survival of nearly 60% at 5 years. And of course, they found that people who had higher AFP or VP4 or tumor size of more than 7 centimeters or a high HV on PET Another paper which basically showed the same thing, 27 odd patients. These guys had segmental PVTT, no downstaging, and again, disease-free survival of around 50 to 60% was achieved. So let's be very clear. These are patients who've had liver transplant. There is no non-liver transplant therapy that has shown more than 50% 5-year survival in these subgroup of patients. So liver transplant does make a difference. Now, the second thing is that there has been enough evidence for the last nearly 10 years that radiotherapy in the form of stereotactic body radiation therapy or transarterial radioembolization results in significant complete or partial response and does improve the progression-free survival in these patients. So this is a study from 8 years ago where 41 patients had Sbrt and 31 and 39% of them had complete or partial response. 120 patients, 33% complete and 49% partial response with Sbrt. Then there are case reports which talk about external beam radiotherapy or transarterial chemoembolization with radiotherapy and then transplantation. And again, these people achieved fairly reasonable survival. And this is what set up the stage for us to start thinking about this. There are more studies, 4 patients, 2 of them achieved 5-year plus survival, 8 patients, and the survival at 1 year jumped from less than 10% to more than nearly 90%. And that's why we started thinking of what we actually did. While we were doing this protocol, we had started in, I think, 2014. Seoul AMC published 17 patients where they had given downstaging with TACE and radiotherapy and then living donor liver transplantation. And they achieved 3-year disease-free and overall survival of 57 and 60% respectively. So we published our experience with our downstaging protocol at Medanta, which basically takes patients with HCC, CLD, PVTT without extrahepatic spread, downstages them with transarterial radioembolization and Sbrt, that's stereotactic body radiation therapy. And then once this response is documented as having cleared the tumor from the portal vein, then we go ahead with living donor liver transplantation. So a total of nearly 3,200 patients had living donor liver transplant until September 20, of which 465 had HCC until 2018, that's 3-year plus follow-up. 410 did not have PVTT, 55 had PVTT, and 25 of these were downstaged, and 30 of these were not downstaged. And these were all, the not downstage ones were VP1 and VP2. But subsequently, we, after looking at this data and publishing the paper, we now do downstage every VP, whether it's 1, 2, 3, or 4. So these are the downstaging modalities that we've used. I've already talked about them, TARE and Sbrt, and occasionally the others. So what we do is we choose patients who have child's A or B with a bilirubin of less than 3, who have more than 70% non-tumor liver volume available, and they're assessed with a triphasic CT angio and a PET CT scan. And like I said, as long as they don't have extrahepatic spread and no lymph nodes which are positive for cancer, and this is checked quite meticulously almost in every case with a EUS FNA of multiple nodes along the thorax and the abdomen. These are the ones that are then chosen for the protocol. We initially, our plan is basically TARE and Sbrt. So we first do a TARE 1, which is an assessment of the shunts, and if there are shunts, they are embolized. And then we place the markers for giving the Sbrt, the fiducials. And then Sbrt is administered 45 to 55 gray over 5 to 7 fractions in 5 to 7 days. And then TARE 2, which is the actual administration of which is 90. That happens. And then we do response evaluation at 6, 8, and 10 weeks, and an average, and then proceed if there is no FDG uptake in the portal vein clot. or the thrombus, and all the contrast enhancement has disappeared. And that's what is called response. So no FDG uptake and no contrast enhancement in the portal vein thrombus. And this response evaluation is started at 6 weeks and is done every 2 weeks. And if there is partial response, we would repeat an Sbrt, typically 2 months after the first one. And then once we document response, we do living donor liver transplantation. We've already seen at an average of nearly 2.5 to 3 months after the therapy started. Let's be very clear. The therapy actually acts within days, or in fact, even hours. I asked my interventional radiologist. But it's the post-therapy reactive hyperemia that takes time to settle. So the response evaluation is only possible after 6 to 8 weeks. And actually, that's the waiting period as well. So there is a waiting period, and there is documentation of response. And only then do we go ahead with living donor liver transplantation. These are just pre and post pictures, pre and post Sbrt. You've seen how the FDG avidity has actually disappeared post Sbrt. And this is more examples of pair and Sbrt doing the same thing, disappearance of FDG avidity and enhancement. This is from our paper, already being quoted. This is overall results. We've not actually separated them into subgroups. So we're looking at 53% 5-year survival overall and 52% recurrence-free survival. And if we censor the early deaths post-operatively, then we are looking at 82, 57, and 57% survival. If we look at the subgroups, we found that among the people who were downstage and then transplanted, the overall survival was influenced by the tumor grade, and the recurrence-free survival was influenced by the AFP absolute levels and also the delta AFP before and after downstaging. Zeng, in their series of similar downstaging and then transplantation, showed that AFP of less than 1,000, tumor less than 8 centimeter, an SUV of less than 5 on FDG, and a VP 1, 2, 3 were good compared to the other group of patients with these adverse factors. So tumor biology is king. And I also completely agree with Vinny. But the thing is that you can't actually deny everyone with PVTT living donor liver transplantation if they have a suitable donor. If they can be expected to achieve 50 to 60% long-term survival, then we need to select these patients carefully and offer them transplant. If you compare transplantation with the palliative yttrium-90 patients, hardly anyone reaches long-term low survivals. With sorafenib, hardly anything. This is the data that's available. Obviously, with newer therapies, data is still coming. But if we look at all the trials, the REFLECT trial, the RESOURCE trial, the REFLECT trial was with lenvatinib, the RESOURCE trial was with regorafenib, the REACH2 was with ramucirumab, and Celestial with cabozantinib, and I am brave with the atezolizumab and bevacizumab. You basically only achieve progression-free survival of up to 8 months and median survival of up to 13 months. And these are the trials, these are the landmark trials where the indications for these drugs have actually developed. Now, if we look at transplant benefit at 3 years, between patients who do not progress to transplantation and those who do after downstaging, there is a huge transplant benefit even at 3 years of 23. So I don't see how we can justify just letting all these patients go without transplantation. So I would summarize to say that, the question is not whether these should be transplanted, but to choose whom to transplant and how to take them to transplantation. So the series from Medanta and a few other centers shows that long-term survival, more than 50% with living donor liver transplantation after downstaging of PVTT with Tnm Sbrt is possible. And this is based on some previous reports of liver transplant working well in these patients even without downstaging, and then tear and Sbrt resulting in complete or partial response. And that's what this whole protocol is based on. But patient selection is obviously crucial, and I've already talked about that, and they should not have any extrahepatic or lymph nodal spread. And downstaging should be defined as complete disappearance of FDG avidity and arterial enhancement. BP1, 2, 3 are agreeably the better patients to do. Low FDG avidity, again, good. Low AFP and smaller tumors do better, no doubt about that. And I'm personally aware, as all of you are, that several major living donor liver transplant centers across the world are actually using this policy, and we eagerly await their results. Thank you very much.
Thank you, Dr. Sain, for that excellent presentation and discussing your fantastic experience. And as you said, two sides of the coin on the same topic, which very nicely presented by both of you. May I now request for the next speaker, Dr. Sanjeev Saigal, to come in, and may I invite Sanjeev to speak to us about the management of liver transplantation and HCC after liver transplantation. Sanjeev.
Thank you. We don't get to shout at each other. Oh, that's bad.
Thank you, Irfan. Thank you, Ajay, and the entire INASL team for this wonderful meeting. Let me share my screen. Right. I hope I'm visible and audible.
Yes, you are. You are visible and audible.
Yeah. So, recurrence of HCC following transplant is indeed a negative news, a depressing news for the patient, the family, and the treating doctors. The question is that, is this the end of the road? Can we do something? And that is what I'm going to speak on my talk today in the next 15 minutes. So we need to know about the factors which predict recurrence, the principles of management, curative intent, surgical resection, ablation, and the palliative options which have really huge role in this sort of situation, the intra-arterial therapies, systemic targeted therapies, immunotherapy, and so on. Now, I'll run through 2-3 cases, which really reflect the pathos of this situation, how this is a problem for us. This is a young, not 50-year-old lady, middle-aged lady who had a liver transplant 2014 within Milan. 9 months post-transplant, he had back pain, a dorsal spine lesion, AFP was normal, and MR showed a metastasis in T6 vertebral body, and a dorsal spine lesion biopsy showed tumor cells, Hepar positive, GP3 positive, and a metastatic HCC was diagnosed. This was a 52-year-old male, hepatitis C-related cirrhosis, 6 centimeter HCC, post-ACE, AFP of 271 was outside Milan criteria, liver transplant in 2013, and 8 months post-transplant, a 3 centimeter lung nodule in the right lung base with a AFP which was raised 450. We did a lung nodule biopsy which showed metastatic cells in the lung biopsy, again GPC positive, and a metastatic HCC was diagnosed. And another case, just to tell you the significance, a 48-year-old male, hepatitis B cirrhosis with HCC, AFP 26 in the pre-transplant, who was outside Milan, and 2014 at LDLT. 11 months post-transplant, his AFP actually increased to 104. Soft tissue lesion was seen in the dynamic CT between the IVC and the liver. And the cytopathology on an FNAC showed round cells, pleomorphic, hepatoid pattern, and this was consistent with metastatic HCC. So what we are looking at? We are looking at a situation where patients can have HCC recurrence even if they are within Milan, but they are beyond Milan, they're beyond UCSF, and of course, as we just heard, PVTT, downstaging and all, we can have a recurrence in such patients also, very high risk. So what do we need to do? We need to understand the surveillance protocol. We need to understand when we manage these patients, what should be the immunosuppression which we give, the treatment options which we have, systemic therapy, targeted versus local therapy, and what is the outcome prognosis of these patients? Is it the end of the story for these patients? And we need to understand it very carefully. So post liver transplant HCC recurrence, overall occurs between 6 to 18% of patients whom we transplant. Two very important facts which still are true. 5-year survival of patients transplanted for HCC overall is from 48 to about 80%. 5-year survival of patients who have HCC recurrence post-transplant is only about 22%. So the moment they have recurrence, the survival falls down. And there are no established guidelines as of now. We say that this should be the right way of treatment. The treatment is largely individualized. It is based on your expertise, the center-specific protocols which we follow. But to understand this problem more clearly, now let me make it more clear for you. The post-transplant recurrence can be divided into early, which is within 1 year of transplant, or late, which is within more than 1 year of transplant. Some centers, I'm aware, in the US take 2 years as a cutoff value, but I think 1 year is a more reasonable thing to understand. Now, why this is done? Because to understand the pathology, how this recurrence is taking place. If it is less than 1 year, usually it's a micrometastasis either before or at time of hepatectomy, which has led to recurrence, and there is engraftment of circulating tumor cancer cells. And when it is more than 1 year, what we call as late recurrence, this is delayed engraftment of latent or indolent cancer cells. And this can happen as late as 7 years, 10 years post-transplant. So recurrence is uncommon within 1 year of transplant, but as time increases, the incidence increases. Please note one point, which is again very true. Median time to HCC recurrence, if you take overall median, it is about 13 months. It can vary from short to long, but that's what average in most series. Early recurrence carries a poor prognosis with a median survival only 12 months, and approximately 75% of recurrences would occur in the first 2 years after transplant, and 10% are detected by the end of 4th year. And the common sites, which I will tell you in more details in my talk today, are the lungs, the bone, adrenal, peritoneal, rarely brain. So extrahepatic involvement is very common, although hepatic is obviously going to happen. Now, as we manage these patients, we need to understand what are the risk factors for recurrence. So obviously, the tumor-related factors are the most important factors: the tumor burden, primary tumor size, number of lesions, vascular invasion, portal vein tumor thrombosis, the serum AFP, PEVCA level, the NRR, poor differentiation, and as Dr. Soin just mentioned, biology is a king to the yes, tumor biology is most important, and of course, some importance on PET uptake. The pre-transplant factors are the preoperative tumor biopsy, local digital therapy response. You can have patient factors like BNC reactivation, post-transplant burden and type of immunosuppression. If you pulse these patients more and more, the more you pulse, the higher the immunosuppression, the more is the chance of recurrence. Donor if it's elderly. And yes, there is a thought that LDLT recurrence will be more than DDLT. I'm not sure if it's true, but yes, in LDLT, we do take more challenging patients. We do downstage patients. We just about PVTT being downstage and taken up. Difficult cases who've been rejected otherwise from DDLT list are taken in LDLT. So there may be a higher risk of LDLT. That's my personal view, and I agree with this. And there is a risk estimation of tumor recurrence after transplant, which is the retreat score. We stratify the patients at a high risk of recurrence based on certain scoring system. Not really very useful clinically, but nevertheless, it's a score range from 0 to 8 and decreased post-transplant survival in those who have higher retreat scores. So it's an AFP, presence of microvascular invasion, and the sum of largest diameter of viable tumor in centimeters and the number of viable tumor on explant. So this is given a score AFP from 0 to 3, microvascular invasion score of 2, and this sum from 0 to 3. So maximum could be 3 plus 2, 5 plus 3, 8. So maximum is 8. And the more the score, the higher the chance of tumor recurrence post-transplant. When we manage these patients, we have to understand that this is a heterogeneous group. It is not a single uniform thing. And a multidisciplinary team approach or a tumor board is very important. It should be a discussion between the hepatologists, the surgeons, diagnostic team, interventional radiology, oncology, and so on. Now, we have to understand, as a hepatologist, I would like to tell you straight away that when tumor recurrence has taken place, what should be an immunosuppression protocol? Yes, there are many protocols which have been designed based on mTOR inhibitors, which say that if you use them post-transplant, your risk of recurrence will be low. And also a situation may happen, or it happens is that when recurrence already taken place, then what do you do with immunosuppression? Well, there are several studies on mTOR inhibitors, and I've just taken one of these, representative ones, which says sirolimus for HCC, a meta-analysis published way back in 2012, about nearly 3,000 participants, and 1 year, 3 year, and 5 year. The overall survival was better on sirolimus, decreased tumor recurrence in sirolimus regimen, no difference in rejection rates, and so on. Now, important point is that when a tumor recurrence has taken place, patient should be preferably converted to an mTOR inhibitor with a reduced CNI dose, and graft function should be very carefully monitored. You should not allow rejection to take place because that will complicate the matters even further. Please understand that tumor recurrence is not the end of the story. So it's the fundamental duty of the hepatologists, the surgeons, to ensure that the graft keeps on functioning well, and whatever immunosuppression we give maintains the graft in optimal position. You don't over immunosuppress them, you do optimally immunosuppress them, but you make sure that they don't go into rejection and so on. Now, among the various options, the surgical and ablative options can be curative in these patients for oligo recurrences, localized recurrence in liver, whereas palliative options like chemo, radioablation, wire entry, targeted therapies, immunotherapies are still from the palliative intent, and we'll see how they really impact the recurrence treatment. Now, surgical resection should be the first line whenever possible, and patients who are amenable to resection with curative intent have a significantly higher survival compared to those who don't have this option available. There are some data and literature which speak about this, number of resections, the site of resection, lung, adrenal, liver, chest, and so on. It depends on your experience. Like we have, many patients who have dissection the liver, there have been lung resection, metastectomy has been done, surgeons have resected the segmentectomy, have done, and so on. Bottom line is that overall survival with surgery is about 28 to 65 months as compared to about 5 to 15 months in those who get systemic treatment only. This is also perhaps true because those who are operated, they don't have widespread disease, they have localized recurrences, maybe 1 or 2 or 3, you can resect them well. And sometimes these patients would have received actually one of the targeted therapies and then they are also resected. So therefore surgery would have a benefit, but there would be some bias on that. Now, the intra-arterial therapies which we use, they are for multifocal recurrences who are not amenable to resection or ablation. Typically, TACE is used, but there are issues with TACE sometimes because hepatic arterial stenosis or kinks. Biliary ischemia can happen because of less selective embolization in these patients and lack of collateral vascularization. Then we have used radioembolization, Y90 in some recurrences, although results are, still, not very strongly positive. And there are a combination of local regional therapies, thermal ablations, RFA, microwave and TACE, and and they really work well in given patients. Now, the systemic and targeted therapies are the most commonly used in these patients. Sorafenib in combination with mTOR inhibitors, it appears to prolong survival, although not very long, but yes, it is still important, which I'll discuss. Lenvatinib is now available, which we are using actually in those unfortunate patients who have recurrences, and immunotherapy, which I'll discuss shortly in my subsequent slides. Now, some data is available on sorafenib because that is the most commonly used drug till now, and there have been meta-analysis which was published in 2015, and there are a lot of retrospective studies, and there was these data, they all show that what really is essential to understand that sorafenib in combination with mTOR inhibitors appears to prolong survival, but there is distinctly a increased risk of toxicity, the side effects of this drug, which is limited, because that side effect limits the full dose of sorafenib being used in these patients. I've seen many patients who cannot cross more than 200 milligrams twice a day, and sometimes once a day also, because the standard 800 they cannot reach many times. Lenvatinib perhaps is better tolerated, but again, the number of patients treated and the published literature is very limited. Now, immunotherapy, the immune checkpoint modulation of cell-mediated immunity is very important. It is implicated in transplant organ tolerance, and downregulation of these pathways inadvertently can lead to rejection of these patients' graft. Now, the commonly used drugs initially, the PD-L1 inhibitors, the nivolumab and pembrolizumab, they target the programmed cell death protein PD-1. And now we have this study of, atezolizumab, which targets PD-L1, and bevacizumab, which is VEGF inhibitor combination, the IM-150 trial, which has been approved in unresectable HCC and say that, well, it works well in these, but again, no data is there in the transplanted population post-recurrence. And these checkpoint inhibitors, the problem is that there is a risk of rejection being precipitated by these drugs, and the current experience is limited to case reports in small series only. Now, this is a compilation of the case reports, some of the representative ones which I've taken here actually, and what we'll notice is that the rejection rate in these patients is actually fairly significant, and that has to be kept in mind. So these are all with nivolumab or pembrolizumab, but the atezo and all, which I'm not aware of any published data on that. Overall, yes, immunotherapy, the poor overall survival and the risk of graft rejection limits the use of this immunotherapy, at least as of now, in post-liver transplant HCC recurrence. I'm aware of 2 patients. One was actually not too long back, few months back, who had recurrence post-transplant, was given nivolumab. He had very bad graft dysfunction, biliary to 2025, and subsequently we lost this patient. So there has been a good publication on post-liver transplant recurrence and HCC, not necessarily the end of the road. And this was, part of it was discussed in the previous talk. So out of these 435 patients who had HCC with no PVTT, the recurrence was, discussed in details and how they were treated. The hepatic recurrence was in 15 patients, hepatic plus extrahepatic 21, and extrahepatic only in 54 patients. So 100 patients overall, which is 23% of HCC, they actually recurred post-transplant with a median recurrence time of 16 months. And this recurrence occurred as early as 2 months to as late as 108 months. And AFP was 80 with a wide range. Commonest site of recurrence were lungs, 53%, 53%, then liver and bone. So they continue to be the commonest site of recurrence, which is important to understand. Now, various types of treatments have been used: the kinase inhibitors, sorafenib, regorafenib, lenvatinib, with mTOR inhibitors, sirolimus, everolimus combination, 36 patients, and these kinase inhibitors with mTOR inhibitors, plus other modalities like surgery, radiotherapy, or ablation in about 32 patients. This is a big mix of patients, and different type of interventions were done, like TACE, folivomet, VATS following metastasis, surgical dissections, purpose erythroid injection of lymph nodes, RFA, and on. So what essentially was the message is that you can have a decent, survival figures. 1 and 3 year overall survival after recurrence were 57% and 24% respectively, with a maximum post-recurrence survival of 7.5 years, which is impressive. And HCC recurrence within 1 year after transplant, AFP more than 200 at time of recurrence, and multiple site recurrence were poor prognostic indicators for post-recurrence survival, which is an important message. And also it was understood that if you have medical plus other treatment modalities, then you have the maximum survival chance 1, 3, and 5 years as compared to those who receive only TKI or those who receive only TKI with mTOR inhibitors. So a multimodality treatment is the thing of choice in these patients who have recurrence. Just a word about, again, this prognostic scoring. People are very fond of scoring things. That is something I've realized in medical science, that if you have an opportunity, you put a scoring system and try and see how it fits your patient population. This was a score which I thought was interesting, which says that prognostic score of prediction of survival after HCC recurrence. So 3 variables taken: early tumor recurrence within 1 year transplant, AFP more than 100, like not 200 in the earliest, which was mentioned earlier, it is 100, and tumor not susceptible to curative therapy. So if there are no variables, good prognosis, 1 year survival after tumor recurrence was 73%. 1 or 2 variables present, moderate prognosis, 55% 1 year survival after tumor recurrence. But if all 3 variables present, then there's a poor prognosis, and only 17% 1 year survival after tumor recurrence was seen. So to summarize, my dear friends, I have this multidisciplinary approach for post-liver transplant recurrence. So what do? We review the immunosuppression, as I just mentioned in my talk, reduce the overall immunosuppression and try and bring an mTOR inhibitor, everolimus or sirolimus, based on patient's acceptability, proteinuria, and so on, renal function, so on. We certainly reduce the CNI. Sometimes we like to use a low dose CNI with mTOR inhibitors, sometimes only mTOR inhibitors alone. So this is something which we are dealing all the time. We stage the tumor very carefully. We look at the PET CT, contrast CT, bone scan to see the sites where it has where the recurrence taken place. If it is a oligorecurrence, if it's hepatic, I would say that yes, best is to do resection. If there's very small ones, we can do ablations, stage, microwave, or you can do Sbrt regional therapy, which also has been done successfully. Extrahepatic, do resection or ablation or Sbrt. And if it is a disseminated recurrence, well, we have to use things like sorafenib, regorafenib, lenvatinib, which we use more commonly now. Immunotherapy, yes, there is still a question mark, and I'm not sure whether it is going to be used in the current form. But yes, if we can reduce the risk of radiation, then this PD-L1 inhibitors, they probably maybe the remarkable things to see in future. But yes, the foremost thing for us would be to not let recurrence take place after a liver transplant, and that should be the primary aim. But anyway, if it has taken place, then we should not have a totally negative and depressive feeling. We should use a multidisciplinary approach and try and treat these recurrences as far as possible and prolong the survival of these patients. Thank you very much, friends, for your patient hearing. Thank you.
Thank you, Sanjeev, for that excellent discussion on a very difficult topic. Ajay, would you have any comments to make?
No, I think you can invite the panelists and have the discussion, and then maybe we can chip in later. Yeah.
Okay. So thank you. Thank you to all.
Sharing your slides.
I will, Ajay.
Thank you to all the 4 speakers. We had an excellent exposition, and may I invite the panelists, Dr. Kaman, Dr. Dinesh Jyotimani, Dr. Gaurav Pandey, and Dr. Ashok Chaudhary to join, please. Maybe as a start, I'll have a few comments to make, and maybe I'll request each of the speakers to add their points to that. I've taken the chat questions, and I asked the panelists to give their opinion as well. So I have one comment each to each of the speakers, if it's possible. To Dr. Subhash Gupta, my question is this. It's a very difficult question to decide when a patient, well, not a difficult, it's I would like your opinion. If a patient who qualifies for resection, for example, either child say cirrhosis with HCC or a non-cirrhotic liver with HCC, how does one decide? And we have, the center has got both the options of doing an LDLT as well as resection. What would be your preferred choice, and what are the logic behind that? Dr. Gupta, please. So you have to unmute yourself.
I think there's no question. I would say it's a no-brainer choosing between resection versus transplantation. Resection can be done safely. It's obviously in everybody's interest. We're not interested in of course, we're interested in long-term outcomes, but at the short term, provided liver functions then the patient is not going to go into post-hepatectomy liver failure, then resection is automatically the first choice. There's no, I mean, I'm convinced about that. Recurrence is happening. I mean, the imaging modalities nowadays are amazing. Most tumors will be either AFP secreting, or at least they will PIVCA would be high. I mean, it's rare to see a tumor which is neither AFP or AFP. So you can have good aggressive follow-up with sort of 3-monthly MRIs, which is what we do in our center. We pick up lesions quite early, and it actually, you can pick them up, you can then sort of do local therapy on them, or you can do sort of salvage transplantation. And overall, I think that is probably the way to go. But yes, some centers are keen to do transplant upfront, but that is not our policy. In fact, even in those who will not surgical candidates, but even, and they are within Milan, we would advocate strongly that they undergo some form of local regional therapy so that they can, then undergo transplantation when it's quite clear that the tumor is of good biology. And everyone says biology is the king.
Thank you. Thank you, Dr. Gupta. May I address the next question to Dr. Pamecha, please? It's a little biology question, actually, because both the debaters mentioned that tumor biology is king. So I just want to ask you about, see, the hepatocellular carcinoma growing into the portal vein is a bit similar to the renal cell carcinoma going to the renal vein. We know that from MBBS teaching. How come the HCC grows into the portal vein and not into the hepatic vein preferentially? In your thoughts about it? It seems to be there's a propensity for that. There must be some biological basis for that. Any thoughts on that?
First of all, I won't correlate HCC with RCC. RCC growing into IVC is a very different thing. And there is, in terms of actually RCC, we can milk out the tumor thrombus from the IVC in a renal cell carcinoma. That is not exactly what happens with hepatocellular carcinoma. So pathogenetically, they both are very different entities. No, RCC, there are lots of data on milking out tumor thrombus. It's a tumor thrombus which just grows into the vein. Here the difference is, it is more of infiltration into the veins. Okay. And obviously, because of the dual supply the liver have, the hepatic artery, the portal vein. So I think pathologically that is related to why tumor grows into the portal vein. And if we say about the hepatic veins, because the hepatic veins as such, the incidence of PVT, incidence of tumor thrombosis in hepatic vein is around 5% or so. And they are associated with a very poor prognosis. So there is a difference between invasion into hepatic vein and portal vein. So that's it. And so tumor biology is related to vascular invasion in HCC.
Thank you. Thank you, Dr. Pamich. May I ask Dr. Soin one question? I really was fascinated by your vast experience and the cutting edge work that you do. So you have mentioned that there are two downstaging treatments which you offer in your protocol prior to doing liver transplant, the person with portal vein tumor thrombus. That was TARE followed by Sbrt. So I'm just trying to take that on a bit. Wouldn't TARE, would TARE actually act on the portal vein tumor thrombus? Or would it be more of, let's say, hepatic tumor thrombus rather than the portal vein? That isn't it the Sbrt more, which is it so, tackling the portal vein tumor thrombus? In which, if that were to be so, why do TARE at all? Why not do Sbrt directly? Dr. Sain, please.
So that's a good question. Now, what happens is that, and this is both from literature and from our own experience with the interventional radiologists and our patients. TARE acts on the main tumor or tumors in the liver. It also acts on portal vein tumor thrombus. It's actually or hepatic vein or IVC tumor thrombus. It actually acts on all tumor that is in the liver, vascular and extravascular. The incidence of disappearance of tumor thrombosis with TARE alone is only in the region of 15 to 20%. You are absolutely right. But it doesn't have no effect. However, it's important to give TARE, one, for the additive effect for tumor thrombosis, and second, because it also acts on the main tumor or tumor. Sbrt definitely is directed therapy, which is marked by fiducial markers, and therefore has on its own nearly 50% efficacy in clearing tumor thrombus, especially non-VT4. And the combined modalities of late in our patients have been clearing the thrombus in more than 70%.
Okay. Thank you. Thank you, Dr. Soin. May I ask Sanji one question as well, please? Sanji, you picked up a very depressing topic and you've battled it very well and highlighted the complexities of treating such a patient. From the different available treatment options when the recurrence happens, looks like the easiest to give is to do is the change of immunosuppression and bring in sirolimus an mTOR inhibitor with a low dose CNI. Everything else is a little more difficult to do, but there are different things which you have done. So my question is there any way of predicting which patient would get a HCC recurrence? And I do not have a recurrence now. Would you consider changing me to mTOR inhibitor now itself? Is there a score like that? And is there any logic of doing that? I know there's a downside of worry of rejection, but would you ever consider like that?
But that's a very good question. In fact, that is something which is being practiced in many centers. And I remember giving a talk in LBS once about 2 years back. There are enough data to say that if you are preemptively switching over to mTOR inhibitors post-transplant like everolimus or sirolimus, then your chance of tumor recurrence in the longer term may be lesser in the HCC patients. This is both within Milan and beyond Milan or beyond UCF criteria. And I did not discuss this part in the slides today because it's more of a recurrence has taken place. And then we are discussing the issue today. Having said that, many centers would not believe this and they would continue the standard image of what they use. So one is that if you ask me, yes, literature has sufficient evidence to say that switching over to mTOR inhibitors preemptively, there's a protocol where people shift at 6 or 8 weeks after transplant if there is no proteinuria, graft is stable, and renal function is fine. And perhaps it leads to lesser recurrence in the longer term. That's number one. And secondly, these patients, like when they have a tumor recurrence, then actually you can say the damage is already done. So what you can do further? I mean, the guy already has tumor. Will it make a difference? Even then, there is literature-based evidence that even then, when you're trying to use sorafenib and all, there is again published data which says that yes, and experience also that yes, you switch over to something like sirolimus or everolimus and use low dose CNI, maintain the graft function. Don't let rejection set in because that will complicate the matters further. Because the view that once recurrence has taken place, everything is over, that should not be carried away. That should not be carried forward, because that's something which patients, even doctors feel, oh, recurrence has come, so this patient is not to be seen, OPD, leave him alone, nothing could happen. Because now we know that with multimodality treatment, we can prolong survival of these patients and they could go on for, a few years easily, which is not bad actually.
Thank you. Thank you, Sanjeev. I note that Dr. Subhash Gupta has got a question to ask, or a point to share. Dr. Gupta, please.
I think everolimus I don't think is of any use, to be honest. And lot of poorly tolerated, very expensive. You get sort of mouth ulcers, cough, I don't think it actually, and data is not clearly supportive of advantage as far as preventing tumor recurrence is concerned. But I don't know what others feel about it. But our own centers experience a huge number of cases that it does not. What the other point that I wanted to highlight was that the two categories of recurrences, one which happens within the liver and one which happen outside the liver. Most of them happen within the liver. Some which happen outside the liver, we find that they respond well to sorafenib or lenvatinib, whereas those which are within the liver, they're very, very difficult to manage. They tend to reoccur again and again. So, but that's, but in those with just extrahepatic manifestation, they seem to, do quite well long-term on, either lenvatinib or even localized radiotherapy. In one patient we did there, and he's still alive 4 years. There's no evidence of anymore now.
Thank you. There are a few questions in the chat box. Before I take it up,
Dr. Epan, maybe also you can invite the panelists for their questions or comments.
I'm Dr. Kamal here. Can I have a questions?
Yes, please. Please go ahead, Dr. Kamal.
Okay. Yeah, this question is for Dr. Sain. Congratulations for your excellent experience of portal vein thrombosis and HCC in liver transplantation, definitely. I was just wondering, you gave preoperative neoadjuvant local regional treatment, and you wait for 10 weeks. That might cause some kind of tumor progressions in those patients who doesn't respond. And can you look at the thing like, do you have any idea like you can do an upfront transplant, then give the local regional or the systemic therapy as an adjuvant setting? Can it make any difference? What is your thought about that? That is one. And second question is, as a surgeon, I got a technical questions. Like, when you are doing a transplantation, especially for B4 kind of thrombosis, what is your extent of portal vein resections for the inflow? Because, or you do just a thrombectomy. So what is your kind of, protocol?
So, okay, both good questions. So the first question is, would I dare to do a upfront transplantation? No, never. As it is, people are, gunning for me, and then they will actually gun me down if I do that. So no, I would downstage them. And what happens is that, yes, they will progress. Some of them will progress in 2 or 3 months. And that kind of is an auto-selection of bad biology, the very biology that Dr. Pamecha and I have been harping about. And people who select themselves to respond and stay tumor-free in their veins are the ones who are candidates for transplantation. And in terms of the technical difficulty in transplanting these patients, about 30 to 40% of these patients, especially the ones who have had VP3 and VP4 thrombosis, will need a portal vein replacement. So that's pretty simple. We just do it with a vein graft, and that's usually okay.
Why I was asking the first question is, Dr. San, I understand your point, definitely. But anyway, we are doing the liver, living-related liver transplantations in portal vein thrombosis, knowing that it is already a systemic disease, maybe.
No, it's
as
not.
Dr. Pamecha was actually showing one of the slides, those microvascular involvement is already microvascular involvement is already there up to 30%.
It's not systemic disease. I have like a bunch of patients who are 6, 7, 8 years out, and they're absolutely well, no recurrence. So it's not necessarily systemic disease. It can be, but it's not necessary.
That I understand, but Dr. Soin, otherwise you are not offering
another webinar actually happening at 6.
Okay. Anyway, you are not able to do anything for this unfortunate group of patients. Otherwise, you will just condemn them. Is not it?
No. They will have. If they are suitable for Atezo and Bev, they can have that, or they can have one of the TKIs. So there is palliation, but obviously nothing as good as our protocol. But that's only for selected patients. That's this disclaimer, and that's basically the essential theme. It cannot be for everyone.
Okay. Thank you. Thank you so much.
Can I just leave? I'm so sorry. I'm in another webinar with the permission of the chair. Or if you want to shoot a quick question, I'll just take that.
No, thank you very much, Dr. Soin, I think, for joining. Thank you very much. Yeah, thank you. Yeah. Dr. Epan, maybe you can continue for another 5 minutes. I think it's a healthy discussion going on here. So even though the time is up here.
Yeah, thank you, Ajay. First of all, I'll request the other panelists if you have any comments to make before taking the chat questions.
Professor Epan and Dr. Kaman again, can I have a questions to Dr. Gupta, please?
Sure, Dr. Kaman.
Yeah, Dr. Gupta, thank you for such a nice presentations. I was just wondering, in a cirrhotic patient and with a HCC around 5 centimeter in the central segment, segment 5 and 8, what is your preferred kind of resections? It is an anatomical or a non-anatomical kind of resection you do?
As I said in my presentation, in cirrhosis, you have to do segmental resection. Because if you leave behind ischemic segments, you will end up with sepsis and post-hepatectomy liver failure. And it's very, very important that whenever you're contemplating resection in cirrhosis, you must consider segment, not from the point of view of recurrent disease, but from the point of view that you don't leave behind any ischemic areas. And that's an important point I'm making here. And we will, and others have as well, will prefer a segmental resection. If it's segment 5 and 8, we'll remove these two selectively.
Then, do you believe in doing a proper, maybe lobectomy? Right, hepatectomy?
No. If you do,
only segmentectomy you won't.
Yeah.
Okay. Yeah, fine. Thank you.
Any comments from any of the other panelists, Dinesh, Gaurav, or Ashok?
Thanks, Ethan. See, the everolimus, I don't think we can write off straight away saying it's not a useful drug. I think most of the studies are retrospective with regards to everolimus in the post-transplant setting, particularly with in relation to HCC. There are not many prospective studies to support that.
The cost and side effects, even if they're not
of course, yes, yeah. Because it's definitely everolimus is much better than sirolimus in terms of their side effects, adverse event profile. Okay. Epan, I have a question for Dr. Pamej. In fact, I had a question for Soin as well. It's left. So when do you offer transplantation in patients with portal vein tumor thrombosis?
Okay. So as we were discussing, it's about tumor biology. So in a patient, so if it is a main portal vein thrombosis, I will be, it's not a good starter. If it is a segmental portal vein thrombosis, then obviously we will look at what is there to start with. In a patient with a very high AFP, high PIPCA, we will be very skeptical. Obviously, they all will go on a neoadjuvant therapy, and with the newer modalities would be radioembolization and also starting, depending on maybe immunotherapy as well, depending on what their status is. And if there is a response to treatment, which is an objective response in terms of AFP coming down. So our protocol, normal protocol is also, if anybody who's got an AFP of more than 200, I'll do local regional therapy, irrespective whether they got portal vein thrombosis or not. So once the AFP comes down to less than 200, PIPCA is also within the range. Then, and there is an objective radiological response to the therapy, then we'll offer them transplant. So ideally, the waiting time for this should be more than 3 months. That's very important actually. And that point is repeatedly being taken off. That's what the Dr. Soin's data's limitation is. They're transplanted very quickly after neoadjuvant therapy. And so you're not selecting very well. So the crux here is how you select. We know that there are patients with very good tumor biology who will benefit from this modality of treatment. There's no doubt about it. It's just that how you select them properly. And these are the things which are available to us right now. So AFP, PIPCA, PET avidity, and response to the therapy, and waiting time. These are the 4 things which are available to us. And then you go along that and wait 3 months. At least 3 months you should give before offering a live donor transplantation. People will come to you, we got a donor, we got everything. They're just transplant, but you don't want to do a palliative transplant, isn't it? You need to have some outcome benefit from such a big operation.
That's a very good point, to wait for 3 months to see the response to local regional therapy, and they remain stable without any new lesions or increasing AFP.
Thank you. I think Dr. Subhash Gupta has got a point to make.
Just to ask Dr. Sanjeev, taking the question forward, are there any preemptive medications to prevent the post-transplant recurrence? I think there is a question from Professor Sudhindaran also. He was asking about use of statins and aspirin, if they could be given first step to reduce the rate of recurrence of post-transplant HCC.
But honestly, I don't think that there are any preemptive strategies which you can use. I mean, statins and aspirin, I'm aware of this, discussion happening earlier also. We don't
Any
use
point on reducing the weight, controlling diabetes, reducing other risk factors for HCC?
Yes, so see, those are general risk factors which are, advised in any way, which is a good point, because if you look at the factors which predict recurrence, one of them is obesity, So if you control obesity, yes, it's good. And one which is again a discussion, which is a debatable issue, is that preemptive use of mTOR inhibitors, which some agree, some don't agree, but that's probably the closest you can do in these patients. And there is no role of preemptive TKI inhibitors without recurrence. Use sorafenib in a given patient and so that it doesn't recur. There's nothing like that. But that's a very good question.
Thank you.
Thank you, Sanjeev. Can I ask Ashok Chaudhary as well, whether he has any comments to make? He's also a panelist here.
Yeah, good evening. So my suggestion that all discussions and what is encouraging or discouraging is the post-transplant HCC recurrence. So that's where practical PPT should be considered now. Why we should not think of developing comprehensive model as rightly said, by the biological behavior, particularly by the APK, PIPK or response to therapy. That is one part. Two, we should get a data retrospectively, particularly in relation to proteomics and genomics, how a tumor is become aggressive. If the same tumor with the PVT, tumor thrombus also AP is normal, but another tumor thrombus, his AP is very high. So is there making a difference? So it is a prospective, or we can retrospectively can collect all the data, and I think that may be the way forward with improvement of bioinformatics. So we can combine the samples, and we see that those have recurrence and those not have recurrence. I think if that way it can give a more precision medicine, and hopefully in future, in coming days, that can be a way forward. So if we can do this, and I can say ILS has a good biobank facilities, and we have all the genomic labs and omics we are doing for the proteomics also, transcriptomics also. We can get all the transplanted patients for HCC to get the sample archived, and we can get an analysis so that we can compare between those of recurrence, those not having recurrence. So we can have the all the data, imaging, biological behavior, and as well as the this precision medicines to combine it. So that I can suggest something to a way forward.
Thank you, Ashok, for that. It's a very valid point and something to take up, something for all of us to work on. I think we've really encroached time, and I must thank all the speakers for the excellent talks, and the discussion showed that it really is very well delivered and very well received. Thank you. I'll hand it back to Ajay to say. Thank you.
Thank you, sir, for this wonderful session. And I think we should close this session. And I request Dr. Sahaj to introduce the chairpersons for the next session.
Yeah, thank you, sir. So moving up on the disease morbidity scale, we now move on to the session on radiation and systemic therapy in HCC. To chair this session, may I now invite Professor Vivek Saraswat, who is the Professor and Head Department of Hepatology, Pancreatic Biliary Sciences and Liver Transplantation at Mahatma Gandhi University of Medical Sciences at Jaipur. Professor Saraswat was formerly Professor and Head of Department Gastroenterology at SGPGI Lucknow. I would also like to invite Professor Rakesh Kapoor, who is the Professor and Head Department of Radiation Oncology and Director at Homi Bhabha Cancer Hospital and Research Center, Mulanpur and Sangrur in Punjab, which is a unit of Tata Memorial, Mumbai. Professor Kapoor was formerly the Professor and Unit Head at Department of Radiotherapy at PGI Chandigarh. Over to the chairpersons, please.
Well, thank you very much, Sahaj. And at the outset, I'd like to thank Dr. Duseja, INASL, the team, Sunil, and the entire group for organizing a fantastic meeting for HCC over the last couple of days. It's been a thoroughly enjoyable afternoon we have spent listening to wonderful talks. And I guess in the Indian context, we have probably saved the best for last. The Indian context being that we generally tend to see large, advanced, intermediate or advanced lesions much more often. And much of the discussion that has gone before is probably confined to a small proportion of the patients we encounter in our day-to-day practice. So I think probably one of the most important sessions of this meeting will be treatment, radiation, and systemic therapy generally applied to patients with advanced HCC. And with these few words, it's a pleasure for me to invite Professor Christopher Hollmeyer, who will be talking to us on external beam radiotherapy for HCC. What are the current trends? And I think I seem to have. Just give me a minute.
Can you see my screen?
Yes, Professor Hollmeyer. I
Great.
think I've, excuse me for the delay. Professor Hollmeyer is a consultant, Department of Radiation Oncology at the Mayo Clinic, Rochester, an associate professor in radiation oncology at the Mayo College of Medicine, Rochester. So Professor Hollmeyer, please share your slides and we look forward to listen to you.
Thank you, Dr. D'Souza, for the kind invitation to speak. I'm going to talk about external beam radiotherapy for HCC. This is a modality that really has garnered a lot of interest over the past decade, as you'll see in my presentation. I have no conflicts of interest. I'll briefly review some of the data supporting the safety and efficacy of high-dose conformal external beam radiotherapy, review some of the more recent data, putting it in the context of other treatment modalities that we have. We'll briefly talk about patient selection and show a couple of case examples. So just as background, whole liver external beam radiotherapy was used more commonly in the United States in the 1970s and 80s. However, the results overall were fairly disappointing. It was recognized that HCC is a radioresponsive tumor. However, it lives in a radiosensitive organ. And when giving whole liver radiotherapy, really once we hit doses of 30 gray and 2 gray fractions, anything above that was accompanied by a significant risk of fatal radiation-induced liver disease. And so in the 1980s, whole liver radiotherapy was really relegated for palliation. However, over the past 2 decades, there have been significant advances in imaging, treatment planning, delivery, localization, and image guidance that now allow us to safely deliver high-dose, conformal, and potentially curative external beam radiotherapy. And the 2 main platforms that have allowed this are the use of proton beam radiotherapy and Sbrt. Just as a brief background, photon radiotherapy, which is the most common type of radiotherapy treatment, a radiation beam is delivered and it passes all the way through the body with some of the dose given in front of and beyond the tumor. With sophisticated techniques, we can use lots of different beams that all converge on the tumor and give a high dose to the tumor with relatively lower doses to the surrounding tissues. Proton beam radiotherapy, a single beam is delivered and most of the dose is delivered to the tumor itself with less dose delivered to the surrounding tissues. Generally, 2 to 3 proton beams are used to treat HCC, again, with relative sparing of the surrounding liver. Proton beam radiotherapy was first proposed as a treatment for HCC in the late 1980s from the University of Tsukuba in Japan. This is one of the first proton beam centers in the world. They quickly realized that they were able to give a high dose of radiotherapy to the tumor with relative sparing of uninvolved segments of the liver. They were able to give significantly higher doses of radiotherapy than was given with whole liver radiotherapy. As we mentioned, with whole liver radiotherapy, you're limited to about 30 gray and 2 gray fractions, whereas with partial liver radiotherapy with protons, they're able to give doses in the 80 to 100 gray equivalent in 2 gray doses, generally given in shorter treatment regimens over 2 to 4 weeks. This is one of their early series where they looked at over 300 patients treated with proton beam radiotherapy from 2001 to 2007. These are patients who are not candidates for surgical therapy. Many of them had failed other local regional therapies. Most patients had intact liver function. And again, they gave high dose radiotherapy over 2 to 4 weeks. The 5-year survival in the series was about 45%. When they looked specifically at patients with Child-Pugh disease, the 5-year survival was 56%, so quite promising. And they were able to achieve this with relatively low risks of significant toxicity, skin and musculoskeletal low-grade toxicities, as well as low rates of GI luminal toxicity. The treated tumor was well controlled in 87% of patients, and those who did develop recurrence, typically it was intrahepatic or extrahepatic mets. This experience has now been replicated in several prospective single-arm studies done mostly in Southeast Asia and the United States, where with 2 to 4 week regimens of proton beam therapy, they've consistently achieved local control rates of about 90% and promising survival rates. The other major platform for delivering high-dose radiotherapy is photon Sbrt. This is much more widely available around the world compared to proton beam therapy, which is only available at select centers. This uses multiple highly focused beams to deliver high doses of radiotherapy, generally in 3 to 5 fractions over 1 week. This has mostly been applied to smaller tumors and allows one to deliver what's been called an ablative dose of radiotherapy with relative sparing of the surrounding liver. This is an earlier series from Japan, a multi-institutional retrospective series of patients with tumors less than 5 centimeters, not amenable to surgical therapy or ablation. They delivered Sbrt in 5 fractions and showed that they could durably control a majority of the tumors with favorable 3-year survival and limited rates of severe toxicities and a 1% risk of fatal liver failure. There have now been several single-arm prospective studies in Europe, the United States, and Asia that have also demonstrated favorable outcomes with 3 to 5 fraction Sbrt with favorable toxicity rates and consistently tumor local control rates in excess of 90% and promising survival rates. In the past 5 years, there have been several studies that have tried to compare radiotherapy to other local regional treatment modalities, either in the bridge to transplant setting or as definitive treatment, and we'll briefly discuss a few of these studies. This is a series from the University of Toronto where they looked retrospectively at all of their patients listed for transplant who received bridging therapy, either RFA, TACE, or Sbrt. The patients who received Sbrt had generally failed other more common bridging modalities or were not eligible to those. They found that the dropout rate was similar, and the patients who had Sbrt prior to transplant, there was no increased risk of perioperative complications. And when they looked at survival, either from the time of listing or from the time of transplant, it was similar with Sbrt compared to the other treatment modalities. Just recently, Hong Kong group presented their experience with Sbrt as a bridging modality. These are patients who are within UCSF criteria. They had a retrospective cohort of patients treated with TACE from 2010 to 2015, at which time they opened a prospective protocol using Sbrt as their primary bridging technique from 2015 to 2020. So they compared the retrospective cohort of TACE with the prospective cohort of Sbrt. They found that radiologic response using modified RECIST was significantly greater with Sbrt compared to TACE at both 3 and 6 months, with the majority of the patients having either partial or complete response with Sbrt. And this correlated well with pathologic outcomes in the patients who underwent liver transplantation. The explant pathology showed a significantly higher rate of pathologic complete response in the patients treated with Sbrt. They saw that the risk of dropout was lower in patients receiving Sbrt, and the time to progression was also lower. Survival measured either from the time of listing or from the time of transplant was similar with Sbrt compared to TACE. Switching gears to definitive treatment, there are now several retrospective series that have compared RFA to Sbrt, both from the United States and from Asia. Generally speaking, the patients who received Sbrt had slightly larger tumors or more advanced BCLC staging. In spite of that, freedom from local tumor progression was similar, if not better, in the patients who received Sbrt. Survival was also generally similar between the two cohorts. This is one series from Japan where they looked at all patients. There was an apparent better survival with patients receiving RFA. However, when they corrected for the difference in tumor size and stage between the two cohorts with propensity matching, 5-year survival looked quite similar between Sbrt and RFA. Just recently, there was a phase 3 randomized control trial published out of Korea comparing proton beam radiotherapy versus RFA for patients with recurrent but early stage HCC. These were generally patients who had had prior surgical therapy or RFA and then developed a new lesion. 72 patients were randomized to RFA and 72 to proton beam radiotherapy. There was a significantly higher crossover rate in patients who were randomized to RFA, but then were not actually able to receive that treatment due to technical challenges. So in the per protocol analysis, there were more patients who actually received proton beam therapy versus RFA. The primary endpoint was 2-year local progression-free survival, with this being powered to show non-inferiority of proton beam therapy using a 15% margin. When they looked at acute events in this randomized trial, there was significantly more fever, pain, and nausea with RFA, but higher rates of low-grade dermatitis and radiation pneumonitis in the patients who received radiotherapy. The grade 3 or higher adverse event rate was significantly higher with RFA at 16% versus 0% for proton beam therapy. And the percentage of patients with an increase in their Child-Pugh score was higher in patients receiving RFA versus proton beam therapy. For the primary analysis of local progression-free survival, proton beam therapy was non-inferior. This dotted line is the 15% non-inferiority margin, and you can see that numerically, the local control rate was higher with proton beam therapy, so it easily met their criteria for non-inferiority. These are the curves again showing non-inferiority of proton beam therapy compared to RFA. And when they looked at progression-free and overall survival for the two cohorts, again in a randomized fashion, 5-year survival was about 70% in both groups. There have been a couple of retrospective series comparing radiotherapy, specifically Sbrt to TACE. This is one such experience from Michigan, where they showed similar survival, but superior local tumor control with Sbrt compared to TACE. There was a study done in Korea that looked at a strategy of TACE followed by radiotherapy compared to sorafenib for patients with BCLCC tumors, so patients with portal vein disease. And what they showed is that the strategy of TACE followed by external beam radiotherapy was superior to sorafenib in terms of progression-free and overall survival. There are several ongoing randomized trials done in Asia and the United States and around the world that are designed to better assess in a prospective randomized setting the role of radiotherapy in comparison to other local, regional, and systemic treatments. The BCLC guidelines, which many people look at in terms of stratifying and recommending treatments, currently do not recommend or do not include external beam radiotherapy. However, several groups have proposed ways in which external beam radiotherapy can be considered. For patients with early disease, Sbrt is a reasonable option for patients that are inoperable and not eligible for other local regional modalities. It can be considered in patients with more local regionally advanced disease, either alone or in combination with embolization techniques or systemic therapy. And it can be used as a palliative treatment for patients with more advanced disease. The NCCN guidelines in the United States do include external beam radiotherapy as a standard treatment option. These are patients with liver confined disease. Surgical therapies are preferred, but if their patients are not candidates for resection or transplant, then external beam radiotherapy can be considered along with ablation or arterially directed therapies. So which patients are good candidates for curative intent high dose conformal external beam radiotherapy, either Sbrt or protons? Patients with intact liver function, so predominantly Child-Pugh A and potentially B6 patients. Those that have unifocal or limited multifocal tumors within the liver. Contraindications are poor performance status, limited life expectancy, extrahepatic disease, more than 3 intrahepatic lesions, decompensated liver function, and prior radioembolization is a relative but not absolute contraindication. Importantly, there are no contraindications based on tumor size, location, and presence of vascular tumor thrombus. Just a couple examples of patients that I've treated in the past. This is a patient with a small tumor in the dome, was not a candidate for embolization or RFA, but was listed for liver transplant. And so we did Sbrt as a bridging therapy. He had a nice CA19-9 response from 29 down to 3, and he's now almost 5 years out in his NED with intact liver function, and has ultimately decided not to undergo liver transplantation at the present time because he's had a good response to treatment. This is a patient with a much larger, a 20 cm tumor with portal vein invasion, treated with proton beam radiotherapy, is now more than 2 years out with an excellent response to the tumor, hypertrophy of the uninvolved left lobe, and good liver function. So in summary, we're seeing increasing data supporting the role of high-dose conformal radiotherapy techniques, predominantly SBRT and proton therapy in the management of HCC. The treatment is well tolerated with low risk of severe toxicity in appropriately selected patients and with careful planning techniques. We can achieve local tumor control in more than 80% of patients. The predominant pattern of failure is outside of the treated lesion, either new lesions within the liver or at extrahepatic sites. And cure is possible in some patients, particularly those with earlier stage disease. Thank you.
Thank you very much, Professor Allmeyer, for an excellent overview and a comparison with other modalities of therapy for EBRT. We'll have question answers at the end of the all the presentations, so please stay with us till the end of the session. And may I now request Professor Kapoor, my co-chairperson, to introduce the next speaker.
Thank you, Dr. Saraswat. Am I audible?
Yes, you are, sir.
Thank you. First of all, I'm thankful to Dr. Ajay and Dr. Sunil Taneja both, who made this excellent seminar, which is happening for last, I think, 1.5 days now. And thanks, Professor Christopher. I think you have made a point for the radiation because most of the BCLC guidelines, they don't introduce it, but we still feel that there is a lot of number of patients who still require radiation, and that is being done day in, day out in many of the centers. So I congratulate you for putting up that thing. And also one thing which is important, which we have shown you in your patient, that many may not require actually the liver transplant once you do a good SBRT in a localized tumor. I think that is marvelous. So I'll invite Professor Satoshi Koda, who is Professor and Chairman, Department of Gastroenterology and Hepatology, Kindai University Faculty of Medicine, Osaka, Japan. I'll request him to go ahead with his slides and show his opinion about the management in such group of patients. Dr. Koda, please.
Oh, thank you very much for a nice introduction. And I'd like to thank for inviting me to INASL 2021. I'd like to share my slide. My topic today is titled TKI in HCC, Solapen, Lenvatinib, and beyond. I'll talk about role of Lenvatinib after first-line Atezolizumab and other TKI therapy in advanced stage HCC. In Japan, this is the history of development of systemic therapy in Japan. In 2009, Solapenib was approved, followed by Regorafenib, Lenvatinib, Ramucirumab, and last year, Atezolizumab and Cabozantinib was approved. So we have 3 first-line agent and 3 second-line agent, and of them, Atezolizumab is the first choice of first-line treatment. So because of this marvelous median OS and hazard ratio, this is the first-line therapy of systemic therapy in worldwide. So what is the role of other TKI? Role of Lenvatinib after first-line Atezolizumab? Because ICIs, including Atezolizumab, are not perfect because there is an early PD, best response is PD is 19%. 19% is a little bit better than ICI monotherapy, like nivolumab or pembrolizumab, like 32 to 37%. But PD patients, best response PD patients, PFS is very short, and also OS is very short. So the patient who with a best response of PD do not benefit from ICI therapy. And ICI resistant subtype include immune exhausted subclass or immune beta-catenin mutated HCC or NASH related HCC. Immune exhausted subclass is this is a subclassification of a cancer or cancer immune microenvironment. Cancer can be classified into 4 types according to CD8 positive T cell or PD-L1 positive T cell. Type 1 is a IO monotherapy is effective because the CD8 positive T cell attack the cancer cell, then PD-L1 is induced by interferon gamma. So PD-1 axis is immune cause the immune escape. So PD-1 monotherapy or ICI monotherapy effective, but this kind of immune microenvironment, which is a CD8 positive T cell, but not so much PD-L1.
इसमें बेटा तुम वो वॉल्यूम कम हो ज्यादा कैसे
suppressive microenvironment. So IO monotherapy is not effective.
बटन दबाओ और
So this is called immune exhausted ICI plus anti-VEGF should be effective. I'll show you one case. This is a 58-year-old male HPV positive HCC with bone metastasis. In 2016, 2 centimeter size HCC was resected by laparoscopic resection. 2 years later, this patient had a metastatic lesion confirmed by biopsy and MRI, and confirmed by histology. So we introduced radiation therapy. So because of the radiation therapy, the PET positive tumor shrinked and very effective. And we started lenvatinib, and stable disease was induced, but still PD on lenvatinib. After PD, we obtained MSI high from the bone biopsy sample. So we started pembrolizumab in order to treat for this lesion. However, the AFP rapidly increased. So we switched lenvatinib again because we thought this is a immune suppressive microenvironment. Actually, we know this is a bone metastasis biopsy sample, CD4 positive, CD8 positive, and PD-L1 positive. So PD-1 monotherapy should be effective, but not in this patient. It was not effective because of FOXP3 is positive, diffusely positive. That means high expression of regulatory T cell. This is an immune suppressive microenvironment. But because the PD-1 activity lasts around 20 months. So this patient is PD-1 plus lenvatinib, the combination therapy, like a combination therapy, similar to combination therapy. So respond very well, and this lesion also shrinked, and FDG accumulation became low. So lenvatinib recurrence therapy is very common in Japan. Lenvatinib ICI lenvatinib sequential therapy, like this patient had lenvatinib as a first-line therapy, but new lesion appeared, so we switched to atezolizumab. But still, progressively, the atezolizumab did not respond. The tumor did not respond to atezolizumab, so we switched to lenvatinib again, rechallenge treatment. Caused almost complete response, and all tumor markers, AFP PBK2 and AFPL3 became normal range. And also this patient, after lenvatinib, the progression on there is no response to atezolizumab, and the rechallenge lenvatinib therapy respond very well. And also this patient, atezolizumab, second line atezolizumab did not respond. But the rechallenge lenvatinib, the tumor became nearly CR per M RECIST. So these subtypes, immune hot tumors, there is the immune suppressive microenvironment in this patient subgroup, and also immune active subclass, ICI lenvatinib sequential therapy is effective, similar to ICI plus lenvatinib ICI or anti-VEGF combination therapy. So ICI lenvatinib sequential therapy is effective. And next, the ACL-resistant tumor is a Wnt beta-catenin mutated HCC. As you know, immune exclusion subclass, Wnt CTNN-B1 mutations cause primary resistance to immune checkpoint inhibitors. ICIs are not effective because ATF3 usually induce chemokine ligand 5 and induce dendritic cell and CD8 positive T cell. But when Wnt beta-catenin mutation is beta-catenin is activated, so ATF3 cannot induce chemokine ligand 5. So this scenario, ICI monotherapy is not effective because of lack of CD8 positive T cell. Actually, there are 3 major driver mutations. Among them, beta-catenin is around 30%. In 30% of when beta-catenin protein is rich in the tumor cell, infiltrative tumor cell is very low. So there is a inversely correlated beta-catenin and T cell infiltration. So lack of a T cell induce ICI resistant tumor. Actually, Dr. James Harding published in Clinical Cancer Research 2 years ago. In 10 patients with beta-catenin mutation, there is no response. However, if there is no mutation, there is a very good, 70% patient respond to the immunotherapy. And also, ICI PFS in beta-catenin mutated HCC, the PFS is much shorter than catenin mutated, no mutations. But sorafenib, in case of sorafenib, targeted agents are effective irrespective of beta-catenin mutation. And recently, the Hiroshima University group found the beta-catenin expression correlates with the high FGFR4 expression using TCGA data set. And also FGFR4 immunohistochemistry, FGFR4 positive tumor response rate is very high, 81%, as compared with negative FGFR4, 31%. And PFS is much longer than negative FGFR4. So FGFR4 high HCC nearly equal to beta-catenin mutation is sensitive to lenvatinib because of FGFR4 suppressive activity is 100 times stronger than sorafenib. So FGF19R4 signaling pathway, lenvatinib is very effective for beta-catenin mutated HCC because of a strong inhibitory effect of FGFR4 signaling pathway. So we checked we have conducted systemic therapy. Among them, 169 patients were treated right after immunotherapy on 36 patients. And also, as I said, ICI is combined with T cell over 20 weeks after discontinuation of ICI, which was shown in non-small cell lung cancer, nivolumab in non-small cell lung cancer. This is after termination. This is a termination. Percent of complete binding is 40%, but 20 weeks, the binding of nivolumab and T lymphocyte lasted more than 20 weeks. So still there is a, after termination, there is still the PD-1 activity. So IO lenvatinib sequential therapy show a very good result as compared with first-line lenvatinib therapy. This is data after ICI, lenvatinib data after ICI. Objective response rate 56%, which is very high, and median OS from lenvatinib is long, 16 months, and median OS from IO first line therapy is 30 months. So when we compared to other the trial Reflect Checkmate 459 in Brave 150, this is even, of course, this is a retrospective and very small numbers of patients, but the second and fourth line of treatment as compared with first line treatment, the response rate and PFS and OS is very comparable with Atezobev, or from the first line therapy, median OS is 30 months, which is very long as compared with other agent. I'll show you one another case. You can see the multiple tumors and the VP3 in the right portal vein and the para-aortic lymph node metastasis, and a huge tumor can be seen. But the ICI treatment, all of the lung metastasis disappeared and VP3 disappeared, para-aortic lymph node disappeared, but the small lesion, the tumor, intrahepatic lesion became small. However, there is still, this did not disappear. And also the new lesion appeared. So we changed to lenvatinib because EOB MRI hepatobiliary phase clearly shows beta-catenin mutation. So we switched to lenvatinib. So this tumor became necrotic and shrinked. So we switched to the conversion surgery. Now currently cancer-free, drug-free status. In this viable tumor, you can see beta-catenin protein is rich, and CD8 positive T cell is excluded from the tumor. This is a typical tumor immune exclusion subclass. And how about NASH-related HCC? NASH immune response to tumor antigen is low in NASH HCC as compared with viral HCC. This is a number of patients. This is a tumor antigen peptide. And the black box is a T cell response, like interferon gamma production, as compared with viral hepatitis, 70% or 76%. NASH HCC is just 33%. And recently, in Nature's March issue, there is 2 reports in the same issue, topic on NASH HCC. This is an autoaggressive CXCR positive T cell, CD8 T cell, is cause liver immune pathology in NASH. And also another paper from the same group, NASH limits anti-tumor surveillance in immunotherapy. So in NASH patients, immunotherapy is not so effective. And using a mouse model, they concluded that lack of response to immunotherapy in NASH HCC patients. And also the 2 validation cohorts, like in the completely different country, NAFLD HCC show a shorter OS in the independent validation cohort. And also the multivariate analysis clearly showed this NAFLD itself is a prognostic factors. Hazard ratio 2.6, survival benefit is poorer in NASH HCC. In contrast, the efficacy of lenvatinib by liver etiology, we compared the NAFLD NASH HCC or viral alcoholic HCC. The PFS is better in NAFLD NASH HCC by lenvatinib, and OS NAFLD NASH is tended to be better. So lenvatinib exhibited better efficacy in NAFLD NASH HCC than non-NAFLD HCC. So lenvatinib is effective after ICI in immune exhausted subclass beta-catenin mutated HCC and NASH HCC as compared with other targeted agent. How about other TKI therapy in advanced stage HCC? This is a Japan Society of Hepatology Clinical Practice guideline updated in this year. After Atezobev, all of the 5 targeted agents candidate for second-line agent, and also NCCN guideline after Atezobev, subsequent line of therapy that they recommend the 5 targeted agents. also ESMO clinical practice guideline. After Atezolizumab, all of 5 targeted agents recommended. Actually, these multi-kinase inhibitor may modulate anti-immune immunity through both angiogenesis-dependent and independent mechanisms like lenvatinib, regorafenib, cabozantinib, and also ramucirumab, and also sorafenib, low-dose sorafenib. The like a CD8 positive T cell increase and the M1 term is increased, but the M2 term or MDSCs or Treg, these are the immunosuppressive cells. So immunomodulation, all TKIs and RAM have an immunomodulation activity. In addition, ramucirumab preserves the liver function completely, so does not impair the liver function. And also in ramucirumab is a very, shows better OS even in most elderly patients older than 75 years old. And also PFS is good in elderly patients. So we compared ramucirumab after progression on Atezolizumab in 11 cases out of 62 cases. All of them are not responder to Atezolizumab, but this is a intrahepatic region. You can see that the high AFP level, we introduced ramucirumab. So tumor size reduction and also AFP reduction were obtained by third-line ramucirumab, like this. Another case, as you can see, right adrenal gland metastasis. And after 6 weeks, the AFP drops and also tumor shrinkage was obtained. So tumor size AFP level reduction in right adrenal gland metastasis. Ramucirumab usually do not respond to, response rate is not so high, but in our study, 18% response rate, which is very high because of after ICI, the immunosuppressive, ramucirumab can change the immunosuppressive microenvironment. And then atezolizumab's activity lasts several months. So similar to combination therapy. And this is an AFP drop. And also PFS OS is very good. This is also true in regorafenib. This is a published case report after sorafenib and PD and the PD on immunotherapy. And but regorafenib show this AFP level decreased and the PR was obtained by regorafenib. So after ICI, the targeted agent is very effective, ICI TKI sequential therapy. And also regorafenib, the tumor necrotic change can be seen, AFP drop can be seen by regorafenib. And the cabozantinib after atezolizumab also can achieve a response. AFP can drop from after atezolizumab. So TKIs after first-line atezolizumab, lenvatinib is the choice of treatment after first-line atezolizumab. For patients with poor liver function, poor PS, or older age, ramucirumab is a choice of treatment, and all of targeted agents have an anti-VEGF activity so that there is an immune modulation effect. In other words, changing tumor microenvironment, suppressive to immune permissive after combination therapy. Rego and Cabo are also the choice of treatment as well. Sorafenib is not indicated after first-line atezolizumab. Thank you very much for your attention.
Thank you, Dr. Kudo. Dr. Santos, will you invite the next speaker? I should go ahead.
Dr. Kapoor, you can go ahead maybe.
Okay, thank you. So I think we are already running short of time. So I'll invite Professor Richard Finn, who is Professor of Medical Oncology from University of California, Los Angeles, and Dr. Finn is going to give his opinion about various medical modalities which are used in the management of I think multifocal or metastatic HCCs. Dr. Finn, please.
Hi there. I'm Dr. Richard Finn from the Geffen School of Medicine at UCLA in Los Angeles, California. And thank you very much for the opportunity to share with you some thoughts on the roles of immunotherapy in liver cancer. I hope you are all well, and I'm sorry we are not together in person. But very exciting topic, and again, thank you. So here are my disclosures. So we've made a lot of progress in liver cancer, but much of it has happened in the past few years. We know that sorafenib, the multikinase inhibitor, was approved in 2007 based on survival advantage versus placebo for patients with advanced liver cancer. And when we're talking about advanced liver cancer, we're talking really about Barcelona stage C, patients who have extrahepatic spread or vascular invasion. So these are patients who can have tumor burden within the liver only, but is invading into the vasculature. But advanced liver cancer can also include patients who have Barcelona B or intermediate liver cancer. And these are patients who typically would get local regional treatment such as TACE, but they progress on TACE, but do not develop intrahepatic vascular invasion or extrahepatic spread, but just have recurrent disease after TACE. Needless to say, there's several drugs that have been approved by the FDA to manage this disease since 2017. In the front line, we've seen lenvatinib and more recently atezolizumab and bevacizumab approved. And in the second line, based on phase 3 data, we have regorafenib, cabozantinib, and ramucirumab, all compared to best supportive care after prior sorafenib. None of these have really been well studied after prior lenvatinib or more recently atezolizumab and bevacizumab. In the US, we also have immunotherapy agents approved in second line after prior sorafenib. And these were really approved on accelerated approval mechanisms. And this includes single agent nivolumab, pembrolizumab, and the combination of nivolumab and ipilimumab. Now, single agent nivolumab recently had its approval pulled given a negative confirmatory study. But we'll focus now on the immunotherapy approvals, where they are now, what we're waiting for in the future, and some unmet needs. So when we talk about targeting the immune system or immunotherapy, really we're talking about drugs that target various immune checkpoints. There's two that have been validated and have drugs approved. The first being monoclonal antibodies that target CTLA-4, which is involved in the immune priming phase, and monoclonal antibodies such as ipilimumab have been shown to block the interaction between CTLA-4 and its ligand, and by doing so, stimulates an immune response against cancer. Tremelimumab, another CTLA-4 inhibitor that we'll talk about, another monoclonal antibody, currently is not FDA approved for any indication. Now, in the immune activation phase, many drugs exist that target the PD-1 and PD-L1 axis. As you know, PD-1's interaction with PD-L1 tends to downregulate T cells, so they do not induce an anti-tumor effect. Now, several monoclonal antibodies have been designed that interrupt this axis, and there's many, but for the sake of our discussion today, there's atezolizumab and durvalumab, which are monoclonals to PD-L1, and then pembrolizumab and nivolumab, which are monoclonals to PD-1. Now, the first PD-1 inhibitor to be looked at in liver cancer was nivolumab, and this was done in a phase 1b study after prior sorafenib. And they showed that regardless of etiology, Hep B, Hep C, or non-viral etiologies, there was an objective response rate of about 15%. And importantly, these were very deep and durable responses. And based on this, the FDA gave nivolumab accelerated approval. Now, what was reassuring about this data set is that fears about autoimmune hepatitis or increased hepatic toxicity were mitigated. And if you look here at all treatment-related adverse events, you can see that For hepatic, as far as high-grade events, there were only 4%. So really 6 out of 154 patients had serious grade hepatic events. And then they were lower grade. And typically these occur within the first few weeks of treatment, within the first 2 or 3 months. But we also see many other well-characterized immune-related adverse events in liver cancer patients, just like in lung or melanoma patients or other diseases. Often these are hypo or hyperthyroidism, but really any organ system can be affected. But overall, the incidence was fairly low grade for all of these. Now, the confirmatory study was Checkmate 459. This was a frontline open label study of nivolumab versus sorafenib for patients with advanced liver cancer as we defined. So not eligible for surgical and or local regional treatments or progressive disease after those. As in all phase 3 studies in liver cancer, we concentrate on Child-Pugh class A. Now you can see here that the survival curves, the primary endpoint, virtually overlap. Median survival was about 14.7 months with sorafenib and 16.4 months with nivolumab. Hazard ratio was 0.85, and the p-value was non-significant. This was a big disappointment to many of us, given the activity of nivolumab we saw from early phase studies, and that sorafenib does improve survival, but it generally does it by inducing stable disease. Now, we did confirm the objective response rate of nivolumab in this study. Again, an objective response rate of 15%, dead on what we saw in the phase 1 study, and a long duration of response. And again, single agent nivolumab was well tolerated. You can see here in pink, the sorafenib toxicities, in blue, nivolumab, light color are grades 1 and 2, and dark colors are grades 3 and 4 or more serious. And you can see that the side effect profile really favors nivolumab in degree of toxicity and type of toxicities. Again, with sorafenib, diarrhea being a big problem, as well as hand-foot skin syndrome. Now, pembrolizumab was looked at in a phase 1b second-line setting and really looked just like nivolumab. Objective response rates of about 18%, and these were of long duration. And again, no new safety signals in a liver population. This led to the Keynote 240 study, which was the confirmatory study, but instead of going frontline like nivolumab, pembro was evaluated in second line versus placebo. And this is probably the last placebo-controlled second-line study to be done, given that, during this study, several of the other phase 3 studies read out as positive. And we showed that the objective response rate in this population was 18% with a long duration of response. And here you see one of the primary endpoints of overall survival. 10.6 months versus placebo versus just under 14 months with pembro. Hazard ratio is 0.78. Upper limit of the confidence interval was less than 1, and the p-value was 0.0238. However, to be considered positive, it had to be 0.0174. And so this study just missed statistical significance, though clearly demonstrated clinical activity. And recently there was this press release that the Keynote 394 study, another placebo-controlled study for pembro in second line, but done exclusively in Asia, did meet its endpoints of improving overall survival, as well as improving PFS and objective response rate with no new safety. So we're now waiting to see these results, but presumably these are confirmatory to the activity of pembrolizumab in the second line setting. And we're still waiting for this study of tislelizumab, another PD-1 antibody that's being compared head-to-head to sorafenib. The unique thing about this study is, unlike Checkmate 459, which was a superiority study, this study is also powered for non-inferiority. And should that meet its endpoint, I think the safety of tislelizumab and quality of life will probably be superior to sorafenib. And this might be another option for patients if we meet that endpoint. So, given the negative, borderline negative, positive single agent studies with PD-1 inhibitors, there was an interest in combining these drugs with other mechanisms of action to increase the response rates and therefore hopefully improve survival. So one of the avenues that's been pursued has been combining PD-L1 inhibition or PD-1 inhibition, such as with atezolizumab, with anti-angiogenic agents. Bevacizumab, a monoclonal antibody to the VEGF, vascular endothelial growth factor, is approved in oncology in colon cancer, lung cancer, ovarian cancer. And initially, the feeling was that bevacizumab normalizes tumor vasculature and therefore starves the tumor of a blood supply. However, our understanding of its effects have matured over time, and now we can appreciate that targeting VEGF, the VEGF axis, actually affects the immune microenvironment and decreases the activity and presence of immunosuppressive cells. And then in combination with a drug like atezolizumab, we can restore anti-cancer immunity and potentially see synergy. This concept was tested in the IMbrave 150 study, which has since been published in the New England Journal of Medicine last year, and also was the basis for the FDA approval of this regimen in liver cancer globally. And again, unresectable liver cancer patients randomized to atezo-bev IV every 3 weeks versus sorafenib in a 2-to-1 ratio. This was a well-balanced study. The majority of patients came from outside of Asia. By design, they were all Child-Pugh-A. You can see the majority of them were Barcelona C, with a subset that were the intermediate Bs that were refractory to TACE. And all the etiologies of hepatitis were included. Now, this study met both its primary endpoints of improving PFS and OS. In the initial presentation, we had not hit the true median OS with atezolizumab and bevacizumab, but we saw over 40% decrease in the risk of death with a hazard ratio of 0.58, and similarly a decrease in the risk of progression with a hazard ratio of 0.59. Earlier this year, we presented updated survival data, and we see now that with atezo-bev, the median survival is 19.2 months in frontline liver cancer. And this is really the benchmark that we look to improve upon as we move forward. And what was very satisfying now is that we have a fairly high response rate, 30% objective response rate by RECIST criteria, as compared to the 15 to 18% we saw with single agent IO, immuno-oncology agents, and again, a long duration of response. And this includes about 8% of patients who have actually a complete response, or their tumor completely disappears. Now, this obviously needs to be a balance against adverse events. And we see here the side effect profile of atezo and sorafenib. And you can see that, all grade adverse events were very similar between both arms, as well as more serious grade 3 or 4 events. Grade 5 or death events were similar, if anything, a little higher with sorafenib. And serious adverse events were higher with atezo-bev, but keep in mind, patients were on atezo-bev for a longer period of time. And discontinuations were 10% for sorafenib, and 7% of patients had to completely discontinue atezo and bev. And here you see the side effect profile, like we've seen with other IO studies, as compared to sorafenib, where you have a high frequency of diarrhea, hand-foot skin syndrome, anorexia. With atezo-bev, while we do see immune-related adverse events, the majority of the side effects comes from the VEGF component, or bevacizumab, and we see more hypertension as well as proteinuria, both things that can be managed. And here you see treatment-related adverse events, again, a very similar pattern. Still, you see hypertension with sorafenib, but not as frequent or as intense. Now, because bevacizumab is an anti-VEGF agent and has been associated with bleeding, all patients coming on study had to have an upper endoscopy within 6 months. And if they were high risk for bleeding, had large varices or recently bleeding varices, they were excluded. But patients could have had varices that were not bleeding. If they were banded, they could come on study. And we know about 25% of patients in both arms had varices, and a little over 10% of patients in each arm had them banded before coming on study. Now, by doing so, we really mitigated any serious adverse events related to GI bleeding. There were a few grade 5 events. You can see here there were 4 patients that had a fatal event, or 1.2%. If we look at grade 3, 4 events, there was 3% with atezo-bev and 2.5% with sorafenib. And the patients who have higher degree bleeding risk with atezo-bev tended to be those who had main portal vein invasion, so extrahepatic portal vein invasion. And obviously those patients are at risk for more portal hypertension. And if we look at all grade bleeding events, the majority of these, while higher with atezo-bev, they're driven mostly by epistaxis, hematuria, gingival bleeding. Grade 3-4 events were fairly similar between both arms. So the ORIENT-32 study was a very similar design with a PD-1 inhibitor, sintilimab, in combination with a VEGF antibody, a biosimilar to bevacizumab, versus sorafenib, and this was done in an only Asian population. And here we see a very similar result, hazard ratio of 0.57 for OS and PFS. Objective response rate was a little lower at 20%, and treatment-related adverse events very similar to sorafenib, if not a little better. So this actually confirms, I think, this approach in liver cancer. But one of the questions is this synergy unique to targeting PD-L1 and VEGF, or will we see this activity when we combine IO agents with VEGF receptor kinase inhibitors? And is it really the same population of patients who respond to atezo-bev versus PD-1 and VEGF receptor TKIs? And then will there be a role for sequencing? So lenvatinib is approved in the frontline setting. It's a multi-kinase inhibitor, very potent against the VEGF receptor, as well as the fibroblast growth factor receptor. And you can see here that by inhibiting these various proteins, we can have effects on the microenvironment and angiogenesis. And this drug met its primary endpoint in frontline as being non-inferior to sorafenib, and this has led to its global approval in that setting. And we've shown in people that lenvatinib in red versus sorafenib in blue has a more potent effect and a broader effect on various anti-angiogenic signaling proteins, and therefore may have some effect on the immune microenvironment. And we looked at lenvatinib in combination with pembrolizumab in a frontline setting, a phase 1b study, and showed an objective response rate of 36%, a very high disease control rate, and a median survival of 22 months, which is very favorable, I think, for a single-arm phase 1b study. And for those patients who had a response, a very long duration of response. And most of the toxicity with this combination is related to lenvatinib, and you see that displayed here. And this regimen is now in a frontline study, the LEAP-002 study, and we're waiting for these results. Cabozantinib, another VEGF receptor kinase inhibitor that also hits some other proteins, c-MET and AXL and RET. It's approved in second line based on the study displayed here that showed an improvement in overall survival, and was combined with cabozantinib in the COSMIC 312 study. This study was just presented at the ESMO Asia meeting last week, and concentrating on the first two columns. In this study, again, the majority of patients came from outside of Asia, and as a sense here, there was not as much hepatitis B accrual. Interestingly, there was a lot more intermediate patients arm. This study met its PFS endpoint with a hazard ratio of 0.63. You can see the delta here. However, at the first interim analysis, and this data is not yet mature, you can see really no difference in overall survival. And quite surprisingly, the objective response rate was only 11%, as compared to higher ones we saw with Embrave 150 or even with Len-Pembro. But the regimen was safe. Really, most of the toxicity, I think, was similar to what we've seen with other TKI combos. Really no new signals for toxicity. And here you see the summary of the adverse events, again, being dominated by the VEGF receptor component. Regorafenib, another TKI that hits many kinases in the tumor cells and microenvironment, has been approved in second line based on the resource study shown here, improving survival versus placebo. And it also is being studied in a phase 1b study here in combination with pembrolizumab, and again, showing partial response rates of 30% with 2 different doses of regorafenib, trying to mitigate the toxicity from the TKI. And this is moving into phase 3 studies as well. And in Asia, also pembrolizumab and apatinib have been looked at in both frontline and second-line single-arm cohorts. And again, response rates in the 30% in frontline, 20% second line. And these are long duration responses. And some other studies of many different PD-1 inhibitors and TKIs being looked at, all showing interesting activity. Now, the next phase is looking at 2 checkpoint inhibitors. Here, PD-1 inhibition and CTLA-4 inhibition. This is a study done in patients after prior sorafenib, and 3 different dosing regimens of ipi-nivo were looked at. All of them gave very similar response rates in the 30% range. This arm A got accelerated approval and demonstrated a survival of 23 months in second line. And these are all long duration of response. The thing is, when we combine 2 IO agents, we actually see more toxicity. And you can see here grade 3-4 events for arm A was 53%. And about half these patients needed steroids for immune-related adverse events. Nevertheless, this combination is approved in second line after prior sorafenib in the United States, and the confirmatory study is looking at ipi-nivo versus TKI in the frontline setting. And also tremelimumab and durvalumab, another CTLA-4 and PD-L1 antibody being looked at in this phase 2 study and mostly second line, showed objective response rates of around 24% with this high dose tremelimumab and a provocative survival of 18.7 months. Unlike ipi-nivo, the incidence of grade 3-4 adverse events was a little less, more similar to other combinations, 38% here. And again, these are mostly immune mediated, given they're both monoclonal antibodies. And this is being looked at in the Himalaya study of durva, tremi versus sorafenib. There were some other exploratory arms, but really these bottom 2 arms are the main endpoints. And there was a press release that said in October that this study met its endpoints of improving survival. So in closing, we have many options now for patients with unresectable liver cancer. In the future, on the bottom here, you can see many of these immuno-oncology regimens are being looked at in earlier stage disease in combination with TACE after resection in the adjuvant setting, and a very exciting time. And clearly, biomarker work is ongoing to try to identify if there is a specific subgroup that might benefit more from one regimen or the other. So in conclusion, I know I went over time a little bit, that we have many new options. Immunotherapy is here to stay. It's really changing the natural history, I think, of liver cancer, and a lot of questions and studies we're waiting to hear about. I just want to acknowledge all my colleagues at UCLA who have been very supportive. We have a great multidisciplinary program, and I'm going to close with that. And I wish you all to stay well and hope to see you all in person in the near future. Thank you for having me. Take care.
Well, thank you, Professor Finn, for an extensive and an excellent overview of the field of immunotherapy. In fact, we seem to be spoiled for choices and flooded with options as far as immunotherapy, individual or combinations are concerned. Now, in this session, we have a couple of more talks, and I guess we'll have question answers at the end of the session and in comments. So we move on to the next talk in the session, and this will be by Professor Shalimar on combination of systemic therapy with loco-regional therapies for HCC. All of us know Shalimar very well. He is an additional professor in the Department of Gastroenterology at the All India Institute of Medical Sciences in New Delhi. Dr. Shalimar, please.
Thank you, sir, for the kind introduction. At the outset, I'd like to thank Professor Duseja and Dr. Sunil Taneja for this kind invitation, and congratulations to the entire PGI team for organizing this excellent single theme conference on HCC, which has been a real feast and with excellent discussions. So my task is cut out is to talk to you on combinations, and Professor Kudo and Professor Finn have made my task quite simple, because what they have shown is I'll try not to repeat any of those data and show what is the data on systemic therapy. So outline of my talk would be to talk to you on the rationale for combination behind systemic and loco-regional therapies. What is the data available from the published studies, predominantly randomized controlled trials on combination therapies? The limitations of the existing studies, and what do we look for in the future studies on combination therapies? So this is the BCLC 2022, which you've been seeing this slide multiple times since yesterday. So what I want to highlight out here is the intermediate stage and the advanced stage, which I would be highlighting in the data which I'm going to present. Another fact which I want you to note is that the recent BCLC 2022 has incorporated radioembolization. So I'll take you through some data on radioembolization and systemic chemotherapy. What also additional fact I want to highlight is that the ablative therapies include over here, as per the BCLC, include RFA, transarterial chemoembolization, Sbrt or radioembolization, and for the advanced stage, we have systemic therapies. BCLC or other guidelines do not recommend for combination therapy. So this is what we are looking at. Loco-regional therapies in form of radiofrequency ablation, transarterial chemoembolization, TARE or Sbrt, combined with systemic therapies, which have been talked in the prior talks, includes the TKIs and the immune checkpoint inhibitors. So does the combination of these two leads to benefits versus the side effects? So what is the rationale behind loco-regional therapies? A combination that is TACE out here is going to cause ischemia, plus in addition, the chemotherapy is going to have its anti-cytotoxic effect on the tumor cells. The hypoxia which occurs post-embolization leads to neoangiogenesis, secondary to increased VEGF and other angiogenic pathways, which in turn promotes revascularization and growth of the residual tumor. So to take care of this, combining with anti-angiogenic agents like sorafenib, does it lead to any benefit in the outcomes of patients? An important point to remember is when we are combining therapies, there are multiple variables which come into play, and these need to be kept in mind. The combinations can be sequential, so a loco-regional therapy followed by systemic therapy, interrupted. You give sorafenib first, give an interrupted break, followed by TACE or Sbrt, followed again by sorafenib, or continuous. You continue sorafenib and then give TACE or Sbrt, followed by you continue sorafenib. So let's look into what is the available data in the literature about these combinations. First, I'm going to take you through the combination of sorafenib with TACE versus sorafenib alone. This was an interesting study. That's the phase 3 STAR trial published in Journal of Hepatology. Total of 300 odd patients randomized into two arms, sorafenib alone versus TACE plus sorafenib. Important to note out here, sorafenib was started 3 to 28 days after the session of transarterial chemoembolization. What this study showed us is that there was no benefit in overall survival between the two arms, but there was a benefit in time to tumor progression and progression-free survival. This was an interesting propensity score analysis published from the United States, a large sample size data of almost like 5,000 patients. The authors looked at and compared the two groups, that is sorafenib with transarterial chemoembolization versus sorafenib alone. In the unadjusted analysis, there was a significant difference in the survival, and survival was better in the group which received sorafenib and TACE as compared to those who received sorafenib alone. On propensity score analysis for variables like the child puke class, the BCLC stage, MELD score, and previous sessions of transarterial chemoembolization. After PSM analysis also, the survival was better in patients who received sorafenib plus transarterial chemoembolization versus sorafenib alone. Importantly, on the further analysis, the authors concluded that the benefit was more among those patients who had a MELD score less than 15, platelet count more than 50,000, and those who had more than 3 tumors with or without macrovascular invasion, without local invasion or metastasis. This is a meta-analysis which included retrospective studies and the randomized controlled trial. And what the authors showed out here is that both overall survival and time to tumor progression was better when a combination of TACE and sorafenib was used as compared to sorafenib alone. Now I'll take you through the data available from the randomized controlled trials on studies which have compared TACE plus sorafenib versus TACE alone. This was a multi-center study from the United Kingdom, which included almost 300 patients, a randomized controlled trial. Sorafenib was given within 24 hours of randomization. And these patients underwent TACE after 2 to 5 weeks of randomization. The data suggests that there was no difference in the overall survival or in the progression-free survival between the groups TACE plus sorafenib versus TACE plus placebo, suggesting there is no additional benefit of giving sorafenib or combining sorafenib with TACE as compared to TACE alone from this data. An interesting study over here from the Japanese and Korean patients, which Professor Kudo would definitely give his comments. And what this study included was also a randomized controlled trial, 500 patients included, underwent TACE. Randomization was done 1 to 3 months after 1 or 2 sessions of TACE. They were started on sorafenib. The study shows that there was no benefit both in overall survival and progression-free survival in patients who were given sorafenib versus those who were given placebo. So another study suggesting no benefit of combination. This is a study by Professor Kudo published in Cut. And this study is a randomized controlled trial, included 197 patients, randomized to TACE with sorafenib versus TACE alone. So this is the study protocol is very different from the other studies which I have shown previously. In this study, sorafenib was started 2 to 3 weeks before the conventional TACE was given. And what the authors analyzed, the study design was different, and overall survival was not analyzed in this study. But what they showed out here is that the progression-free survival and time to tumor progression was better in the combination group of TACE plus sorafenib versus TACE alone. And this is the only trial, that's the randomized controlled trial, which has shown positive results of a combination therapy. But the limitations being it's a small sample size study and needs validation across other centers before it can be used routinely for management of patients. So this is another randomized controlled trial of use of adjuvant sorafenib for HCC after resection of ablation. So we are moving from the intermediate stage to now those patients who have undergone resection or ablation. So let's look at what does this study showed. Again, the addition of sorafenib did not have any improvement in terms of overall survival in these patients and also did not have any effect on recurrence-free survival. When the data was categorized into those who underwent ablation versus surgical resection, sorafenib didn't show any additional benefit. This meta-analysis, which is a little old, included retrospective studies and a single randomized controlled trial, and concluded that though the combination was safe, and overall the survival and the objective response rate was better in those who received combination compared to those who received TACE alone. So what is the data on TACE plus bevacizumab? So this study, though a small sample size study of just 32 patients, did not show any significant benefit in terms of survival in patients, those who received TACE plus bevacizumab as compared to those who received TACE alone. Both survival and radiological response rates were not of any difference. So what is the data on Sbrt, that is TARE? So let's see, what does this study show? This is another randomized controlled trial, the ceramic trial. Sorafenib was started on day 3 of the last Sbrt episode. Again, the results show that there was no benefit of addition of sorafenib to Sbrt compared to Sbrt alone in terms of overall survival. And none of the predictors of any categories which was used for analyzing the difference showed any kind of benefit. Coming to another randomized controlled trial on the role of addition of sorafenib to hepatic arterial infusion chemotherapy. So addition of sorafenib over here also in this randomized controlled trial didn't show any overall benefit, and the study was done by Professor Kudo. So the key points till now, what we have discussed, on locoregional therapies, either TACE, TARE, or ablation, addition of sorafenib, bevacizumab, or other drugs has no survival benefits. What these studies also show that you will add up more side effects. But important to keep in mind the limitations of these available studies is that the sorafenib dose, timing, duration of administration, sequencing of sorafenib with locoregional therapies, and the drugs used in TACE vary across studies. In addition, what we have been discussing since morning is the selection of patients in tumor biology has not been accounted and compared across studies. And this definitely would have affected the outcomes in these studies, making the comparisons difficult. So another interesting concept which is now coming up is, can we combine locoregional therapies with immune checkpoint inhibitors? We've heard about this. I'll not take you things in these details, but what locoregional therapy does is it changes the tumor immunity, as we've heard from Professor Kudo and Professor Finn. And this necrosis of the tumor cells leads to release of these inflammatory cytokines, activation of the antigen-presenting cells, enhanced dendritic cells, T cell priming, and then you're making a tumor which is resistant to more which is more responsive to immunotherapy. So that lays the sound basis whether combination of TACE and TARE with immune checkpoint inhibitors could lead to improved outcomes in these patients with HCCs. In addition, as another concept, what you already heard is about combination of TKIs with immune checkpoint inhibitors. And what Professor Kudo alluded excellently in his talk was, by blocking these different pathways, you are actually eventually making an immunologically cold tumor into something like a hot tumor, and which is characterized by more dendritic cells, more inflammatory cells, and then probably more responsive to immune checkpoint blockade. And maybe we need to see with time whether such kind of combinations would be beneficial. Unfortunately, we do not have randomized controlled trials at present, and there is a lot of studies which are ongoing, and especially I'd like to highlight these ongoing randomized controlled trials, which are being used in patients who are undergoing locoregional therapies, and these combinations are being tried. That includes durvalumab with bevacizumab, nivolumab plus deptase, lenvatinib plus pembrolizumab, nivolumab plus ipilimumab, and in combination with conventional TACE. So I think we need more data from these studies before we start recommending the use of these combinations in clinical practice. Till the time more trials are going on and these patients can be considered individually on case-to-case basis, whether you want to combine these agents along with the loco-regional therapies. In addition, other trials are going on in patients as adjuvant therapy after resection and ablation, and these include the immune checkpoint inhibitors as highlighted over here. So the key messages from the talk include the combination of local and systemic therapies, that is stair ablation with TKIs, and the data presently is on sorafenib, though theoretically sound, but have not shown clinical benefit. We don't have much data on lenvatinib, but whatever data is available in sorafenib doesn't show these combinations to be of benefit. Combination of loco-regional therapy with immunotherapy, I feel the results of the randomized control trial, once they are there, and we eagerly look forward to them before, so that can lead us to more better patient management and improving the outcomes of these patients with HCCs. And what's more important is the future trials, which are going to, it's important that carefully selected candidates are used, tumor biology is taken into account, what kind of sequences to use, which drug is going to be used first, and what combination, after how many days, and what are the assessment of response, what criteria would be used. Those are very important points when we're looking at such new drug trials and new data once those comes in. And right now, we still don't know who are these ideal candidates who are going to respond to these combination therapies. Are there any kind of biomarkers, any kind of tumor markers, any kind of levels, PD-1, PD-L1, what kind of patient characteristics, host characteristic etiologies are responsible, and which could influence the outcomes and help us in choosing the ideal candidates for response. That needs to be seen with time. So that's how the precision medicine is going to go forward. With this, I'd like to end my talk. Thank you for your patient hearing.
Well, thank you, Shalimar. That was an excellent overview of an area of which has always been very intriguing about the combinations of loco-regional therapies and systemic therapies. And I guess we'll be hearing more about this in the coming days. I see Professor Rakesh Kapoor is there. So could you please invite the last speaker, Dr. Kapoor?
Thank you, sir. Now I'll invite Dr. Kaushal Madan, who is Director and Head Clinical Hepatology, Max Super Specialty Hospital, Saket, New Delhi. Dr. Madan, please.
Good evening, everyone. Are my slides visible?
Yeah, sir. They're visible.
Thank you for a kind introduction by this chairperson, and thanks to Dr. Duseja and INASL for inviting me to this very interesting single theme meeting. So I've been asked to speak on biomarkers of response to systemic therapy. And you would have realized by now that my job has been made easy by the previous speakers, specifically Dr. Kudo and Dr. Finn. So you all know that these are the guidelines, both the ASCO guidelines and the recent BCLC 2022 update, which suggests that the first line of therapy is a combination of immune checkpoint blockers with VEGFR, or if not feasible, then sorafenib or lenvatinib, followed by second line, followed by third line. So why do we need biomarkers for these therapies? The answer is to select out best suited subgroups to maximize efficacy and minimize harm to the patient. So why I am saying all this, let's see. So the problem with systemic therapies, both TKIs and immune checkpoint blockers, is very low response rates. Although when we talk about in oncology terms, even these small response rates go a long way to develop the field of oncology in a particular tumor. But still, overall, when we look, these response rates are quite low. So let's look at this first SHARP trial of sorafenib, the first drug which got approved because of its effect in reducing improving overall survival in HCC. Look at this: complete response rate 0%, partial response rate 2%. Why this was effective? Because it led to a stable disease. Let's look at checkpoint inhibitors. Nivolumab, checkmate 040, objective response rate of only 20%. Even if we add the response rate of total stable disease of 45%, 55% patients did not respond. So if you give this drug to all 100% patients, in 55% patient, it will be a useless exercise. Similarly, Dr. Finn talked about IMBRAVE, a combination of immune checkpoint inhibitors with a VEGF blocker. It definitely doubled the response rate, but still more than 55%, more than 50% patients did not respond. So you have very effective drugs, but effective in a small proportion of patients. Then the issue of significant immune-related adverse events, specifically with immune checkpoint blockers. You already know about what happened to sorafenib, especially in Indians. All the hepatologists who practice in India, they all know that it leads to debilitating hand and foot syndrome, and almost 80% of our patients are not able to continue sorafenib beyond a certain point, and that too in very low doses. The recommended full doses of sorafenib are not tolerated by Indian patients. ICBs also have significant side effects, specifically autoimmune. Here we are talking about liver. Yes, it leads to autoimmune liver injury with a rise in AST, ALT levels, most notably with anti-CTLA-4. Most notably with anti-CTLA-4, and least with anti-PD-L1 plus VEGF combinations. And not only liver toxicity, there is autoimmune mediated toxicity in other organs also, specifically GI. It leads to inflammatory bowel disease, worsening of inflammatory bowel disease, skin side effect, endocrinology, as well as in the pulmonary system. Then a very unique adverse event, unique for immune checkpoint blockers, is the hyperprogression. About 8% of patients with HCC have been shown to have hyperprogression of disease or accelerated progression of disease while on immune checkpoint blockers. And this is similar to previously reported 9% in other form of solid tumors on immune checkpoint blockers. Why this happens, no one really knows. There are postulated molecular mechanisms, but we'll not talk about them right now. And finally, the cost. You look at the cost. The monthly cost for nivolumab, these are unsubsidized cost. For nivolumab is about 4 lakh rupees per month, and atozo-beva combination, it is about 3 lakhs per month to achieve a response rate of about 20 to 36%. So in all other patients, that is 76% patients or 70% patients, you will be using or making the patient spend so much money without any response rates. So it's important to select out patients, if possible, who will respond well to these expensive therapies with associated side effects. So the first example of systemic therapy in HCC in which there was a biomarker which could tell whether this patient would respond to was ramucirumab, because in the phase 1 and phase 2 study, patients who had alpha-fetoprotein more than 400 were the ones who were having a higher objective response and a better progression-free survival as compared to those in which the alpha-fetoprotein was less than 400. But this is second-line therapy. Let's talk about the first-line therapies. So the biomarkers could be of two types: tissue-based, in which you need to subject the tissue to genomic analysis, or serum plasma-based. Very easy if we can have these ones, but let's look at the slides which are coming. So the biomarkers can be used for TKIs, so for sorafenib or lenvatinib. So this was a study, I think Dr. Kudo also alluded to this, in which 81 sorafenib treated tumors were subjected to next generation sequencing with looking out for mutations, and they found that the upregulation of PI3K mTOR pathway predicted poor prognosis. So the tumors in which the PI3K pathway was activated had a very poor progression-free survival as well as overall survival as compared to those in which this pathway was not activated. What about biomarkers for immune checkpoint blockers? So intuitively speaking, since these immune checkpoint blockers block PD-1 or PD-L1, so intuitively speaking, if you are able to detect expression of PD-1 or PD-L1, you may be able to get an impression whether these patients will respond to this or not. But is it so clinically? Actually, that's true in most other solid form of tumors in which ICBs have been used. However, look at this data. Although the data is small, this is a data from phase 2 trial of nivolumab. So the patients were divided into those in which the PD-L1 expression was more than 1% in tumor cells versus less than 1%. And look at the response rate, statistically not different whether the PD-L1 expression was high or low. Another study of pembrolizumab, phase 2 open label study, pembrolizumab in sorafenib treated patients. 52 patients had data related to PD-L1 expression in the tumor cells, and the tumor proportion score more than 1% versus less than 1%, no statistically different response rate. So although these drugs target PD-1 or PD-L1, their expression has no effect on the response rates. So that's a limitation in HCC. Second, pan-oncology. That means in almost all tumors, if the tumor mutational burden is high or the macrosatellite instability is high, these are the patients who respond very well or they respond well to immune checkpoint blockers. But let's see whether that's true in HCC. So this was the data on 756 HCC patients. 203 were viral etiologies, 46% had extrahepatic spread. Look at this, high tumor mutational burden or high MSI present only in 0.8 or 0.2% tumors. So you cannot use it. The prevalence of high tumor mutational burden or high MSI is very, very low in HCCs. Another study highlighting the same point, microsatellite instability studied in more than 11,000 tumor normal tissue pairs across 39 tumor types. And look at this. In HCC, high MSI was present only in less than 1% patients. So you cannot rely on MSI or tumor mutational burden to decide whether your patient will respond to immune checkpoint blockers or not. So what are the other markers? Dr. Kudo again talked a lot about Wnt beta-catenin signaling. So the same study by Harding, 31 patients who had received immune checkpoint blockers, the tumors underwent next generation sequencing, and Wnt beta-catenin pathway alterations were associated with poor outcomes. So this is the progression-free survival. Patients who had altered Wnt beta-catenin activity, the progression-free survival was significantly lower as compared to those in which it was unaltered. Further, the overall survival as well as the disease control rate was significantly lower in patients who had these mutations as compared to those who did not have these mutations. Now, this is a very elegant study. I'll just take 2 minutes here. Elegant study done in animals and in vitro, in which they took a mouse model of HCC, introduced external antigens. So what happens when they introduce external antigen? It leads to an immune response. So that led to delayed tumor formation. So patients in which external antigens were introduced, their survival, not the patients, the animals, the mice, their survival was significantly better than those in which the external antigens were not introduced. However, this was reversed when the same experiment was done in T-cell depleted mice, suggesting that it is the tumor inflammation driven by an antigenic stimulus which leads to clearance of tumor formation. Then they found that even among the antigenically stimulated mice, there were some mice who still developed tumors. These were labeled as immune escaped HCC. And this immune escaped HCC were shown to have an activation of Wnt beta-catenin signaling, again suggesting that this is associated with poor response rate tumors and poor immunology, poor inflammation in the tumor. And this was mediated by impaired recruitment of dendritic cells, and this could be reversed also by expression of chemokine CCL5. So this was all dynamic and could be manipulated. Further, they found that when murine anti-PD-1 antibodies were used, they were able to salvage these mice and the survival was better. But in the beta-catenin activated mice, the anti-PD-1 antibodies did not have any response. Again, linking beta-catenin to poor response rates to anti-PD-1 antibodies, albeit in a mice model. So this led to, there have been other classifications also, another immunological classification of HCC, in which there were 3 groups: T-cell infiltrated tumors, also called immune tumors, also called hot tumors, immune intermediate, and T-cell non-infiltrated tumors, which constitute about 25%. These were called cold tumors, and again, they were enriched in activation of beta-catenin pathway. So that brings us to the next candidate for a biomarker, and this is the TGF-beta signaling. So this is in this particular study, 956 HCC patients, they were able to detect a new class of HCC, again in 25%, called the immune class. They labeled it as immune class, which were enriched in immune cells, showed enhanced cytolytic activity and enhanced PD-1, PD-L1 expression. And then there were 2 subgroups. One was active immune response, the other was exhausted immune response. And they showed that the patients, the HCCs in which there were active immune response, their overall survival was significantly better than the rest of the tumors. Further, the patients in whom the exhausted immune response tumors were there was increased TGF-beta signaling, suggesting that TGF-beta signaling inhibits inflammation and immune responses within the tumors and makes their prognosis poor and possibly poorly responsive to immune checkpoint blockers. So to test that, this was a study in 24 patients with advanced HCC who received pembrolizumab. And look at this. So this is a serum marker. They found that both the overall survival and progression-free survival was significantly better in the group in which the TGF-beta levels were less than 200 picogram per ml as compared to those who had higher TGF-beta levels. So it is the TGF-beta which was causing some problems with the inflammation and immune response within the tumor microenvironment. So even in cases of TKIs in sorafenib, this is how TGF led to resistance to sorafenib use. So sorafenib inhibits RAF kinase. TGF stimulates expression of all growth factor receptors, EGFR, IGFR, FGFR, and PDGFR. So while sorafenib was inhibiting this, TGF-beta stimulated expression of this, released this tumor cell from effect of sorafenib, again leading to resistance to sorafenib use. And if that is so, can TGF blockade result in improved survival or improved tumor responses? This was a study in 47 patients. TGF-beta inhibitor galunisertib was combined with sorafenib, and there were patients in which 20% reduction in TGF levels were achieved. These were called responders. And look at this. Patients who were responders and had a reduction in 20% levels of TGF-beta had a better survival probability as compared to those in which those who were non-responders. Sorry. So these were biomarkers. What about gross? What about something more clinical? So what about etiology? Dr. Kudo again alluded to this. NASH versus viral etiology. We all know that NASH related HCC is going to overtake most of the other etiologies of HCC. Looking at this data, by 2030, there would be a 130% rise in HCC related to non-alcoholic steatohepatitis. And it has been shown that NAFLD reshapes immune microenvironment within the tumors by reduced presence of anti-tumor CD4 positive cells, T cells. This was a study in Nature which suggested that the CD4-CD8 ratio was significantly higher in viral etiologies as compared to NASH as an etiology. And this is a latest Nature paper. Again, Dr. Kudo is one of the co-authors. NASH-related HCC, the initial and a series of experiments in animals and in vitro showed that there was abundance of CD8 positive, PD1 positive cells in the exhausted immune type of HCC. So this led to immunosuppression and failure of immune surveillance. Clinically speaking, they also did a meta-analysis of 3 major randomized control trials, that is Checkmate, IMBrave, and Keynote, more than 1,600 patients. Look at this, viral HCC, beautiful responses favoring immunotherapy. Non-viral etiologies, no difference in response between all these wonderfully acting drugs. And then they looked at 2 different validation cohort, 130 patients, 118 patients. Both the groups, patients who had NAFLD, their median response rate was significantly lower as compared to other etiologies in both the cohort, suggesting that NASH-induced HCC in itself may be a marker of poor response to immune checkpoint blockers. Now, NASH, the most important or the most common risk factor for NASH we all know is obesity, and it has been shown that obesity is associated with resistance to anti-VEGF. Why we are talking this? Because we are talking about a combination of atezolizumab and anti-VEGF, that is bevacizumab. Again, this was a study done in animals. They took obese mice and lean mice, in which there were HCCs, and treated them with bevacizumab. Just concentrate on the blue and the orange worm. So patients, the mice who were obese had large tumor volumes despite being treated with bevacizumab, whereas lean mice, there was a significant reduction in the tumor volumes. Not only that, these mice could be released from the effect of or resistance to bevacizumab by pre-treating them with anti-IL-6, again suggesting this is the inflammatory microenvironment induced by fat or induced by adipokines, which leads to resistance to bevacizumab. So to summarize, ladies and gentlemen, first-line systemic therapy nowadays is a combination of immune checkpoint blockers and anti-VEGF or tyrosine kinase inhibitors. Correct patient selection is the key to get optimal response rates and optimal resource utilization. High tumor mutational burden, high MSI, PD1 or PD-L1 expression, which conventionally have been used as biomarkers for other tumors to predict response to ICB, are found to be useless or not of much value in patients with HCC. Now, how do we proceed? So the most important clinical marker is NASH-related HCC, especially in obese patients who are going to have poor response to ICBs. And I'm sure in future, this will become an exclusion criteria, maybe, to avoid the use of immune checkpoint blockers. Still, if you want to use immune checkpoint blockers in your patients, then please subject the tumor tissue to next generation sequencing and pick up certain markers which will help you decide whether these patients will respond to TKIs or to ICBs, and these are the PI3K mTOR pathway for sorafenib and beta-catenin pathway for immune checkpoint blockers. And in future, possibly, we will also have serum-based markers. For example, right now we have the TGF-beta, high levels of which predict poor response to ICBs and sorafenib. Thank you for a patient hearing.
Thank you, Dr. Kaushal. Thank you so much. I think there must be some questions. So before that, I'll hand over to the organizers to call the panelists.
Yeah, I think we have several panelists with us, and I think as it is, we are running a bit behind schedule. So I would invite each one of the panelists to please make quick comments, starting with you, say, Dr. Harshad.
Harshad, need to unmute yourself.
Harshad.
Yeah. No, I enjoyed all the talk from all the speakers. One question is, Kaushal talked about mutational burden. especially in patients with HCC. The mutational burden in immune checkpoint inhibitors in studies have all been, and because the excellent response has been seen in patients with melanoma and small cell lung cancer. And that is why the ICIs work well in them. Yet I find a lot of research being done in patients with HCC where the mutational burden is low. So anyone, can you please comment on the dichotomy, please?
And I think that is the most important thing, because the response rates to ICBs in HCCs are not very high. So that is why we need to find these biomarkers so that we can decide which patients to give this or which patients to shift to other forms of therapy. Like Dr. Kudo said, that even after atezolizumab or bevacizumab fails, these patients can be put on lenvatinib, and he talked about FGF4 being a biomarker in such patients. So maybe Dr. Kudo can also throw some light on this.
Yes, as I told in my talk, the FGFR4 immunohistochemistry clearly show FGFR4 positive cancer respond to lenvatinib so well. Response rate is 80%, and the PFS is double as compared with FGFR4 negative staining.
Thank you.
Right. Okay. So the others, I think, Dr. Bhavna, would you like to make some comments or have some query for the speakers?
Yes, thank you so much. I really enjoyed the sessions. I just have 2 quick points, and I don't know whether Dr. Kudo or Dr. Finn can help. So there was this data at AACR that with atezo, the anti-drug antibodies are about 30%, and the response rate is significantly lower. And, you know, we being in a resource-limited setting for most of our patients, just getting that one drug of immunotherapy is important. So does that drive your decision-making that, you know, with pembrolizumab, the anti-drug antibodies are less than 1%? So does that influence your choice in choosing the checkpoint inhibitor? Dr. Kudo or Dr. Finn, if he's here, yeah.
You mean ADA and
yes, yes.
Anti-drug antibody. So in case of atezolizumab, the ADA is very high, but in pembrolizumab, ADA is not so high. But still, response rate is much higher in atezobev, 30% versus less than 20%.
With pembrobev?
No. Atezobev is 30%. Response rate is 30%. And the pembro less than 20%, 50 to.
No, what I was saying, whether you combine pembro with bev, because the.
Yeah, pembro plus lenvatinib in phase 1b study show a best response rate around 40%.
Yeah, and one thing was, you know, I was listening to Dr. Soin and everybody. I'm seeing quite a few patients who have recurred post-transplant, and the choice to give, which we didn't discuss, of giving immune checkpoint therapy. I think there is some data that if you test for PD-L1, if PD-L1 is positive, the graft rejection is very high, and you would want to treat them with anti-CTLA-4 or lenvatinib. So do you have any comments on that?
I do not have experience for transplant patient after recurrence.
Great. I think we should discuss it in detail, Dr. Duseja, at the next meeting, maybe.
I think if I remember right, Sanjeev did make this issue, Sanjeev Sahgal, on this, and he did show some data on the high risk of, you know, rejection using, you know, immunotherapy post-transplant. But yes, I think the, you know, this is open, yeah. Maybe the other panelists can comment on this, yeah.
Right. So any other queries? I think Dr. Divya?
Good evening, everyone. Well, Dr. Christopher, it was a wonderful lecture.
And I completely agree with you that radiation therapy has potential important role in the treatment of HCC across all stages, but still there is no recommendation on the role of Sbrt in the BCLC update, despite promising results with excellent local control rates. I want to have your inputs on that. And the second thing, in an institute where all the treatment modalities and expertise are available, how to help patients with indecision making about the treatment modalities, whether they should go for TACE, TARE, or Sbrt. As we all know that the patients referred for Sbrt, they usually have large tumors, portal vein thrombosis, or they have failed on previous locoregional therapies, or they are deemed unsuitable for the same. So how to establish role of Sbrt in such a setting?
Yeah, those are great questions, and I'll address the second one first, which is it is challenging to determine what's the best treatment option for each individual patient, because oftentimes there can be multiple options that a patient may be eligible for, both local, regional, and systemic therapies. We try to take into consideration all the factors that we have available, the location of the tumor, the size of the tumor, and recognizing that oftentimes, a patient may end up getting multiple treatments. For example, we may, for a large tumor, do TACE first for a couple times to see how it responds. And if we don't see a complete response, but they still have localized disease, then we would consider, radiotherapy as a next step, and then hold systemic therapy for if they have progression after radiotherapy. So oftentimes patients are getting multiple treatments during the course of their disease. In regards to the BCLC guidelines, I can't comment as to why radiotherapy was not incorporated. I think there are sufficient data that are available now. There are multiple prospective studies from multiple continents and some limited randomized data. It's not clear to me why that was not considered in the BCLC guidelines. I personally think it's a little bit of an oversight, but I guess it is what it is.
Quick comment on Professor Hallmeyer. Which patients would you take straight first up for Sbrt rather than as salvage therapy after they have failed multiple other attempts? So if you can identify a profile, maybe it may be best to move with that depending on availability of modalities.
Yeah, and I would say the population that we seem to see a lot for first-line therapy is, for some of the hypovascular tumors, and if they're too big for ablation, so like a 4-centimeter tumor, and especially if it's, hypovascular, then oftentimes, we'll think that embolization probably is going to be less likely to be effective, and we might consider radiotherapy as a first-line treatment, or a smaller tumor, but in a location that's not amenable to resection or ablation, like a caudate lesion or something high up in the dome of the liver that, might not be a good candidate for radiofrequency ablation or surgery. And oftentimes we'll consider radiotherapy as a definitive treatment.
Thank you. Dr. Kulkarni, I'm sure you have some comments or questions.
Yeah. Excellent talks. Only Professor Kudo, I have one question. There is actually all these drugs, sorafenib, lenvatinib, and cabozantinib. All of them are multi-kinase inhibitors. You did mention that all of them have immunomodulatory effects. And why is lenvatinib superior over cabozantinib and sorafenib? I know there is a difference on FGFR, but why on cabozantinib?
Because,
and second thing, why is one more question? What is there any racial difference in the tolerance of dosage of lenvatinib?
For first question, the lenvatinib is very good because there is a dual inhibition of a VEGF receptor and FGFR receptor, FGFR. So that way, lenvatinib show 40.8% response rate per mRECIST. So response rate is much higher than other targeted agent. Other agents are just a stable, induce a stable disease, but lenvatinib is different. The response rate is much higher. So that's the reason. And also inhibition of FGF receptor, especially FGR4, is a very important R4 inhibition. And the second question I cannot catch. What is the second?
Is there any racial difference in the tolerance of this drug, lenvatinib? It is weight-based dosing, I understand, but is there any racial difference?
Difference? The
racial difference in the
Caucasian
tolerance.
versus the Asian races, are they different in their response to lenvatinib?
Lenvatinib, as I said, response rate is very high because of the maybe due FGR suppression inhibitory effect is very high.
Right. Thank you, Professor Kudo. I think the last quick question, Dr. Rathi, if any comments or queries, would you like?
So my question was word for word asked by Dr. Divya, so I think I'm good.
Okay, great. Well, I think I...
Can I make a comment?
Yes, please, Professor Kapoor.
Yeah, because I have Dr. Christopher here, Dr. Bhavna here, and Dr. Finn, maybe he's there or not, but Dr. Kudo is also here. My question is largely related to the whole medical community now being in the part of treating, looking after 2 centers in the country. Should we go protocol based in each patient, or there is a need to include the patient in itself in the decision making with the ethical consideration of financial burden as well as the results which we are going to achieve with that modality? I think this is open for all of us to discuss.
Very good point, Dr. Kapoor. Financial toxicity is something, I mean, I'm working at the Proton Center currently in Chennai, but financial toxicity is the same for all our patients. And most of these drugs that we've discussed today, once you start, you continue forever. I mean, it's a nightmare. You discuss and the patient asks you how many cycles, you know, and the money they have to arrange, the land they have to sell, the loans they have to take. So I think it's for pembrolizumab, you know, 1 milligram per kilogram is enough. We have a 30 kilogram lady. You can just give 30 milligram. We're giving 200 milligram. So as a community, I think we have to individualize. So I individualize all the time for our patients. And I try and do local regional treatment, which is one-off, and not start systemic treatment at all till, you know, it's absolutely needed. I observe patients with lung mets who are completely asymptomatic sometimes and just keep following them up to assess the tempo of progression. If the tempo of progression is rapid, then I would start. So, you know, I think you're absolutely right. We have to really come up with something which is very low and middle income country specific.
Right. Well, I mean, this is an issue on which I think we can have a full half an hour discussion and views expressed. And I think Dr. Kapoor has raised a very important point. But I guess in the interests of time, and the organizers must be feeling we're really overrunning by about half an hour or so. So I think I'd like to thank all the speakers for wonderful talks, information-laden, cutting-edge information given, and very lucid and crisp messages transmitted in this session. As well as I'd like to thank all the panelists for their participation and insightful questions. And finally, the organizers for putting together such a brilliant show. This has been one of the best HCC meetings I've attended. And with these words, I think I'd like to end this session and hand over back to the organizers. Thank you.
Before Dr. Rathi, you just wrap it up, I think my special thanks again to all the speakers, chairpersons, Professor Saraswat, Professor Kapoor, and the panelists, I think, for wonderful presentations. On behalf of INASL, a big thank you, and a special thank you to Dr. Christopher for early morning joining, and Dr. Kudo for late evening. I think it's more than 10 p.m. for him. So I think we have both sides of the world. We are in between, So I think thank you very much, all of you, for joining. And Dr. Rathi, if you want to say some concluding thing, yeah.
Thank you. Thank you, sir. It was indeed a very engaging session where we started off with all the potential really exciting therapies, and then Dr. Kaushan Madan very nicely put everything into context that yes, it looks very good, but there are problems, and we need to individualize, and there's much more work to be done before this all comes to generalized clinical prescription. So yeah, that was a very exciting session. So without further ado, I would hand over the proceedings to Dr. Nipun, and he can take us to the last session.
Well, thank you, Dr. Sahaj, and it was really delighted to see the last session. And this is about the practical issues in the patient's management regarding HCC. And let me have the privilege to invite chairpersons for this session. Professor A.C. Anand, who's a professor and head Department of Hepatology and Gastroenterology, Kalinga Institute of Medical Sciences, Bhubaneswar, and he is an editor-in-chief of JCEH, which is the official journal of INASL. Professor Setu Babu, who's a senior consultant, gastroenterology and hepatology, Krishna Institute of Medical Sciences, Hyderabad. Over to you, Dr. Anand.
Thank you very much. Can you hear me well?
Yes. Yes, Anand.
Okay. So for last 2 days, you've been hearing the extensive review of knowledge, the current cutting-edge knowledge on hepatocellular carcinoma treatment. And that brings us now to this last session, which is possibly the most important session, because it is going to talk to us about how we manage hepatocellular carcinoma. And this session will have 2 parts. First part will have a talk by Professor Acharya, and the subject of the talk is treatment of hepatocellular carcinoma in South Asia, challenges and solutions. And the second part will have a case discussion. And we also have a very expert panel who has been dealing with hepatocellular carcinoma. That includes Professor K.M. Mohandas, who is a senior consultant and director, Department of Digestive Disease Oncology at Tata Memorial Center, Calcutta. Dr. Dharmesh Kapoor, who is a consultant hepatologist in the Department of Hepatology and Liver Transplantation at Yashoda Hospital, Secunderabad. Dr. S. Sudhindran, who is a professor, liver transplantation, surgical oncology, gastrointestinal surgery at Amrita Institute of Medical Sciences and Research Center, Kochi. And Dr. Sanjay Satpathy, who is a medical director of liver transplantation at North Shore University Hospital, Northwell Health, Manchester and New York, USA. And Dr. Sridhar, BC, who is an associate professor, Department of Radiodiagnosis at PGI Chandigarh. This audience, I think, will need no introduction to Dr. S.K. Acharya. Dr. Subrat Acharya is Pro-Chancellor of KIT University and Kalinga Institute of Medical Sciences. He's also the president of All India Institute of Medical Sciences, Bhubaneswar, and an executive director of gastroenterology and hepatology at Fortis Escorts Hospital, Okhla, New Delhi. He has possibly published the maximum experience about hepatocellular carcinoma treatment from South Asia. So I'll now request Professor Acharya to give this talk.
Thank you, General Anand. Good evening, everybody. At the outset, and thank you, Professor Setu Babu, my dear friend. I'm very happy to see whenever he comes here.
You are my mentor. You are my mentor.
No, I'm not your mentor. You are my guru. Nice to see you all. At the outset, I must convey my deep, heartfelt thanks to actually INASL and Professor Ajay Duseja to actually expose personally me and all of us to actually a barge of new information and the explosive knowledge on the advancement of field of liver cancer, starting from the epidemiology, its diagnosis, its staging, its biology, as well as pathogenesis, as well as various therapeutic options at various stages, and their results, their recurrence rates, their modifications, their improvements, their downstaging, the end-stage transplant, post-transplant recurrence, tumor immunity, the immunology, the angiogenesis, the angiogenetic intervention, combinations of therefore, and what not. Professor Duseja, I'm indeed grateful to you. I'm only thinking what I will do with this knowledge. What is my use?
It's an academic toxicity.
And what I will do when I see my patients, whom I see, and they come to me only, they think I'm a very senior clinician in this country and a great liver expert. And that's what General Anand and other people ask. So they tell me, ask me, Dr. Acharya, you are such a great liver expert. People say you are the master. So treat us. And I tell them I don't know actually how to treat. Because all these treatments has been described by actually those people who are very rich. And they are have all facilities. They have all drugs. They have insurance. They can give this therapy. They can count their survival rate. They can count their complication. They can take care of their complications. And they can provide them this duration of therapy, which you think is true for us, keeping our problems. And somebody at the last stage asked, and what I see, we are having a lot of meetings. Don't mind my statements. But this is what you have asked me, what are the challenges and what is the solution? That is my talk. And I find second important event, not only the huge knowledge, I find a lot of our young faculty and also many senior faculty are indeed very, very knowledgeable. I was very surprised to listen that that our faculty knows that microsatellite instability, the number of mutation, and in the tumor itself can influence the immunotherapy, which somebody pointed out every 15 days is 2.5 lakhs. And it works in a subgroup. And nobody told us the cost of this assessing microsatellite instabilities and mutations. Sir, these are our challenges. I find we have very knowledgeable people. We have all the knowledges. We have the patients. And the challenges are the translation of this knowledge to the benefit of this patient. I'm very sorry to say that is probably all my lecture which you wanted to listen, but I have made some slides and I will just present it. See whether you will be more angry on me or not. Hope my slide is visible.
Yes. Carry on, Acharya.
Okay. The first challenge is, I will point out, I have written down the challenges. And the first challenge is the burden. Actually, if you see, we have projected as the lowest incidence of liver cell cancer region in the whole world, based on the cancer registry report maintained by Indian Council of Medical Research. We have 25 population-based medical research, which over 10 years, despite my personally as informed, the center stays in cytology and oncology and pathology divisions. All your cancers which you diagnose, they don't go to cytology or pathology. And this is one of the reasons a group of fellows who strongly argued against hepatitis B virus vaccination in your country, and you are all big expert, INASL also doesn't know it, and they stalled it for 10 years, allowing infections of thousands and thousands of children because of this data. So this is what I think one of the major thing, and it is not a notifiable disease and nobody bothers about it. Yet it happens, and there are various models to calculate. This is the autopsy study, right, published from this country only, which clearly says it's one of the major cause of death, despite it is amongst all cancer. It's a major cause of death. This is about how can it be the lowest incidence? And if you see, there are studies which has modeled it. There is 5-fold discrepancy between what World Health Organization is saying and what our modeling for one disease only. There are many, many diseases. Now we have fatty liver disease, we have alcoholic liver disease, we have hepatitis B continuing, hepatitis C has not come down. And well, so obviously the discrepancy is here, and all tertiary center is increasing burden. So this is a fast challenge, huge challenge, which needs your basic planning. And this challenge is known to all of you. I don't know why Professor Duseja asked me at the end of 2 days all these knowledgeable meetings, and they're knowing everything, knowing the gaps, and without knowing the solution, of course, what to do. Because this is a gathering of all experts. They know all this. And we have never made an effort to transfer this knowledge for the benefit, and that's the challenge. Obviously, in the diagnosis, obviously is a big problem. And simple example I give. Now we see many cirrhotics. And one of these studies which I did long back when I was at All India Institute of Medical Sciences, I wanted to know the incidence of liver cancer among cirrhosis, because cirrhosis are at highest risk of developing liver cancer. So you have to include cirrhotics at baseline who do not have liver cancer. So over a period of time, consecutive patients of cirrhosis who have good liver function, I thought I can follow them up. If they take bad liver function, they will die. And when I included them, I had to do a baseline proper imaging using a triphasic CT scan to rule out liver cancer, at least detectable liver cancer. Lo and behold, 35% of them had underlying liver cancer, and I have to exclude them. And remaining I followed up to find out the incidence. And all of them had ultrasound in our country. And all of them had reported that ultrasound is okay. Because cirrhotic is heterogeneous, you need a dedicated person for ultrasonography, not the general ultrasonography which is available in the corporate hospital. For small tumors, they will miss. This is another problem in diagnosis screening. Now, MR which is much better than triphasic CT, and in cirrhotic as a protocol and follow-up, which can detect tumor up to size of 1.5 to 2 centimeters. Smaller than that, that also cannot detect. But they are curable tumors. And are we doing any protocol for the benefit, even in tertiary center, even amongst the experts? And have we generated any evidence for that, particularly for us in our country, where we face all this problem? These are what I see the gap. Now, some of the important practical gaps. Third is screening. We don't do any screening for all our high-risk patients. We know all the high-risk patients. We know what are the risks according to high-risk patient for development of liver cancer according to World Health Organization definition. They clearly has defined, and they clearly has defined who are at risk to be screened and with what screening. But screening, detecting small tumor needs an eye. It is not generally done. I gave you an example. I think very few tertiary care center has their dedicated ultrasound. This is another challenge. And we know with the screening, if you have screening, it is obligatory to have treatment. If you add that, then only it is cost effective. with some amount of money. Otherwise, these are all useless. We know all this. I thought in our country, these are small challenges, but these are definite challenges which, if it established, then we will improve, other than listening to the lectures. This is also very well known. Screening for HCC surveillance, some studies shows it is efficacious. But whether it will be effective in a population or not, depends on various aspects of the population, of the system, on the patients, on the expertise. We have never evaluated in our setup what is the status of all this to make them effective. That is another challenge what I see. And then we don't have teams for holistic therapy. Till now, none of the cancer board discusses HCC as a holistic treatment. We also need surgeons, interventional radiologists, pathobiologists, right, oncologists, transplant fellows, hepatologists, all together under one roof. And it's time to be practical. As far as management, we discussed all this very sophisticated management, but we can divide them, no? Depend in our country also. And our society can do that. That if you have very limited resource, what to do? Whatever intermediate resource, what to do? We have a very advanced resource like Professor Setu Babu has. He has all the resources under his belt, always, throughout his life, right? So what he will do, right? So we can at least think about it and give some benefit and see whether this works or this doesn't work. Well, we have, as I told, this is very important. I think in this last week, we have 3 meetings on liver cancers. And last meeting I have attended and I have heard so much that my brain is only liver cancer and I have forgotten about everything else. And when I come to practice, I am unable to do any of them. And all these are sponsored by a drug company which gives us money. And can we ask them that this money increases simply in awareness of the public's liver cancer occurs? It occurs in a high-risk group of people. Just tell them repeatedly. And it is a preventable disease. It is now can be easily diagnosed and cured. I don't think the physicians, the surgeons, the general physicians, the patients, their relatives know this. And well, then we have the advantage of meeting and we can collect this data. And I was very ashamed of myself also. When I'm a party to all this, I myself organized this meeting and discussed among ourselves, never called a public meeting to make them aware when I am having this meeting. And one book I recently read by Dr. Nandi, brilliant book. I think one of the best books Sir has ever written. And the editor, the editorial, the preface was written by Sir Richard Smith, who is the editor of BMJ, with whom you know he is a friend of Professor Nandi. He wrote, and I have highlighted 3 points, which I have expanded. I will request you to kindly read this. And this says, this is on liver cancer. I'm telling in reference to liver cancer. We have tended to blindly follow the richer countries instead of trying to provide healthcare to our population, which is accessible, affordable, and most importantly, appropriate. Friends, don't you think this is much more true for liver cancer than any other disease? And in the last session, the young lady at the last just mentioned that how she has to modify her treatment for our patients. Other people's research can be valuable, we learn. We are learning about liver cancer, but can never be as valuable as your own. We can at least start collecting our data. And I think that's just like Professor Ajay D'Souza recently published a portion of his data. And if he can be instrumental to create this data from INASL, somehow or other, I don't know how, addressing the problems that matter to your people with relevant methods, tools you have. We will know what tools we have, how we are diagnosing, what is our magnitude from our data. We know that very act of researching brings improvement. And as I know to my cost, that is Mr. Dr. Smith is writing, not me. You can never learn about research from reading or hearing great expert from the West about it. You need to do it. This is what in the preface, Dr. Richard Smith writes. And to start with, can we all join hands, divide the country nation into various blocks, just like politicians divide them, and give responsibility to each faculty in each area to hold a meeting on liver cancer in this particular area on rotation, and tell them that this cancer occurs because of these diseases, and this can be diagnosed if they screen them and can be cured and treated effectively. Thank you very much.
Thank you, Professor Acharya, for that excellent talk. And the solution you have given is also very important for all of us. Can we have some comments or questions from the panelists?
I have not given any fact. I have not given him any fact. I have just given such suggestion. He asked me what are the
challenges and solutions.
Challenges and solution.
You've given very good suggestions, sir.
Thank you very much, sir. I think just a small, I think only you could have done it, sir. Thank you so much for being there and for your support. I think these challenges, the way you have, shown and the solutions which you have given us, I think only you could have done it. So thank you so much for that. But then we can have comments and questions from the panelists who are there in this session.
And Dr. Setu Babu, would you like to start with one, sir?
Yeah, I think Professor Acharya is, as usual, brutally true to the concept. I think we have to collate a lot of experiences and then share the knowledge, which has started happening. I think this a day and a half deliberation has actually thrown that so much of therapeutic approaches, and I think Professor Bhavana used the word which is actually new to me, called the financial toxicity. I think, as you said rightly, we have to individualize the treatment rather than go into guidelines and choose from the guidelines which is suitable for the patient. As you said rightly, there could be a small subset who could only take oral medicine, either sorafenib or lenvatinib. So I think we stop there or go to higher end treatment depending on multiple issues. I think we talk about individualized treatment rather than guideline based management for everybody, or one point doesn't hold to everybody. Yet you're right, actually.
Is Dr. Mohan Das online?
Oh, he had some issue with his connection. I think there's some problem.
Should we go to the next talk so that, then we can have some time if you can.
Okay, Dr. Setu Babu, I've taken permission from Dr. Duseja to go somewhere else. So I'll leave you to manage the part.
It's nice of you to put me on your shoulder. Thank you very much.
Thank you very much, sir.
Right. Dr. Setu Babu, I will also take permission. I have to also attend to something.
Sure. I mean, sure. You made your point very clear. I think it's okay. Time.
To see the young man.
So nice to see you smiling, and so the same Acharya.
So I can always remember your saying, and in most of the meetings, and which is so true, that most of the liver diseases are preventable. And that's true even for liver cancer, which you very rightly, pointed out. So if you just vaccinate people for Hep B, control obesity, diabetes, and control the epidemic of NASH, and, Hep C is not treatable, I think so the liver cancer also becomes, preventable. So,
let INASL's motto be this year, and let it circulate through its member, through pamphlets, throughout the nation to 120-30 crore people. One issue.
Actually, Dr. Acharya has given a very, very hard-hitting message.
Absolutely.
That we should, INASL should possibly direct all its regional branches to hold public meetings and educate people about what is it that is causing liver cancer and how we can prevent it. And that probably will be the biggest service, not only to the nation, but also to the poor patients who cannot really afford to have such diseases.
I was coming to that. So I think that brings us to the public awareness, which you rightly put in as your last, this thing. I think that's very, very important as far as the preventive aspect is concerned. And the second thing I would like to say, the first thing which you said is, again, the cancer is not a reportable disease in this country, number one. And secondly, all the HCC data which you said used to come from cytology, oncology, and the registry which do not have data on HCC, because all the HCC in this country or globally would be seen by the hepatologist or the gastroenterologist or GI surgeons. So the data was not being taken from them. This was taken from.
I have gone to court for that, my dear.
I know, sir. I know, sir. Yeah. And how the hepatitis B vaccination,
Court case because of this data only.
Absolutely, sir. I think that's the biggest thing. So I think we all have to work together. Would need your guidance and further support and your suggestions on this. But yes, INASL is committed to that, and I think we will work hard to make sure that we do create public awareness on these issues which are preventable, and that would take care of liver disease in general and liver cancer in particular. Thank you so much, sir.
Thank you, sir. I'm grateful. I'm grateful, General Anand, for your.
Thank you very much, sir.
I'm grateful, Professor Setu Babu. I could see you.
Salute to you, sir.
Thank you.
If you could stay back, that would be very nice on this panel discussion. But then if you have to other commitments,
I have to go. That SCV.
I know, sir. I know, sir. Thank you so much for being here, sir.
Thank you.
Thank you, sir. Maybe Dr. Setu Babu, you can invite the moderator.
I think Dr. Manav is going to come in.
Yeah.
And I think he'll have a real-time challenge with a case. Professor Manav?
Thank you, sir. Thank you. Before I start, I must thank the organizers, Dr. Duseja, Sunil, everybody in the team for organizing such a good meeting. Now, we have been hearing and we've been learning about HCC in the last 2 days. We know all the data. We understand every single paper, whether it's a checkmate trial or pembrolizumab study or the NEJM paper. I have been asked to do a job where 6 experts are there. These are the guys who are managing HCC day in and day out. So what I'm going to do is I'm going to ask their experience, how they manage particular cases, and I'm going to focus only on 2 cases here. We have 40 minutes. I'll try to finish off in this time. You may not get too much literature in this presentation. Why? Because that already has been discussed. We want to know how the experts do it here. Now, I'm not going to talk about BCLC staging. We have already talked about that. All I wanted to highlight was, we all understand stage D disease. If it is within transplant criteria, you transplant. Otherwise, you only give best supportive care. The controversy management between the hepatologists, between the surgeons, between the radiotherapists arises in early HCC and advanced stage HCC. So I'm going to present 2 cases, one of early HCC and one of advanced, and try to take the opinion from the house. We also been told throughout these 2 days, there are only 3 possible curative options in HCC. We have radiofrequency or microwave ablation or IRE, whatever you do for smaller tumors. You have resection, which is potentially curative, and you have liver transplant. Nowadays, there is some data on Sbrt being a curative form of therapy, but we still need more literature to call it that. We'll discuss about that also. So the first case which I'm going to discuss is small or early HCC. Let me clarify here. We are referring to either a single tumor less than 2 centimeters or a stage A tumor, which is solitary and less than 5 centimeters. We have 6 experts here. I think Dr. Mohandas has not joined, if I'm not wrong.
There's some connectivity issue, that was it. I think you should go.
Other 5 are here.
Yes.
So let's start with case number 1. So this is a 55-year-old diabetic male with social drinking habits, diagnosed cirrhosis when he had hematemesis. Was found to have varices and banded, had 1 episode of HE. During that episode of bleeding, which was controlled
sorry
with medication.
to interrupt. Can we request all the panelists to switch on their audios and videos? It will be easier.
Absolutely. I thought they're already switched on. So can I request Dr. Dharmesh, Dr. Sanjay, Pramod?
Yeah.
Yes. My video, I'm Sudhi here. My video I can't turn on. I think host is disabled. I don't know why.
We can hear your voice. That's good for us.
Okay.
Your video is not coming, sir?
Yeah, okay. Yeah.
All right.
Okay.
So a bleeder underwent banding, had one episode of HE while he was admitted with bleeding, no jaundice, no side pain. Bilirubin 1.4, enzymes near normal, albumin is 3.1, INR is 1.5, ASP levels are 8.4, hepatitis B and C are negative. Underwent a MRI on routine follow-up, which showed a 2.2 centimeter HCC, classical arterial phase enhancement, and washout in the venous phase. So we have a 2.2 centimeter hepatocellular carcinoma, which you call early HCC by all criteria. PST score 0, child status B7, male score is 11. So let me start with Dr. Dharmesh. Dr. Dharmesh is there? Dr. Dharmesh?
Yes, he said he's there.
So I'm trying to ask for it. Okay, Dr. Sudhindaran, what would you do? Surgeon, resection, transplant, RFA, taste.
Mute.
Sir, please unmute yourself.
Please unmute yourself, sir.
Yeah, sorry. Okay. So this 2 centimeter tumor, history of encephalopathy is striking, that basically means that he has got clinically significant portal hypertension. So in such a patient, although, if had it been for anything else, the resection would have been okay, particularly by a minimally invasive technique. Liver transplant is certainly an option. I will discuss that with them. But as a first thing, I think I will go for an RFA because it's easily accessible, less than 3 centimeter, as good result as a resection. So I will definitely go for an RFA first. That'll give you a time to sort of look at the tumor biology, etc. as well. And then, later, if it recurs, if other tumors come, you can think about transplantation.
Perfect. The surgeon wants to do RFA. Professor Satpathy, opinion on this, sir?
Yes. So first of all, congratulations, excellent sessions so far. I would look, this is a patient who has portal hypertension, who has come with bleeding. So surgical resection is not something that I will favor. Certainly patient meets the Milan criteria, is already more than 2 centimeter. In USA would list this patient and would bridge this patient to transplant. And the option would be here between RFA and TACE to choose from. Now for RFA, I want to point out again to the listeners that the location, it should not be subcapsular, the location should not be subdiaphragmatic, and the location should not be near major vessels. You have to take this into account and also and then decide whether RFA is an option or not. So this tumor, I don't have the full picture, but it appears like close to the diaphragm, close to the dome, and if that is not the case, then RFA would be the first line. It's a small tumor, easy to ablate. Otherwise, my choice would be a TACE. And again, from this, many centers even also point out our centers now more going towards TARE actually, even in early stage tumors as well. But TACE would be the first approach in this patient, in my opinion.
But you would like to list the guy for transplant before you go ahead with any procedure, if I gather you right?
No, the patient, we'd like to list the patient, we'll evaluate this patient, and we bridge the patient to transplant. Yes, of course. This patient has significant portal hypertension, has come to bleed, and I would definitely would like to list the patient for transplant. Yes.
So that's very interesting.
Dr. Dharmesh has joined.
So Dr. Dharmesh, I was waiting for you to join in. So any comments on that? Dr. Sudhindaran wants to do a RFA. It's a 2.2 centimeter HCC right in the heart of the liver. It has significant liver parenchyma around it, and it's not close to a vessel.
So you already
11.
So portal hypertension is there. You mentioned that the performance status is good.
That's right. He's a bleeder. He's a bleeder. We have banded him.
Yeah. So RFA would be the preferred modality from the description you provide. And of course, tumor markers have to also factor in the treatment algorithm.
Fair enough.
Can I say, sorry?
Yeah, sure, please.
just make a comment is, after RFA, would you also, if only his AFP is high, would you like to consider some sort of an oral therapy with any of these drugs, sorafenib or lenvatinib?
Not really, sir. The 2.2 centimeter lesion with a normal alpha fetoprotein, you just do a RFA, you give a curative treatment. The systemic therapy is only for those tumors whom we are not giving a curative option.
That's to be
so
made.
No systemic therapy, at least from my side.
Yeah.
Let's change the scenario a bit. Let's say this was a 3.5 or 4 centimeter lesion. Dr. Pramod. Dr. Pramod is there? There is some connectivity issue. All right, can I go back to Dr. Sudhindran here? Can I go back to Dr. Sudhindran here? So if it's a 4 centimeter lesion, would your options change?
No, because of the portal hypertension, surgery is not in my list at all, because the risk of liver failure is very, very high with that degree of the bleeding and encephalopathy. So I'll go for ablation, but this time I may probably choose microwave ablation, because there is some evidence that microwave ablation is perhaps a little bit better for bigger tumors compared to RFA. But still, I think the position from the films that you gave made look pretty good for an ablation rather than a TACE. So perhaps go for a microwave ablation.
So anybody has experience on a combination of TACE and microwave or RFA in these patients? I wanted to ask maybe Dr. Caesar can.
We do that regularly. Yeah, carry on.
Yes, even at 4 lesion, if the lesion is around 4 centimeter, I think as Sir said, we would probably prefer a microwave ablation. It has a fairly good margins. Looking at the images, there is a very good margins, and we can have a 0.5 to 1 centimeter ablation zone. I know, but recent data suggests, and recently we have also started doing a combination therapy. So if you go by the recent guidelines, whatever the talks, I think more than 3 centimeter, they suggest to do a combination therapy. But probably what we can do is do a microwave, wait for 1 month, because when you have a ablation zone, when you do a microwave, if you're sure that you're completely encased the tumor, because 4 centimeter fairly, we can up to 5 centimeter, we can do a microwave ablation. And we can do a 1 month follow-up, or probably at 3 to 4 weeks do a CT. And if we see there is a peripheral hyperemia, there is equivocal appearance on a LRTR rather than a non-viable, then we can probably do an immediate TACE as a second option. Or maybe to be 100% sure, we can go in with the combination therapy at the beginning itself for the lesions more than 3 centimeter.
Fair enough.
Can I ask Dr. Sanjay one?
Yeah, please.
So Dr. Sanjay, let us suppose these patients develop a complete response to the HCC therapy like ablation we have done. So how long would you wait for transplant in your setting?
The way here it works is patients more than 2 centimeter lesions, and they are within Milan criteria. We list the patient, and the patient wait for 6 months to get their MELD exception point, which is the median MELD at transplant -3. So usually, like in New York region, they get about 27 points after waiting for 6 months, and they so that's the waiting time to allow the patient's biology of the tumor to assess during those times. If the patient fall out of the criteria during the time, they are delisted. So they stay on the list with that score, and they get transplanted ultimately.
So what you mean to say is, if the patient has a complete response, the patient will be taken off the list, right?
No.
No. So a patient has a MELD score of 11, he has a HCC, you do a RFA. RFA gives you complete response. Obviously, the patient
they still get transplanted. Right? They still get transplanted.
That's interesting. Yes. So that's a major difference in what we do and what you guys are doing there. Is there anyone in our house in India who would transplant a guy who's had a complete response with a MELD of 11?
No.
Among the panel?
No.
So
that's a major
the
difference.
MELD, they don't get they get MELD exception here if their MELD score is not counted in regards to the transplant itself, because these are patients with HCC. They're likely to have recurrence. Even if you do RFA, let's say by 5 years, the studies from Lencioni, the Tatesi, Choi, there's so many studies. 1 year, we have a great response. The survival is like almost 90% to 100%. By 3 years, they drop down to 46 to 70%. By 5 years, 31 to 50% around. So you're certainly giving this patient a risk of recurrence. So we transplant these patients and giving a mal-exception score.
Fair enough. Fair enough. So that's a major difference. So that's what we don't do, but that's done in USA. So we are okay. So just
but Manav, we will
set of
Manav, sorry, we will obviously follow these patients with CT scans CTMR every 3 months. Slightest risk of recurrence, we will go for transplantation. But I mean, as long as the complete response and follow-up doesn't show recurrence, obviously we can follow. Thank you.
All right.
And as
Great.
also
So
the
I
things
agree
which
with
are
you,
not captured by the MELD score, Manav. So, MELD score does not capture a number of things. So it's not just the tumor characteristics, but a host of other things. What is the portal flow like, any encephalopathy, recurrence of bleed, presence of ascites. So all these things will have to be factored in, because you've just mentioned the MELD score. But obviously what Satpathy is saying also makes a lot of sense. We know that there is recurrence associated with disease. So this patient has to be on the radar continuously.
And
also
also
we will keep the
mindful.
patient on radar for any decompensation or HCC recurrence here in India. But what I gather from Dr. Satpathy, possibly a transplant would be done there, and which is fair enough, I would say. Just the only set of data I thought I'll present. If you look at any lesion less than 5 centimeter, resection is better than RFA. But if you look at only less than 3 centimeter lesions, RFA gives similar 5 years, 1 year, and 3 year survival and recurrence-free survival as compared to resection. So if you have significant portal hypertension, nobody wants to do a resection in a small lesion. This we have already touched upon. So this is the message I wanted to give here in India. Liver transplant, we will not consider as a first-line option in early HCC, but only as a salvage strategy for tumor recurrence or liver failure after the definitive therapy. Obviously, things are different in US, but here that's what we would do. So does the House agree on that?
Yes,
Is this a correct
absolutely.
message to do?
Yeah, that's correct.
Absolutely. Okay, thank you. This is something which I thought I'll ask Dr. Sridhar to talk about. So this is a new concept which is coming in, radiation segmentectomy. So you do a complete segment of the liver is taken away by the high dose Sbrt radiation.
Yes.
Any experience with this in your center, and do you do it, and what are the results?
Sir, actually, radiation segmentectomy per se, we are not doing it. We are primarily treating the tumors. You know, the economic constraints are there, but I can tell you about the data from Salam and all, what they have published. So, and I think even if you go through the BCLC stage, recent BCLC, they have included this. So definitely it works in 2 ways. One is that tumor and the surrounding lobe is taken care of completely. And based on the data, they are good actually. Especially in those patients who are, as they said, tumor size is less than 8 centimeter, go for a complete segmentectomy. So there is a good disease-free survival or recurrence-free survival with the radiation segmentectomy.
So are you doing this as a primary mode of therapy or only in RFA failures in your center, the radiation for these tumors?
I think, sir, in our center, actually radiation, Y90, because it's, PJ is this thing, a government hospital. So we have our own limitations. So radiation segmentectomy, generally we don't do it. We are doing TARE Y90 for those patients who, with the large tumors with a portal vein thrombosis, as bridge or downstaging, or as a palliative treatment.
Okay. So open question for the House. Anybody who has experience with this? Dr. Satpathy, Dr. Sridhar, Dr. Surendran?
Yeah, this seems to be a new area of disease care. Would this be a pre-surgical, downstaging the tumor like any other procedure? Would that be possible?
Yes, sir. I think now radiation segmentectomy has been used as 2 things. One is pre-staging. The other one is the purpose it solves is it's going to kill the tumor. It also causes the contralateral hypertrophy. So those way it works in two phenomena. So definitely they are doing it for a pre-surgical downstaging, sir.
You must ask Professor Sudhindran will be happy or not.
Yes, sir. Yeah, no, we are okay with that. It's just that we do quite a lot of SBRT, but however, not as a primary modality, except in some situations, which was mentioned earlier, that is the lesions which are hypervascular and not amenable for ablation. For example, close to the diaphragm or very close to the veins, etc. Those, those are the only few ones where you go for a primary SBRT. And the way they're usually failures or the ones with portal vein thrombus.
Okay.
Yeah.
Why would one want to do resection? Because this treatment can offer oncologic cure also. So if you have planned the radiation in such a manner that you are able to deliver the dose that you intended to, and the patient has not developed any RILD, so why should such a patient be subjected to a follow-up surgery?
It will be only a downstaging and a transplantation, not a resection.
Yeah. So, but it is capable of offering oncologic cure by itself.
Yeah, evidence is a little bit weak at now.
So what we did in this case, we did not consider resection in view of bleeder status and a history of encephalopathy. Patient underwent RFA. 6 months later, repeat dynamic MR study showed no recurrence. Also, although this guy did have a recurrence 2 years later, but that's a story for another day. I'm not covering that this time. So he did have a recurrence 2 years later, but 6 months down the line, he was okay. Let's go on to case number 2, advanced stage C HCC. 55-year-old male, resident of Myanmar, hepatitis B plus HCC, is on entecavir for 5 years, and he's been referred for liver transplant. Look at the parameters. Bilirubin is normal. AST, ALT are significantly high, 253, 147. Gamma GT 471. Normal albumin, normal INR. ASP is a whopping more than 8,000 nanogram per ml. He's HPS-AG positive, and his HCV HIV is negative, and DNA is target not detected. The imaging shows this. So you have a portal vein tumor thrombus. You have a diffuse infiltrative HCC, and it is PET positive. You can actually see the PET positivity in the tumor thrombus. So again, question for the house. Let's start with Dr. Dharmesh this time. Is Dr. Pramod now audible? Can he take a question, Dr. Pramod? If he can, would you like to downstage this guy?
So difficult.
Pramod is not audible. Dr. Dharmesh, please. What is your take on this? Would you like to downstage a portal vein tumor thrombus?
Yeah, so obviously I just need the information of PET for the extrahepatic spread also, because that will determine whether I want to downstage this or I want to treat this patient upfront with systemic therapy. So if this patient...
extrahepatic spread, sir. So this patient has diffuse infiltrative HCC with a portal vein tumor thrombus, no extrahepatic spread.
Right. So then obviously the options would be in the form of a tear. It will all depend on the liver function. You've shown that to be good. The bilirubin is normal. We've all started to increasingly use ALBI now, rather than go with any other markers to predict suitability for a given treatment. So I think your parameters with good albumin and good bilirubin would put him in stage 1 LB. And so that is why the preferred modality for me would be a tear for this patient.
Dr. Siddhi? Tears,
for me,
it's a diffuse infiltrative HCC, almost replacing the whole of right lobe.
Yeah, a couple of points. One is because it's hepatitis B related, the prognosis could be slightly better than the others. But the point to note is the DNA level is high and the SGOTPT is also high.
So no, DNA is undetectable. DNA is undetectable.
Undetectable.
Okay, but SGOTPT is high. I don't know why. But that's a little bit worrisome, even for tear, I think. But anyway, in this case, what we would do is again Sbrt to the portal vein thrombus alone, just to the portal vein thrombus, and see how it goes. Because AFP is also high, which is again a bad biological marker. So overall, you can't give the whole Sbrt to the whole tumor and the portal vein thrombus because the guy will decompensate. I think same thing might apply for tear as well, because the load is going to be huge. So what I would do is give Sbrt to the tumor thrombus, 6 to 8 weeks later reassess. The tumor thrombus has gone. At that point, you could go a TACE or a tear and then see how he goes. That's it.
What would you do in US? Dr. Sridhar, you want to make a comment?
It would be rather good if you combine tear with the SBRT for the portal vein thrombosis and probably tear for the lesion, because tear we can again limit our dose based on the lesion and non-target embolization, so we can plan it and only focus on the tumor rather than avoiding the non-tumoral components and these things, and Sbrt for the portal vein thrombosis at the same time.
How soon can you combine in both together?
Sir, if you're just aiming at the portal vein thrombosis for a Sbrt, I think within 2 to 3 weeks or in a 3 weeks gap we can do probably. I know that tear, they say up to 2 weeks, it's at 2 months for the response. That's because there is a peripheral hyperemia. So actually to pick up on imaging, we have to wait for 2 months. But if you look at the effect, probably by 4 to 5 weeks, we would have a good effect on a tear. And so probably patient can be considered for Sbrt.
I guess the liver enzymes could be because of the portal vein thrombus.
Possible,
The tumor.
quite possible. Yeah, quite possible, sir. So that's what we thought. Dr. Satpathy, what would you do?
Well, this is a biologically aggressive HCC by definition with the portal vein thrombosis with high AFP and diffuse infiltrating tumor. In USA, I think the way we would approach here is in a multidisciplinary meeting, and we would discuss with and come out with a consensus plan. And in my if I would quote similar examples in my center, I think mostly we have preferred to start these patients with a systemic therapy, preferably with atezolizumab and the bevacizumab combination, and target the AFP if they're responding. Would definitely combine this with an Sbrt because of this portal vein thrombosis. And we had seen actually, we had a patient recently which we did a similar combination therapy almost a year later after successful treatment, completely resolved the portal vein thrombosis as well as the tumor. And we were able to now list this patient and we're putting an application for to the National Liver Review. These patients, it doesn't go in the standard exception. If you transplant these patients, they will not get the MEL score exception. So there has to be appealed if they respond through the National Liver Review Board. But this is a biological aggressive HCC and would not be a candidate for transplant otherwise.
So any reason you would prefer a immunotherapy or a immune checkpoint blockers over TARE? Because our house seems to be more in favor of TARE in this patient. Why would you have a reason?
Well,
why
I think
I
do not disagree with this. I would definitely this is a sequential approach. Whether you are doing tests with Sbrt followed by systemic therapy or systemic therapy to begin with, and then go to the test and TARE. So in here, we usually prefer the other way around in this particular aggressive tumor.
Fair enough. Okay, Dr. Dharmesh, if you do TARE and Sbrt for this guy, what would you consider successful downstaging? So where will you say this guy is good for transplant?
So if we are only confining ourselves to radiation-based therapy, then yes, someday, though we have never done, let me concede that. Anybody with the PVTT, we have not transplanted ever. And I think in the imaging that you showed, this is going up to right to the VP4. So I don't know, even the advocates for transplant would take this patient on. But of course, the response to therapy would be, like has been mentioned, by serial imaging and decline in the tumor markers. So that is what is going to define the response to therapy. With the radiation-based therapy, the LIRAD's TR is a little difficult to interpret. And at times we might have to wait even for a period as long as 6 months to know whether the therapy has been able to make the tumor non-viable.
Okay. Dr. Sudhindaran, would you think transplant in this guy? Dr. Dharmesh says he's never done a transplant for such guys.
Yeah, I think my experience has been the same. We never managed to transplant. But I mean, there's a tumor marker is there. So it's a very good marker to sort of follow up the patient. If it comes to less than 1,000, then I could seriously consider transplantation. But I have to confess, I've not done one yet this big in this large tumor.
So I think Dr. Pramod's center has some experience with that, but we can't connect to him. I'll talk about this patient, what we did with him. We've already discussed what would you like to do for downstaging in this guy. We've already discussed we can consider transplant, but not many people do it actually. The thing depends on the response. So if you have a fall in tumor marker, if your AFP actually comes down, if the tumor size comes down, if you can actually get the tumor thrombus to be non-enhancing on PET, only then you consider transplant. And in our experience and our own experience, only 1 or 2 guys out of 10 whom you treat would actually reach that stage. He was one of the lucky guys who did reach that stage, but most of the guys, either the enhancement will not go away or the tumor will not shrink in size or the AFP will not come down. So the conversion rate is very low. So what we did was immunotherapy. The reasons we preferred immunotherapy over TARE was what Dr. Sudhindaran was talking about. We were looking at the extent of the tumor, looking at the whole right lobe involvement. We were not too sure whether TARE will be very beneficial for this guy. Secondly, he might decompensate. So what we did was we did Sbrt for the portal vein tumor thrombus and we gave immunotherapy. We used nivolumab. The only reason we gave only nivolumab is because the cost of nivolumab is 1/3 of the combination of atezolizumab and bevacizumab here in India. So it was slightly cheaper. That's the reason we gave it. The portal vein tumor thrombus became non-enhancing. AFP dropped to 155. This is the follow-up CT. So PET CT, which shows you can appreciate the shrinkage in the size of the primary tumor also, and the tumor thrombus is now non-enhancing. And the PET positivity which you had seen in the previous PET, and the tumor thrombus had gone away. So we decided to transplant this guy. We've already answered that. Would you transplant? How we would transplant? When we would decide? Now we did a transplant after 3 months. So this guy got 5 sessions of immunotherapy. He got 1 Sbrt. Underwent transplant, but interestingly, the histopathology showed a viable tumor in both portal vein tumor thrombus as well as liver. So despite non-enhancing portal vein tumor thrombus on the CT scan, there was viable tumor. I'm just waiting for the recurrence to happen. Till now, he's been lucky. 6 months down the line, he does not have a recurrence. But I believe any portal vein tumor thrombus you transplant, you can't discount the possibility of a recurrence. The recurrence rates are very high. I would like to hear opinion from the house. Anybody who's there, who has seen these patients, how many of them recur post-transplant?
Manav, before that, I think it was very audacious on the part of the treating team to take somebody up for transplant within 3 months of IO.
Yes, sir. So this guy from Myanmar, he's sitting on our head, eating our head every day, telling us, how long do I have to stay here? And now that my PET CT is good, why are you not transplanting me? I agree with you, sir. I completely agree with you. 3 months is too short a time, but that's what we did, and I thought I should be true.
Yeah, what immunosuppression? The experience with IO followed by transplant is very limited and anecdotal. And of course, there are numerous reports and some case series of very bad outcomes with respect to rejection as well as graft necrosis in patients who've received IO and get transplanted, even when the washout period has been more than 6 months. Maybe Sanjay can talk about this because this experience comes from some centers in the US.
Yeah, with we review all our explant. I'm not sure what is the question here that you have. We can be
no. How many months after IO is it safe to proceed for transplant?
Yeah, so and usually we wait for a year, and that's not just that's just I think some center may differ, but that's our protocol. We don't immediately transplant these patients. These are biologically very aggressive tumor. We want to see stability before we consider. But certainly very rare. I mean, within out of 100 patients, we will say only a handful of patients who would consider for transplant in these patients.
Fair enough. So the message has to be loud and clear. This is not the way to go. I wanted to present this case to make a point that even in a portal vein tumor thrombus, where you see a complete response, you still have viable tumor. 3 months is a short time. Usually minimum 6 months is the waiting period which we want to do. Here we had to transplant for a different reason, which I've already told you. But that's something which is anecdotal. You only have case reports. Usually you should be waiting for at least 6 months. That's what I would say. Any comments, Dr. Sundaram?
No, I think I would definitely have waited a bit longer. A couple of questions. I mean, what immunosuppression did you use? Antivirals did you change? Are you considering any adjuvant therapy at all? Given that,
I'll take them one by one. Immunosuppression, we started small dose of tacrolimus with everolimus, right from word go, a very small dose of tacrolimus, which I tried to make this guy more on everolimus. Once we saw the tumor histopathology, we did add lenvatinib. I don't know how much evidence-based medicine that is. I really don't know, but we did add because we were scared once we saw the histopathology report. The third question was, sir?
Antiviral, did we change it? Entecavir, are you continuing entecavir?
No. Entecavir we continued, sir. He was DNA negative at the time of transplant, so we continued entecavir.
Yeah. No, I'll wait and see. I think, but it is definitely. I can understand how the patients will come on your head. They have the donor ready, everybody is ready, they want to do the thing, and I can understand that definitely.
And an intelligent guy, he comes to you and says that my portal vein tumor thrombus is perfectly fine. You told me that that's the end point. Now, why are you making me wait here and making me spend extra dollars? So that's the problem.
So for anyone from radiology or RT therapy who's there on the panel, if you see the repeat imaging, Manav, at least one of the walls of the portal vein continues to enhance. So do you think that is meaningful? If you go back to your slides of the follow-up scan.
So Dr. Sridhar, that's for you to comment.
I don't think, sir. It's just, I think I would have said it as a blunt thrombus because there is no enhancement.
Sure.
Can anyone comment on the FDZ positive, the PET positive still there at that time when you transplanted? Would that still showing some activity there?
Yeah, it's there. The liver activity is there, but the portal vein tumor thrombus is not showing activity. And most of the tumor, which was in the right lobe, if you remember the previous PET, so the extent of the lesion has significantly decreased. So that's what made us took the decision.
Do you have any way to find out that tumor is still there, persistent, which was only shown after surgery? Is there any way? Because we were.
So you can put a needle inside, sir. You can put a needle inside, and but how many would do that?
Yes. We understand the clinical situation. I'm only just questioning because yes.
Manav, despite you downstaged it, the size of this lesion that before your transplant, do you have any comment on the size? I mean, of course, it is very.
So the as per Embrace's criteria, there was 75% reduction in the size of the tumor. The overall size which was reported was around 5 centimeters, if I remember correctly. I don't often remember the CT picture or the report, but it was very small. It was within UCSF. That's what I clearly remember.
I see. So here within UCSF, outside Milan also we were not transplant. So until they are within Milan.
No, it was not within Milan. It was within UCSF. So that's what we follow for our downstaging criteria.
How was the AFP decline in this patient?
155 from 8,700 to 155. So it was a significant decline.
Manav, I think as I said before, the two good points were that the etiology of hepatitis B and the rapid fall in AFP, both are very good. So I sincerely hope he's lucky enough to get away with it for some time.
I am still waiting for a recurrence. Looking at the histopath report, the portal vein did have it. Although we did a thrombectomy, did not leave any thrombus behind the portal vein, which was anastomose. But I'm keeping my fingers crossed. Let's hope for the best.
Dr. Manav, can I just make a comment?
Yes, sir. Please.
Yeah, my thing was for SBRT, often the responses are very delayed. So it could take 3 months up to 6 months for the response to actually come to SBRT. So how long are you guys waiting in SBRT after that to look for the response?
So we do serial imaging. The first imaging is done a month after completing SBRT, and the second one after 3 months.
Right.
So that's about the two cases. I think we have done with our 40 minutes. Dr. Sethu Babu,
I have a basic question is cirrhotic HCC and non-cirrhotic HCC. Would the guidelines broadly differ because it's a dual disease? If there is a liver disease which is cirrhotic with different levels of decompensation, can we make a broad comment that we bifurcate the approach altogether?
In a non-cirrhotic HCC, Dr. Sudhindran would be very happy to operate.
Correct.
Yeah,
no matter what is the size of the tumor, no matter what he is taking out. Dr. Sudhindran, you would like to comment on that, sir?
Yeah, absolutely. I mean, if it's a non-cirrhotic liver, even this would be resectable. We could do portal vein embolization, we could do many things and make it resectable, particularly if it's hepatitis B. So we have no problems with that at all. Such a liver, the risk of post-operative failure is actually low because already the tumor has taken so much of the liver size. What we remove, in reality, the liver tissue that we remove actually quite low because the tumor is so big. So the FLR is actually not too bad compared to what he had before. So if he was non-cirrhotic, we could have easily gone for a resection despite the portal vein thrombus. We would give him a chance.
Could you tell me a better screening protocol on a regular basis? This patient underwent, maybe you would do once in 3 months because you really did a transplant and you are really anxious about recurrence. But what would be, suppose patient has been a good resection or the first case, like how often would you like to screen them? Is it 4 months, 6 months? Which is the final word?
3 monthly.
3 months, fine.
You know, in a year here, if we do TACE, we try to check after 1 month the response and then follow every 3 months after that. But if it is tear, they tend to do 2 to 3 months after, because it's difficult to interpret because of the edema and all this thing that happened in the month time. So we wait a little longer to see the response.
In your second case, there was a significant elevation of AFP. Would that be at least a simple marker for us to follow up for recurrence?
That's true, sir.
Yeah,
that's absolutely true. Many a
Yeah.
times AFP would start rising much before the liver lesions would appear after a transplant or even without a transplant.
The second case had that advantage, strategic advantage.
Mm-hmm.
I think nice, Manu. I think it's really wonderful. I think 2 cases, 2 different approaches. Thank you very much. I really enjoyed it.
I want to ask one thing, Dr. Manav. How many
Yes, sir.
centers across the panel are doing transplant for like PCLC-D but small lesion? So this question was never, consensus was not made. Like a patient who had ascites and severe hypoalbuminemia and fitting into BCLC-D because of child's class, but a small lesion.
So I
That's
think
the
all
basic,
of us should be transplanting these patients if
yeah.
the logistics work out, provided you have been able to optimize this patient.
Optimize the patient. That's very important.
This is not
The
a contraindication.
BCLC-D now clearly says they're not transplantable for non-HCC reasons. So maybe because of performance status. So otherwise, if they're transplantable, we would all transplant them.
That's right.
I think
Thank you,
centers
Manav.
make
Thank you.
some difference, and availability of the donor makes also some difference. Maybe it's individualized. Thank you very much. I think Ajay should
Thank
come
you,
in.
sir. Thank you.
Ajay should come in and make his final comments.
No, I think thank you so much. I think this was such a wonderful discussion and really brings out, the practical issues and the logistics, what we all face day in, day out and everyday clinical practice. And Dr. Manav, you've done a wonderful job. I think these 2 cases really tell us, the real life management. This is what we really wanted, at the end of these 2 days of meeting, to really go with a clear message that, the guidelines are guidelines to only guide you. But the clinical decisions which you make obviously would be dependent on, so many other factors. And I think, as rightly said, that financial toxicity was another new word which we learned today. So I think that's very, very, pertinent, at least in this part of the world, and especially with, resource constraints setting like ours, and where we out of, again, the whole group, we work, in a public sector hospitals. And I think there, this financial toxicity would be, more relevant anyway. So I think if anybody has more questions or comments on the cases or this thing, I can see Sunil, Dr. Nipun, or anybody, Dr. Madhumita, or anybody, or otherwise, I think we can, try to close this meeting.
Goodbye. Yeah. We all actually, on behalf of everybody, I must thank you. You created a platform that has single theme, and P.N. Rao particularly, who heads the entire society. I think it's a wonderful thing. It's really learned so many things. It's a demanding from every patient who comes to the liver clinic. So I think
Can you
Ian make some comment?
Anybody else?
Ian should make.
Yeah, Dr. Rao would be.
Shafali, can
Sir,
you
can
start
you
my
switch
video?
on your video?
My
Yes, sir.
video is disabled.
Okay, sir. Okay, sir.
It
Okay.
is disabled.
You are
Disabled
known
by
and-
the host.
No.
Okay, sir.
It's okay. It's okay.
We can
it's
still
okay.
hear you, sir. You can make your comment. We can still hear you.
I don't have any other comment except that, the way the entire thing has gone on, excellent. And we have learned many things which would have taken some months for us to listen to. And also some of these protocols, it helps us to see for practically, which we can see in our own places, respective places. It's a good thing. Good, wonderful. Ajay.
Yeah, thank you so much, sir. So I think it is now, it's our pleasant duty now to propose vote of thanks. Maybe I can say a few words first and then followed by Dr. Taneja. So I think on behalf of the Indian National Association for Study of Liver and from the Department of Hepatology, PGI Chandigarh, I think this is a big thank you to all of you. I think without whom I think this meeting would not have been possible, I would say, and I don't know whether it's really successful or not. But then I think the credit goes to the whole team of obviously INASL and our department. I think who has really been working hard, especially I think Dr. Virender Singh, Dr. Taneja has been very closely. We both of us were kind of working for last 3-4 months, and then followed by Dr. Madhumita, Dr. Nipun, Dr. Arka, and Dr. Sahaj. I think all of them have really worked hard. So first thanks is to obviously my department, my colleagues, and my I mean all the support which I got from them, as I said, especially Dr. Taneja. And then the thanks to big thanks to the faculty, both national and international. I think again, without whose participation, I think this meeting would not have been a success. Special thanks to international faculty, because I'm not saying the national faculty was anyway less, but then special thanks because they joined us in in very and this was a Thanksgiving weekend for them in US at least. And this was odd hours for them. I think Dr. Harsham El-Sarag from the Baylor College of Medicine joined 4 a.m. in the morning yesterday. I gave him the option to join and give him his recorded lecture to us, but then he said, no, I wanted to be live. So I think hats off to him and all the international faculty. I can see Dr. Sanjay Satpathy. I don't know what time is it at his place now, but I know it's all early morning. Sanjay Kakkar joined at 6 a.m. in the morning. And then, all people from, Dr. Finn, finally, it was 6 a.m. for him. So he said it will be difficult for him to, come for the discussion. So I think big thank to, and then only the eastern side was Professor Kudo from Japan. And for him, it was 10 p.m. in the night, for his talk. So I think big thank you to, as I said, to both the national and the international faculty. Then I think we had a good number and a very good response, overwhelming, I would say, from the delegates. We had 1,300 plus registrations for this single theme meeting for HCC, I think, which is a very, special kind of a topic, which would not interest even all the hepatologists or the gastroenterologists, what to talk of, physicians and the other this thing. So we had 1,300 registrations plus, and we had 700 plus logins, throughout the meeting, I think, which is a very, very, good number, I would say, very encouraging for us. And again, I think big thank you to all the delegates for their very active participation. They were putting in a lot of questions on the chat box, but again, I think because of the paucity of time, we are really sorry that we couldn't take all your questions, but then I think we will, all the faculty, I would say, probably would be very happy if you, get in touch with them or even send us your questions, and we would like to, pose your questions to them. So after that, I think my thanks go to, the sponsors. I think, obviously, I think any meeting, is whether it's virtual or physical, I think would need, finances and the logistics and other things. So I think platinum sponsors, Roche, then we had the gold sponsors, who were, the Sun and the Isai, and then we had silver sponsors, the Zydus, Natco, and the other sponsors also we had. I think a big thank you to all of them. Finally, I think to my family, I think obviously when you do all these kind of activities, the time ultimately, the hospital will not leave you, the other work will not leave you. You will have to take out time from your family. And my eldest son, who's into finance, I think he's going on through some exams, and so I know I mean, they are grown-up boys now. I mean, my eldest son is 27, so that's okay. But then still, they want the kind of attention which probably he wanted. I mean, obviously, I think I had to take out time from this meeting, my family, my wife, my other son. So I think big thank you to all. And Dr. Sunil, as he said, obviously, my thanks to the department and my colleagues, obviously goes without saying. Dr. Sunil, I think if you want to say something.
I just want to say this is the most uninterrupted kind of web which I saw. There wasn't any snag. It went on uninterrupted. That's something.
Okay, so I think sorry for that. I have to thank my logistic team and my conference manager for that. I mean, it's just going out of my mind. Maisha has done a very good job as always, I would say. They have been with us for almost, I think, 6 years, I would say, when we used to do the physical meetings, 6 years back, and they have been with us, and they have kind of become very reliable for us. So in the virtual platform also, I think they have done meetings for us. But this meeting also, I think they have really put in very hard work, starting from, all the logistics and the preparations which we have had. And finally, their audiovisual team, I think, is wonderful. Yes. And all the, the messages and the logistics and the sponsors and everything which I think they have been doing. And big thank you to, the audiovisual team. I think once Dr. Sunil has spoken, I would request them to be maybe switch on their videos. And I think we would really like to say a big thank you to them also. Yes, Dr. Sunil, please.
Yes, so let me start by saying that it has been a wonderful meeting, and whatever we've learned today and yesterday is out of the box, and I think we should utilize this and bring this to clinical practice. And as Dr. Acharya has said, that we are a resource constrained country, and we need to really utilize the resources and take care of HCC. The second thing which I want to say is I really want to thank you for giving me this opportunity, as well as all my colleagues who've been part of this meeting. And the grand success of meeting goes to the efforts which have been put by all of us together. And I hope that we will continue to do this for the next meeting. And I think we are going to soon announce the INASL national meeting, which is going to be held in August next year. And thank you all for being a part of this meeting. Thanks a lot.
So anybody else wants to say anything, or I think we can close it. And Dr. Rao, I think, is gone. And you're here. Yes, sir. Please.
We can only say superlatives, right?
Thank you very much. And I think we got delayed by maybe half an hour or so, but I think this is part and parcel of, the any academic meeting. So thank you all, and big thank you, and look forward to future meetings. And hopefully, I think they should be on a physical format. Thank you all. Thank you.
Thank you.
Bye-bye. Bye-bye.